Good morning, everyone. It's my great pleasure to welcome you all to the 5th Annual Cardio-Rheumatology Symposium. My name is Lihi Eder. I'm a rheumatologist and a co-director of the Cardio-Rheumatology program at Women's College Hospital and the University of Toronto. And together with me will moderate this symposium, Dr. Paula Harvey, who is also the co-director of the Cardio-Rheumatology program and a cardiologist. We have a great agenda today with both local and international speakers, and we're really excited to open this symposium. So I'll go over a few housekeeping rules and some necessary information that you would like to know, and then we'll go right ahead to the first session. So first, why cardio-rheumatology? We know all that cardiovascular diseases are increased in patients with rheumatic diseases. There is an increased mortality, and despite improvement in treatments that we have, there is still a mortality gap with rheumatic patients keep dying more of cardiovascular disease than in the general population. We also described some existing gaps in care, and there is a significant gap of underdiagnosis and undertreatment of cardiovascular diseases, including dyslipidemia and hypertension, that we and others have described in different rheumatic diseases. So we can do better in managing cardiovascular risk factors in this population. And this really triggered us to create the University of Toronto Cardio-Rheumatology program that we established in 2017. And this is an interdisciplinary program that aims to improve the management of cardiometabolic diseases in rheumatic patients. So we have a primary prevention clinic. We see patients with various rheumatic conditions, and we aim to better manage their cardiovascular risk factors in order to prevent future events from happening. We also do research. We try to understand what are the underlying mechanisms that drive these diseases and how we can use existing tools like imaging to better risk stratify patients. And finally, the last component of this program is education. And this is part of our educational efforts to bring together physicians and other allied health professionals from different disciplines and update all of you and us on new advances in this field of cardio-rheumatology. So this symposium, so actually this is our program. So we have physicians, both cardiologists and rheumatologists, as well as radiologists that work together on this program. This is the team at Women's College Hospital, and we have other teams in Mount Sinai led by Dr. Bindee Kuriya that you'll hear later today. We have Dr. Elsie Nguyen, who is a vascular radiologist from the University of Health Network in Toronto, and we all work together on these prevention clinics as well as do research together. If you're interested in more information, we have some resources as well as some information about publications, and you can find them in this website. And this symposium, as I mentioned, is part of our educational efforts, and this first one was held in 2018, and then another one 2019. You can see all of us look a bit younger here, and then COVID hit us and we had to go virtual, and we had virtual events ever since, and this is the 5th event, and I guess one of the great things that happened is that we can reach more international attendees that we were not able to reach before. So we have today, actually the number is now 140 attendees today from all on 5 continents. So you can see them even from Australia and Asia and South America. So this is really exciting, and thank you all for attending this event. So as I mentioned, we have really great speakers and very interesting topics to discuss today. We'll start the morning with a year in review by Dr. Bindee Kuriya and Tosin Osuntokun. We then will hear about pulmonary hypertension from Dr. Sindhu Johnson and Jakov Moric. We'll have a break. We'll have a panel discussion then, so we'll ask you to keep your questions to the panel discussion. So we'll hear these 4 talks, one after the other. And then we'll have a short break, and the next session will be about obesity with different approaches to obesity in rheumatic patients, followed by a panel discussion. And then the afternoon session will be focusing on different topics, again, with great speakers, discussing exercise in rheumatic patients, antimalaria-induced cardiomyopathy. And finally, we'll have 2 international speakers discussing their experience with cardio-rheumatology, again, followed by a panel discussion. So again, please keep your questions to the panel discussion at the end. You can post your questions in the chat box, and then we will address them. So please keep them flowing. We'll address hopefully all of these questions. If you're Twitter fans, please follow us on Twitter and also tweet about this event using the hashtag here, Cardio-Rheum. This is an accredited event, so you can claim your CME points after this symposium, and there are some instructions that you should have received, and you can get your certificate at the end. If you have any technical issues, we have an excellent technical team that can address anything that you face during this event. And finally, you'll get access to all of the recording at the end of the session that will be available for you to hear for 6 months after this event. And finally, I really would like to acknowledge the contribution of our sponsors, that without their support, this event could not have happened. I want to mention AbbVie, Fresenius Kabi, Janssen, and Pfizer for gold contribution, and Novartis, UCB, and Lihi for silver contribution. Thank you. And I'll turn it over now to Dr. Paula Harvey, who will open the first session, please.
Thank you, Lihi. So it's my pleasure to be moderating the first session today, and I'm going to do the introductions of the first 2 speakers right now, prior to their presentations, as Dr. Kuriya and Dr. Osuntokun are going to be presenting Cardio-Rheum a year in review, so giving us an update on the latest clinical research that's been published over the last 12 months. So again, as Dr. Eder has outlined for you, we're not going to be answering questions during the course of the talks, but we will be having a panel discussion with all of the speakers together at the end, and we'd really encourage you to be entering your questions into the chat so that we can focus on those with the panel discussion. So our 2 speakers this morning, firstly, we have Dr. Bindee Kuriya, and I will say that both of these speakers are from our Cardio-Rheum network here at University of Toronto, so we're very pleased to have them presenting. Dr. Kuriya is a clinician investigator and an assistant professor at the University of Toronto. Dr. Kuriya's research primarily focuses on outcomes of rheumatoid arthritis, with a particular very keen interest in using observational cohorts and administrative databases to study important comorbidities that include mental illness and cardiovascular disease in rheumatoid arthritis. She's an expert in pharmacoepidemiology and is interested in studying how disease-modifying anti-rheumatic drugs impact patient-reported outcomes, as well as the development of comorbidities in rheumatoid. Dr. Osuntokun is a cardiologist at Women's College Hospital and an assistant professor at the University of Toronto. Dr. Osuntokun obtained her medical degree from the Royal College of Surgeons in Ireland and went on to complete her internal medicine and cardiology training in Ireland. She then did subspecialty training in non-invasive cardiology and inherited cardiac conditions at Guy's and St Thomas hospitals in London in the UK. And then she relocated to Canada and specifically to Toronto here at Women's College Hospital, where she completed cardiology clinical fellowship training in really a number of conditions that particularly affect women, and that includes complex hypertension, autonomic disorders, and also cardiovascular diseases associated with rheumatological conditions. So we're very pleased to have both Dr. Kuriya and Dr. Osuntokun with us today, giving us an update in the field of cardio-rheumatology. And with that, I'm going to hand over to Dr. Kuriya.
All right, I'm hoping everybody can hear me. And thank you for that kind introduction, Dr. Harvey. And I'm really excited today to be part of this wonderful symposium. So I'm going to be presenting a few impactful abstracts that were published in this field. Here are my disclosures. And the objectives really are to evaluate some of these studies as they discuss the association between systemic autoimmune rheumatic diseases and cardiovascular disease. So the first big area I want to focus on is the epidemiology of cardiovascular disease as it pertains to our patients. And this was a very nice study that was published in the Lancet by Conrad et al., looking at the incidence of cardiovascular disease more broadly among autoimmune diseases. By way of background, I don't have to tell this audience that conditions like rheumatoid arthritis and psoriatic arthritis, systemic lupus are associated with an increased risk of cardiovascular disease, particularly focusing on atherosclerotic disease and ischemic events. And the question of whether this holds true and to what extent for a broader range of autoimmune diseases is not as well known. Nor is it well known how other non-ischemic complications in terms of cardiovascular outcomes are associated with autoimmune disease. And so the aim of this group was to assess the association between 19 autoimmune diseases and a broader range of CVD outcomes. This was a very large retrospective population-based cohort study using a well-known data set called the CPRD, and this is a large administrative database in the United Kingdom. For this study, patients with a new diagnosis of any of the following autoimmune diseases were selected, and this was based on ICD codes between the years of 2000 and 2017. You can see the range of autoimmune diseases listed there. In red highlights are the rheumatic diseases that we may encounter in our practice, but I do want to highlight that many of our family practice colleagues or other health professionals may see a lot of these other conditions. Patients were excluded if they were over the age of 80 or had any prior history of a cardiovascular event. The outcome of interest was the first cardiovascular outcome, so incident outcomes of the following 12 conditions. You can see that they ranged anywhere from purely vascular things like aortic aneurysms to valvular issues, to dysrhythmias, to venous thromboembolism. And they also looked at a composite outcome of all of these cardiovascular diseases combined. They matched these individuals to the general population subjects, matched on age, sex, socioeconomic status, region, and of course, these patients also had to be free of autoimmune disease and cardiovascular disease in order to be matched. They calculated incidence rates, and they did the appropriate statistical analyses, controlling for important variables that may influence cardiovascular outcomes, such as traditional cardiovascular risk factors, as you see listed there, ethnicity, and whether or not patients were taking any preventative therapies such as statins or antiplatelet agents. So the key results are, this was a very whopping study in terms of 400 and almost 50,000 patients with a new diagnosis of an autoimmune condition and over 2 million matched controls. The mean age of this study population was 46%, and 61% of the study population was female. Over the median of 6.5 years of follow-up, 15% of those who had an autoimmune condition compared to 11% without, had a first cardiovascular disease outcome, and this was statistically significant. Here you see on the left-hand side the incidence rates per 1,000 patient years, and on the right the hazard ratios. And what I want to draw your attention to is the top red box, looking at the full cohort. There was a significantly increased risk of developing a cardiovascular disease outcome with an autoimmune disease compared to those without. And although the risk was slightly attenuated when you controlled, which is the black estimate, controlling for traditional cardiovascular risk factors, this was still statistically significant. Females had a higher risk than men. And interestingly, the younger age group, so those less than the age of 45, had a substantially increased risk. Again, still significant even when controlling for traditional risk factors. And the risk seemed to actually decrease with advanced age. The other important finding was that the risk of cardiovascular disease increased progressively with the number of autoimmune diseases present. So there was this concept of a dose response. So whether you had 2 autoimmune diseases, you had a greater risk than having 1. If you had 3 or more, you had a greater risk than having 2 or less, for example. Which of the diseases was most closely linked with cardiovascular disease? In our arena, it was systemic sclerosis and systemic lupus erythematosus. Other things included Addison disease and type 1 diabetes. And the most common types of events, interestingly, were myocarditis, pericarditis, infective endocarditis, and peripheral arterial disease. So not the traditional ischemic complications that we might otherwise think of. This is just another forest plot looking at some of the results I just spoke about. So this concept of a dose response, having more autoimmune diseases increased your risk substantially, and then highlighting in terms of the rheumatic diseases that, again, we may see or share with our colleagues, lower risk with things that are more rare, such as ankylosing spondylitis, polymyalgia rheumatica, and quite an elevated risk with systemic lupus erythematosus and systemic sclerosis. So the conclusions of this study and these authors was that autoimmune disorders have quite a high risk of developing cardiovascular disease, and that among 19 of the most common studied autoimmune disorders, all were associated with an increased risk, suggesting that there's a common pathway of dysregulated inflammation that underlies these autoimmune diseases that deserves attention. So how does this affect our clinical practice, and what can we take away from a study like this? Is one thing I thought of when I read this is that autoimmune diseases often cluster. So how often are we actually inquiring about diseases in our patients? Often we do it at the first initial visit, but potentially we should be considering asking about updated health history, such as autoimmune thyroiditis, which patients might not think of as a serious condition, but that may have an additive risk in our patients. I think this also highlights that we need to screen early, irrespective of age, given that the younger age groups in this population-based cohort were at increased risk. And the other thing is some of the outcomes, such as myopericarditis, may be difficult to ascertain using standard clinical or bedside assessments. And so the use of imaging modalities may be a better tool to screen. And I think we'll hear a little bit more about that later on today. So now that we know that patients with autoimmune disease and inflammatory diseases are at increased risk, can the treatment with immunomodulators to lower inflammation reduce this risk? And there are many studies in this area, but I wanted to highlight Dr. Solomon and Joan Bathon's TARGET study, which really evaluated whether immunomodulators can lower this risk. And this is really predicated on the background that other studies, big randomized controlled trials of anti-cytokine therapies, such as the CANTOS trial, which looked at inhibiting interleukin-1 beta, and many of you know the colchicine study that reduced cardiovascular events, were highly positive studies. And even within our diseases, so not looking at just the general population, we know from meta-analyses of conditions like rheumatoid arthritis that there's quite a substantial risk reduction when you use TNF inhibitors, for example, or even conventional synthetic DMARDs like methotrexate. So the question is, are biologics more potent? Is the targeted therapy better? And will this preferentially lower cardiovascular disease risk more than traditional disease-modifying drugs? So the aim of this study was to assess 2 different treatment strategies, patients on TNF inhibitor compared to traditional, what we call triple therapy. And what was really nice about this study is that their outcome wasn't traditional RA outcomes. It was looking at FDG PET-CT inflammation, which is a surrogate of arterial inflammation. So this was a 24-week randomized study done across 14 sites in the United States, completed just a couple of years ago. Patients had to have active rheumatoid arthritis despite optimal use of methotrexate, which is sort of our gold standard in RA management. And they had to have an elevated DAS score, which is an indicator of disease activity. For this study, they included women over the age of 50 or men over the age of 45. And of course, they had to be free of cardiovascular disease at baseline. Patients underwent an FDG PET-CT at baseline and then at follow-up at week 24. And of course, they had physical examination and some lab work done over the study time points. Patients were receiving add-on TNF inhibitor such as adalimumab or etanercept, or they were randomized to receiving methotrexate, sulfasalazine, and hydroxychloroquine, so-called triple therapy. The main outcome of this study, as I mentioned, was change in uptake in the carotids in the aorta. And this is a validated index of cardiovascular risk that has been replicated in other rheumatic diseases as well as the general population. And they also looked at secondary outcomes, so how much disease activity was reduced. And they also wanted to determine whether any risk markers such as lipids, troponin, CRP levels changed also with these treatments. 115 patients were included in the study. Again, typical median age of 58, majority female. Patients didn't have an awfully long duration of rheumatoid arthritis, so median duration was 1.5 years. And as expected, you had to have moderate disease activity to be entered in this trial. What was quite interesting is both groups actually experienced significant reductions in vascular inflammation, up to about 9%. But this didn't differ by treatment strategy. And if we looked at some of those biomarkers, the TNF inhibitor treated group actually had a lower CRP at follow-up, but the triple therapy group actually had a lower triglyceride. Otherwise, there was no significant differences in the troponin or other lipid parameters between the treatment arms. So the conclusions from this study were that patients have an increased risk of arterial inflammation, that the addition of either a biologic, such as a TNF inhibitor or triple therapy, both resulted in clinically important improvements in vascular inflammation, but that a biologic did not reduce arterial inflammation more. So what can we take away from this study? I think one is that our patients have subclinical vascular inflammation using these very sensitive modalities. It's quite prevalent. And this validates, I think, our need to aim for low disease activity or remission, irrespective of the mechanism of action. So we know that disease-modifying drugs, when used well, can lower cardiovascular risk, as this study illustrates. However, we know that certain therapies have been linked with potentially increasing the risk of cardiovascular outcomes. And so I think it's really important to still investigate whether there are differences by mechanism of action, such as interleukin-6 inhibition or the new JAK inhibitors, and these studies are underway. Next, I want to move to highlighting some of the work from our own group and really focusing on improving cardiovascular preventative care in our patients with arthritis. And so again, you know that there's an increased risk of atherosclerotic cardiovascular disease among our patients. And as Dr. Eder pointed out in the introduction, screening and management of important risk factors such as dyslipidemia is actually not very well done. And so the aim of this study was to apply Canadian dyslipidemia guidelines to our patients to see how many patients would qualify for a statin and are not getting them. So many of you may know that in 2021, the Canadian Cardiovascular Society updated their dyslipidemia guidelines, and the family practice colleagues in the audience probably know this very well. What I want to highlight is that there were some changes. So typically we think about screening for lipids over the age of 40, but these guidelines emphasize that regardless of age, if you have an inflammatory disease, such as the ones that we treat, you should be screened. And another thing that is sometimes is overlooked is that there's no magic lipid number that will be a reason to treat. It's really based on risk factors and other characteristics, unless, of course, you have a statin-indicated condition, which I've listed there, such as diabetes or chronic kidney disease. So, one of the big problems that I think we face in rheumatology is you often don't know what you don't measure. And these guidelines actually incorporate a lot of other parameters that are very, very useful. And as Dr. Eder mentioned, one of the main pillars of of this program and what we want to highlight during the symposium is that we really are hoping to improve primary prevention of our patients. And so this study really looked at that. We took patients that were entering our cardio-rheumatology program over the age of 40 with inflammatory arthritis. They had no prior history of cardiovascular disease at entry, and we included for this analysis patients not taking a statin. We stratified patients by Framingham risk score and actually summarized, according to these guidelines, how many would meet statin indication. And then we looked at some of the predictors of who would be meeting statin indication. We had 302 patients. 59% of these patients had rheumatoid arthritis. Typical of most cohorts, they were 58 years of age on average, and most were female. Most of our patients, almost 70%, were categorized as low Framingham risk. And that, again, we can have a discussion about some of the limitations of the ongoing risk stratification scores. But what was surprising is that 50% of our patients walking through our clinic were eligible for a statin, but were not on one. And what were the reasons that they were not potentially receiving them it's a lot of the things that we don't typically measure. The frequent qualifiers, according to these guidelines, were having a high apolipoprotein B level, having a very high LDL cholesterol, or having a coronary artery calcification score of more than 0, which indicates hardened plaque in the arteries. Male sex, hypertension, an elevated ApoB level, and having a calcium score more than 0 were most strongly associated with needing a statin. And interestingly, none of our disease arthritis characteristics were associated with needing a statin. So CRP levels, disease activity, swollen and tender joint counts did not play in our analyses. This is just a bar graph showing that among patients with low Framingham risk, you can see some of the qualifiers. So there's different cutoffs for different parameters, but ApoB was a very important predictor, and 30% have elevated ApoB levels. And when you looked at patients who had higher Framingham risk estimates and stratified by men and women, again, a quarter of patients had elevated coronary artery calcium scores, indicative of atherosclerotic disease and didn't know it. So there's a huge treatment gap. And, I really feel that this is the tip of the iceberg. Remember, patients who are typically enrolled in our cohort are those who are really interested in research, have well-controlled disease. And if they are the ones that are not being prescribed statins, we do wonder what's happening in the rest of the community in patients with active disease. And so we really need to understand why this is happening and what are the barriers. So I think this highlights that we need to do a better job of adhering to guideline recommended care, that there are better stratification tools available, and we should think about using things like lipoprotein levels and coronary CT, but we can't do it alone. And so we need to build networks like we've done here at the University of Toronto between all of the specialties that care for our patients. So the last thing I want to touch upon before I hand it over to Tosin is, if we think statins are really important for preventative care, what is the role of statins in actually improving arthritis outcomes? So looking at the reverse association. So I want to focus on osteoarthritis, which is highly prevalent, and in Canada, interestingly, knee osteoarthritis, even in younger people over the age of 30, is estimated to be up to 15%. But unfortunately, for many of us who treat osteoarthritis, that there's very little we can do to slow down the progression. Interestingly, statins are hypothesized to slow down cartilage degradation. And it's thought that they have some anti-inflammatory properties by lowering interleukin-1 beta, by lowering all the enzymes that actually chew up cartilage, and by increasing proteoglycan production that might actually stimulate cartilage production. But the studies are quite conflicting. Some have shown that they're protective for osteoarthritis, and some have actually shown that it can actually accelerate osteoarthritis. And the other limitation of most of the studies is that they've used plain radiographs and often in later stages of osteoarthritis. So the aim of these authors was to assess the effect of statin use on cartilage progression using more sensitive modalities such as MRI. This was another nice Canadian study done in Vancouver. Patients between the ages of 40 and 79 years with knee pain were followed over a period of 7 years. And of course, they were excluded if they have any other conditions that might affect knee pain. Their main exposure of interest here was statin use, yes or no, at baseline. They looked at cartilage damage and progression of cartilage damage at baseline and year 7 using MRI. And they also looked at some other MRI parameters, such as the development of osteophytes, bone marrow edema, and effusion, which are validated, again, indicators of osteoarthritis. And they did the appropriate analyses, adjusting for things that may also influence cartilage damage, such as being overweight and having metabolic risk factors. So this study included 255 individuals. 122 completed the 7-year follow-up. Mean age was a little bit younger, 55, more equitable distribution between female and males in this study, and mean BMI was 26.1. At baseline, about 8% were statin users, and at follow-up, interestingly, quite a number, 61% had progression of cartilage damage by MRI. So this was a progressive disease. And the bottom line, what I'm showing here in this table, is that unfortunately statin use was not significantly associated with any of the MRI progression parameters of cartilage damage. And this was true when they looked at different models adjusting for things like age and sex, and then the cardiovascular risk factors. So no significant association, no protective effect of statins. So what does this tell us in our practice? I don't think that this really changes what we'll do for the management of OA, but it's nice to know that it doesn't improve or worsen, because there are some studies that suggest that statins may actually impact or worsen arthritis. But I think about the osteoarthritis patients you see in your clinic, right? On balance, treating their cardiometabolic risk factors is really, really important, and I think is going to be something that we need to continue to optimize. The other thing that this study raised is, maybe statins will affect osteoarthritis, but not in the outcomes that they look for. So there are some hypotheses that the anti-inflammatory effects of statins may actually reduce pain progression, and is that maybe a more meaningful outcome to study in our patients. And with that, I'm going to pass it over to Tosin, and I thank you for your attention.
Thank you, Dr. Kuriya. That was an excellent talk. I am going to just talk about some interesting publications over the last year that relate to the field of cardio-rheumatology. This paper here talks about the analysis of cardiovascular complications during delivery admissions among patients with SLE in the United States from 2004 to 2019. So as a cardiologist who cares for women with heart disease, this to me is a very important study. The background, as we know, and as Dr. Kuriya alluded to in her first abstract, there is increased cardiovascular morbidity and mortality associated with SLE. People with SLE have a higher prevalence of traditional risk factors, obesity, hypertension, diabetes, but the risk factors alone do not explain or totally explain the increased morbidity and mortality. In relation to this paper and women who are of childbearing age, polycystic ovarian syndrome is also associated with SLE and associated with increased cardiovascular risk. As discussed, inflammation is thought to underpin this increased risk. We know that people with SLE have adverse maternal and fetal outcomes, but the data in relation to this and acute cardiovascular complications at the time of delivery are less well established. I know we're in Canada, in the United States, and in other countries, there are high maternal mortality rates, particularly due to peripartum cardiovascular complications. And in relation to this, the authors deemed it imperative to try and identify novel risk factors to implement preventive strategies aimed at reducing mortality rates. So the author's aim was to study the association of SLE with trends, outcomes, and risk factors of cardiovascular complications during delivery hospitalizations using the US nationwide National Inpatient Sample Database. So this was a population-based cross-sectional study. They looked at a period from 2004 to 2019. They used ICD-9 and 10 codes to identify delivery hospitalizations among those giving birth who had a diagnosis of SLE. This came out to more than 63 million hospitalizations. And you can see here, there were 77,560 hospitalizations in those who had SLE. The primary study endpoints were preeclampsia, peripartum cardiomyopathy, and heart failure. Secondary endpoints included stroke, pulmonary edema, cardiac arrhythmias, AKI, VTE, as well as length of hospital stay and cost of the delivery hospitalization. The characteristics of the hospitalizations compared between those with SLE and those without SLE showed that those with SLE had a higher age. They did have a higher number of traditional risk factors, particularly those associated with obesity, such as PCOS, gestational diabetes, and dyslipidemia. Over the 15-year period, there was an increase in prevalence of SLE, as well as an increase in overall acute peripartum cardiovascular complication rates. Again, over the 15 years, there was an increase in obesity, PCOS, and gestational diabetes. Some of the increase was felt to be related to a change in coding, but this did not totally account for this because these conditions tend to be under-documented. Looking at the actual complication rates, there were higher rates, significantly higher rates of preeclampsia in those delivering with SLE. There were higher rates of peripartum cardiomyopathy. Heart failure was higher, particularly associated with advanced maternal age. All other cardiovascular complications were more common. There was a higher length of hospital stay and higher costs associated with delivery. SLE itself was an independent risk factor for cardiovascular complications, both crude analysis and adjusted analysis. So I think this is a very important study. There are higher rates of cardiovascular complications among individuals giving birth who had SLE. There's an increase in the prevalence of SLE over the 15-year period, increase in cardiovascular complications associated with SLE, and increase in obesity-associated comorbidities. The future implications of this study is that there should be a consideration for a multidisciplinary approach in these patients with a family practice specialist, obstetrician, rheumatologist, and cardiologist closely working together to improve both the acute and the long-term pregnancy-related care. I'm going to switch gears a little bit to something clinical. This is a European Association of Cardiovascular Imaging document talking about cardiovascular MRI in autoimmune rheumatic diseases. The authors stated that this really was the first kind of document specifically related to autoimmune diseases. And really, they had aims to place cardiac MRI in the context of evaluation compared to other non-invasive imaging modalities, to propose a decision algorithm for evaluation of suspected cardiovascular disease, to propose a standardized CMR study protocol, and then to present the clinical implications of potential findings in a CMR examination. We are all aware that echocardiography is the most readily available imaging modality to assess cardiovascular disease in our patients. Echo is critical for the assessment of heart failure, valvular heart disease, pulmonary hypertension. Echo using stress modalities can give us information about myocardial ischemia. It can give us information about the pericardium and pericardial effusion and complications related to pericarditis, particularly constriction. SPECT here is readily available, not as much here as echo, although it is the case in other areas. I know we have an international audience, but this is useful for evaluating myocardial ischemia mainly. Dr. Kuriya mentioned a study that used FDG PET looking for inflammation. Yes, we can use it for ischemia, particularly in Canada. PET is not readily available. To get a PET, you need to be approved by at least 2 independent specialists prior to getting the study done. So from a clinical perspective at the moment in Canada, that is limited. PET is very good for vascular inflammation, as Dr. Kuriya's study alluded to. We have cardiac CT here. Again, as discussed, that is important for coronary anatomy and calcium scoring. We use cardiac CT in the evaluation of pericarditis, particularly looking for effects of recurrent pericarditis, such as calcification and thickening of the pericardium. But here we have the cardiac MRI, and obviously these the authors of this study are cardiologists, cardiovascular imaging specialists, and rheumatologists. And we know clinically as well that cardiac MRI is extremely useful in assessment of ischemia, myocarditis, heart failure, and pericarditis. In relation to vascular involvement in autoimmune diseases, MRI can help looking at wall thickening, wall edema, and effects of inflammation. They have a very nice algorithm here that they propose to be used in clinical practice. And this type of thing, it was validating to see, because this is the kind of approach that we take with complex patients that are sent to us. We work very closely with our imaging and cardiac MRI specialists here. So some of their proposed indications for doing an MRI here at the time of initial diagnosis, particularly for scleroderma, but also for SLE, if there's any consideration of cardiac involvement, then they actually suggest that you should think about doing an MRI initially. As is our practice, if we have patients with autoimmune rheumatic diseases who have cardiac symptoms, we would examine them and evaluate them clinically. We would do blood tests, ECG, echo, and maybe Holter monitoring, depending on the symptoms they have. And if there are abnormal findings, we would institute treatment, appropriate treatment, in conjunction with the other specialists looking after the patient. And we may consider an MRI to evaluate response to treatment or if there's ongoing symptoms. Here in this limb of the algorithm, we use this very frequently, again with our specialists. Someone has cardiac symptoms, we do the evaluation, they have no abnormal findings, but they continue to have symptoms, and there appears to be a mismatch between their symptoms and the findings based on clinical evaluation. In those cases, cardiac MRI can be extremely important. Clinically, we have seen this particularly, as Dr. Kuriya mentioned earlier, in patients who have pericarditis or myocarditis, where some of these initial assessment modalities are normal, depending on the stage of the disease. Also important here is that cardiac MRI does not exist on its own. We need our clinical follow-up on an annual basis for these underlying cardiovascular conditions. So in relation to this study or this paper, they propose some very interesting questions. So number one, what is the prognostic significance of CMR findings in patients with autoimmune rheumatic diseases? What is the role of CMR as a guide for immunomodulatory and cardioprotective treatment initiation? In our clinical practice, we often have this assessment, particularly for complex patients, where we are working together with rheumatologists, nephrologists, imaging specialists, and ourselves to see what the best approach and treatment choice would be. We need further research to elucidate the prevalence and prognostic significance of cardiovascular abnormalities in patients where the extracardiac disease activity is not controlled. What is the relationship between CMR indices and biomarkers, as well as autoimmune specific autoantibodies? More research in this area would be extremly helpful. Can we use CMR to identify and quantify myocardial fibrosis and thus patient selection for potential targeted therapies? This would be important, for example, in patients who have scleroderma. And here is for the future, can we use modeling techniques in cardiac MRI to identify patients at risk for malignant arrhythmias? In relation to cardiac MRI, this was a sub-study, part of the Rhapsody trial, which is a study of rilonacept in recurrent pericarditis. So this feeds on nicely from our discussion about cardiac MRI as well as conditioned pericarditis. So now in this particular study, it was in people who had recurrent pericarditis despite standard therapy. This was not done in patients who had rheumatic disease per se, but in people who, majority of these people had idiopathic recurrent pericarditis. The Rhapsody trial is international, multi-center, double-blind. Rilonacept is an IL-1 alpha and IL-1 beta cytokine trap, and it effectively treated recurrent pericarditis and reduced the risk of recurrence. We are aware that CMR can use something called late gadolinium enhancement to assess the pericardium, looking for inflammation and edema, and this may delineate the disease course in recurrent pericarditis. So this was a protocol predefined sub-study of the Rhapsody trial. The primary aim was to assess whether pericardial late gadolinium enhancement was associated with time to pericarditis recurrence. These people had multiple episodes, so more than one, and they had an acute recurrence despite standard treatment. And the standard treatment consisted of non-steroidal anti-inflammatories, colchicine, and even steroids. And these people were withdrawn from the standard medication and initiated on rilonacept. The people in the Rhapsody trial, there was an optional component to have a baseline CMR within 7 days prior to the rilonacept. And the pericardial late gadolinium enhancement was graded based on the amount of late gadolinium enhancement. So if it was more or less than 50% circumferential enhancement, and also at different levels of the left ventricle, so from the base to the mid cavity to the apex. Patients were randomized to further rilonacept or placebo, and the time to a recurrent pericarditis event, which was characterized by typical pain, increase in CRP, and supportive objective evidence. So 25 of the 86 randomized patients had CMR. 14 were in the placebo arm, 11 in the rilonacept arm. Moderate to severe LGE was compared with trace to mild LGE. Those with severe, those with trace to mild had, or those with, moderate to severe had a longer duration of recurrent pericarditis. They had a higher mean number of episodes, a higher mean CRP at baseline. In the 25 patients, recurrent pericarditis occurred in 10 out of 14 of placebo, and none of the rilonacept randomized patients had a recurrence. And in the placebo patients, median time to recurrence was shorter numerically at 4.2 weeks, with moderate to severe LGE at baseline versus 10.7 weeks in those with trace or mild LGE. Major limitation of this study was a small sample size and few events, but really the strength was the CMR interpretation. It was done by two CMR experts who were blinded and assessed the images independently with good inter and intra observer reducibility. We saw that the time to pericarditis recurrence was numerically shorter if there was moderate or severe LGE. And maybe this is a potential prognostic tool in the use of pericardial LGE in pericarditis. Clinically, we do use this ourselves for complex patients who do have underlying rheumatic conditions and have pericarditis. We use the MRI to tailor treatment, to discuss length of treatment and appropriate therapies, and in some cases with our rheumatologists to intensify immunosuppression. Just in the last 2 minutes, I'm just going to mention this because this was a very elegant description of cardio-rheumatology. It was a perspective by Dr. Weber and colleagues, and we're going to hear from her later on in the afternoon describing their cardio-rheumatology program. This is some of the key blocks that we have been talking about and will continue to discuss during this meeting. Cardio-rheumatology involves looking at disease-specific risk assessment, as was alluded to already, looking at effects of specific anti-inflammatory therapies on short and long-term cardiovascular risk, clarifying the role of cardioprotection therapies, and in this area, future trials will be very important. I've discussed a bit about multimodality cardiac imaging in diagnosing, prognostication, and monitoring of the patients, increasing patient awareness and education, particularly in the area of cardiovascular risk assessment, as Dr. Kuriya has highlighted by the study done by her and her colleagues. And this is the last part, and this is what we're doing today. We're building the cardio-rheumatology community with the aim of improving care for our patients. Thank you.
Thank you, Dr. Osuntokun, and thank you, Dr. Kuriya. Really excellent updates. And it's wonderful to see, as you just said, Dr. Osuntokun, that we're focusing on building the expertise and community within cardio-rheumatology. And this truly is an area that requires a multidisciplinary approach. And we have a multidisciplinary audience today. So we're hoping everyone has something to take home from the update. It's also great to see that the literature is now addressing all sorts of autoimmune inflammatory rheumatic disorders, and that we're looking at not just coronary artery disease, but all of the other complications that are associated from a cardiovascular perspective with these inflammatory disorders. So a lot of action out there, and it's very, very helpful to have such a well-articulated and clear update from both of you. So thank you. Now we are on time, and in fact a couple of minutes early because we started a bit early. So I'm going to move forward and introduce our speakers for the next session. We're changing tack a little bit. The next session is entitled Approach to Pulmonary Hypertension in Systemic Autoimmune Rheumatic Diseases. And we're very pleased to have two speakers today from the University of Toronto. Our first speaker is Dr. Sindhu Johnson. Dr. Johnson is a rheumatologist and director of the Toronto Scleroderma program and an associate professor of medicine at the University of Toronto. She's an internationally recognized rheumatologist and clinical epidemiologist, in particular in the area, of course, of scleroderma. She's a principal investigator at the American College of Rheumatology, working in guidelines for screening, monitoring, and treatments of autoimmune rheumatic disease associated with interstitial lung disease. She investigates novel treatments for scleroderma, and she also has over 200 publications, with her work being published in such prestigious journals as Nature Review Rheumatology, The Lancet Rheumatology, and Annals of Rheumatic Diseases. So we're very pleased to have Dr. Johnson join us. The second speaker today is Dr. Jakov Moric. Dr. Moric is a respirologist. He is a full faculty member at the University of Toronto. He's a clinician teacher and a highly awarded clinician teacher, I would say. He's the associate program director in internal medicine. He is importantly a member of the pulmonary hypertension group at the Toronto General Hospital, and this is an internationally recognized group with specialty in pulmonary hypertension. He's also, I'm pleased to say, the division head of respirology at Women's College Hospital, which is fully affiliated with the University of Toronto. So we have Dr. Johnson speaking first, and then Dr. Moric will follow on. So with that, right on time at 9 o'clock, I'm going to hand over to you, Dr. Johnson.
Thank you, Dr. Harvey, for that very kind introduction, and thank you to the organizers for the opportunity to speak to everyone today. It's really thrilling to be speaking to both a multidisciplinary audience as well as an international audience, because I really do believe that patients will do better if we all work together. In terms of disclosures, I have no financial disclosures, and that's largely because of the work I'm doing that Dr. Harvey alluded to for the American College of Rheumatology. Since I'm the principal investigator for the development of guidelines for the screening, monitoring, and treatment of interstitial lung disease, I've had to give up all financial conflicts of interest for the past 2 years. So today, I will be speaking with Dr. Moric about an approach to pulmonary hypertension in the systemic autoimmune rheumatic diseases. To frame this discussion, I'll present to you a case. A 61-year-old female presents with a history of pulmonary arterial hypertension diagnosed in 2021. She's been treated with endothelin receptor antagonists and phosphodiesterase inhibitors. She now has a 6-month history of worsening dyspnea, palpitations, fatigue, leading to World Health Classification Functional Class 4. She presents to the emergency room of your hospital, and she has cardiogenic shock, right heart failure, and acute kidney injury. You order an echocardiogram, and the RVSP is 86. She has a severely enlarged right ventricle with evidence of hypokinesis. A high-resolution CT thorax is ordered, and there's no evidence of interstitial lung disease, but she does have pleural effusions. Right heart cath is organized, and her mean PA pressure is 58, with a mean right atrial pressure of 12, a wedge pressure of 8, cardiac output of 2.8, and a cardiac index of 1.5. She's moved from the emergency room to the ICU, and diuresis is initiated. The ICU physicians consult both respirology and rheumatology. And so what I'm hoping to do in today's discussion is, first of all, to emphasize the importance of making the right diagnosis. And often this can be best achieved if specialties work together. So both specialties come and assess the patient, and you find that she has telangiectasia over her face. She has abnormal nail fold capillaries with enlargement and dropout. She has puffy fingers. And then when you examine her legs, you see this erythematous rash. It's non-palpable. Some of the lesions are blanchable, but some are non-blanchable. When you order her investigations, you find that she has an elevated creatinine that was suggestive of the acute renal injury. She has pleural effusions and ascites. She has an antinuclear antibody with a titer of 1 in 160 in homogeneous pattern. She has leukopenia, lymphopenia, and her serology reveals the presence of a rheumatoid factor, RNP autoantibodies, and antibodies to Rho and Law. So let's just pause for a moment and think, what is her rheumatologic diagnosis? And so if you feel you want to use the chat, feel free to type in the chat what you think her clinical diagnosis is. Is it systemic sclerosis, also called scleroderma, systemic lupus erythematosus, mixed connective tissue disease, overlap syndrome, rheumatoid arthritis, or vasculitis? So let's work through this differential diagnosis while you are putting your diagnosis in the chat. I was one of the methodologic architects of the American College of Rheumatology European League Against Rheumatism classification criteria for systemic sclerosis. And while these are not meant to help make a diagnosis, they can certainly frame our conceptual framework in the modern era of what these diseases look like. And so these classification criteria are a numeric additive point system where you evaluate the patient's symptoms, signs, and investigations. And if present, you assign a certain weight or score. And so in her case, she had puffy fingers, so she gets 2 points. She had abnormal nail fold capillaries, which give her another 2 points. She has telangiectasia, which give her another 2 points. And I told you at the start of the case, she had a diagnosis of pulmonary arterial hypertension. So that gives her another 2 points. She has a total score of 8. Now, this is insufficient to classify her as systemic sclerosis, but I'm showing you the classification criteria to really emphasize an important conceptual point. And that is, systemic sclerosis is largely a vascular disease. When you hear the word systemic sclerosis or scleroderma, you conjure up notions of fibrotic manifestations, tight skin, and interstitial lung disease. But that's an old way of thinking about systemic sclerosis. We now realize that systemic sclerosis, for the most part, is a vascular disease. Nearly all people with systemic sclerosis have Raynaud's phenomenon, and with time, they may develop other vascular manifestations, So in her case, she's vascular predominant and really has very little fibrotic manifestations. When we think about pulmonary hypertension occurring in the setting of systemic sclerosis, this can occur for a number of reasons. One of the more uncommon causes of pulmonary hypertension in systemic sclerosis is pulmonary veno-occlusive disease. So on the far left of the slide, you can see histopathology of a small pulmonary venule with near occlusion of the lumen. So in this case, the pathology is happening at the level of the venules. Pulmonary veno-occlusive disease is a difficult diagnosis to make because you really need lung biopsy. And often these patients are too unwell to proceed for a lung biopsy. So we and others have proposed the PVOD pentad. That is, if there is the presence of severe hypoxia, a pleural effusion, patchy opacities on high-resolution CT thorax, thoracic lymphadenopathy, and septal lines, this is highly suggestive of pulmonary veno-occlusive disease. The clinical pearl here, of course, is the presence of severe hypoxemia, because pulmonary hypertension in general is not a hypoxic disease unless there is concomitant interstitial lung disease or a shunt. This is also a second pearl that I will share with you, is that if treated with a vasodilator, these patients can go into acute pulmonary edema and go into respiratory failure, leading to death. And this is important for rheumatologists because we commonly use calcium channel blockers for the treatment of Raynaud's phenomenon in scleroderma patients. And so if a patient was to inadvertently go into pulmonary edema after initiation of calcium channel blocker, this also can suggest the diagnosis of pulmonary veno-occlusive disease. Finally, last point, the medical management of pulmonary veno-occlusive disease leading to pulmonary hypertension is very challenging, and most of the time these patients need a lung transplant. A second consideration in our case is the presence of venous thromboembolic disease. We know that, and through our work in the Toronto Scleroderma program, is that pulmonary arterial hypertension is a predictor of development of venous thromboembolic disease. And so if you have a scleroderma patient with a pre-existing diagnosis of pulmonary hypertension, it's important to evaluate for the presence of deep vein thrombosis or pulmonary emboli. We also know that pulmonary arterial hypertension is a predictor of mortality in patients with systemic sclerosis and venous thromboembolic disease. And so these all may be indicators of the prognosis for our case. A third cause of pulmonary hypertension in the setting of systemic sclerosis is concomitant sarcoidosis. Systemic sclerosis sarcoidosis overlap is rare, but does occur. When it does occur, interstitial lung disease is twice as common in these patients compared to patients with pure systemic sclerosis. And similarly, pulmonary hypertension is twice as common in the systemic sclerosis overlap patients with sarcoidosis compared to systemic sclerosis alone. Now, this graphic illustrates different causes of pulmonary hypertension, many of which I've already alluded to. But a more common cause of pulmonary hypertension is pulmonary hypertension secondary to interstitial lung disease. But by far, the most common cause of pulmonary hypertension in systemic sclerosis is pulmonary arterial hypertension. Peter Lee, using the Toronto Scleroderma cohort data in the 1990s, in his seminal paper, demonstrated that when pulmonary hypertension occurs in the setting of systemic sclerosis, the median survival was 12 months. And this is far more sinister than systemic sclerosis interstitial lung disease or having no pulmonary involvement. We have demonstrated that with time, survival has improved. So I've summarized a number of papers for you in chronological order. And in the red colored rows, you can see data from the same two cohorts. And so you can see over a 15-year period, the median survival improved from 12 months to almost 5 years. And even still, this data is old. And what you will find from Dr. Moric's lecture is the modern treatment of pulmonary hypertension in the setting of rheumatic diseases has resulted in significant improvements in survival. When we look at prognostic factors for such patients, we really learned how function at presentation matters. That is disease severity. So the strongest predictors of mortality are right heart function and a rising pulmonary artery pressure. Interestingly, sex does not appear to be a prognostic factor. On the far left, I have a Kaplan-Meier survival curve from the Toronto program data demonstrating survival or comparing survival between females and males. And while systemic sclerosis is more common in females, when it does occur in males, it is a more sinister disease, resulting in diminished survival. On the right, we have data from the pulmonary hypertension cohort of scleroderma patients with pulmonary hypertension. And in this case, you can see that the lines cross over, suggesting that sex does not impact survival. Now, that's systemic sclerosis. Let's switch gears and think about systemic lupus. Here I present for you the classification criteria for systemic sclerosis, of which I was the ACR lead. And again, this is a numeric additive point system. In this case, she does have serosal involvement with her pleural effusions and ascites. She has the presence of autoantibodies. She has hematologic involvement, evidenced by her cytopenias. So I bring this to your attention so you're aware that while less common, pulmonary hypertension can occur in the setting of lupus as well. Back in the 20 years ago, when we were using echocardiogram as a means of diagnosis, we demonstrated that an elevated RVSP is seen in up to 14% of lupus patients. But we now use cardiac catheterization as the means of making a diagnosis. It's important to note that there seems to be international variation in the prevalence and prognosis of pulmonary hypertension. For example, pulmonary hypertension is the third most common cause of death in Korean SLE patients, where we do not see that in North America or in Europe. Also, lupus-associated pulmonary hypertension patients have a shorter time from diagnosis to death compared to idiopathic pulmonary arterial hypertension patients. So this suggests that while less common, pulmonary hypertension in the setting of lupus can be a more aggressive disease. Shirley Lake, formerly known as Shirley Chow, who's a rheumatologist at Sunnybrook Hospital, evaluated prognostic factors for survival in lupus-associated pulmonary hypertension. And what she demonstrated is that if you have inflammatory pulmonary vasculopathy, that is pulmonary vasculitis or thrombosis, that can lead to diminished survival. These are factors that were not seen in the evaluation of prognosis in systemic sclerosis-associated pulmonary hypertension. And so when we think about lupus-associated pulmonary hypertension, there are really three pathologically based subsets that we should consider. There are those that have predominantly thromboembolic disease, that is lupus patients with antiphospholipid antibodies that develop pulmonary emboli and have a thrombotic arteriopathy. These are the patients that you might want to consider anticoagulation. Then there's a subset of patients who have a vasculopathy that's irreversible, the presence of the plexiform lesions that's non-inflammatory, tends to be associated with RNP autoantibodies. And in this case, these patients are more similar to systemic sclerosis patients. And then finally, there's the subset of patients who have essentially a pulmonary vasculitis. That is a vasculopathy that's reversible, that's inflammatory in nature, and is associated with anti-endothelial cell antibodies. And so finally, the last diagnostic consideration is rheumatoid arthritis. Using data from the pulmonary hypertension cohort, we evaluated survival in patients who had rheumatoid arthritis and pulmonary hypertension compared to those with idiopathic pulmonary hypertension. Many have questioned, is this a diagnostic entity, or is this just a group of rheumatoid arthritis patients that are so unlucky to have developed a second significant chronic disease? And what we have demonstrated is that when pulmonary hypertension occurs in the setting of rheumatoid arthritis, these patients are more frequently female, have an older median age of onset, and tend to have less severe disease, demonstrated by a lower baseline mean pulmonary artery pressure, lower WHO functional class, lower baseline pulmonary artery pressure, a BNP, and a longer 6-minute walk test distance. So this would suggest that PH in the setting of rheumatoid arthritis is different than idiopathic pulmonary hypertension. The last interesting clinical pearl that I'll share with you is that all of the RA patients in this cohort were only on DMARDs, meaning none of these patients were treated with biologics. And in fact, we could not identify any patients with rheumatoid arthritis on a biologic agent that developed pulmonary hypertension. So this may suggest that in the modern era of rheumatoid arthritis treatment, we are preventing the development of pulmonary hypertension much like we are preventing the development of other sinister systemic manifestations of rheumatoid arthritis. And so many probably are asking, why does this matter? And the argument I'd like to propose to you to consider is that pulmonary hypertension in the setting of systemic rheumatic diseases follows a pulmonary vascular spectrum. That is, some patients will have a non-inflammatory pulmonary vasculopathy, and these are usually scleroderma patients. On the other hand, there will be a subset of systemic autoimmune rheumatic disease patients, that is, people with lupus, rheumatoid arthritis, or systemic vasculitis that will develop pulmonary hypertension due to an inflammatory pulmonary vascular disease, that is, pulmonary vasculitis. And then finally, there will be a subset of patients, that is, those with overlap syndrome or mixed connective tissue disease that could go either way, depending on which rheumatic disease is predominating their picture. The scleroderma predominant mixed connective tissue disease patients are more likely to have a non-inflammatory vascular pathology, whereas the patients that are lupus predominant mixed connective tissue disease are more likely to have a pulmonary vasculitis as the etiology of their pulmonary hypertension. And so I say all of this to you so that you may consider what is the role of immunosuppression in the management of pulmonary hypertension patients. The French groups have been forward thinking in this regard, and they have a number of publications suggesting that treatment with pulse methylprednisolone with concomitant cyclophosphamide can result in improvements in functional class, mean pulmonary artery pressure, and pulmonary vascular resistance. And furthermore, these improvements in hemodynamics and functional class are sustained at 1 year. In our center, Megan Aversa looked at our pulmonary hypertension cohort and evaluated 70 patients with lupus-associated pulmonary hypertension, some of whom were treated with immunosuppression and some of whom were not. And what she demonstrated was indeed there is a statistically significant difference in improvement in hemodynamics, RVSP, as well as functional class when in the immunosuppressed compared to the non-immunosuppressed. And so as we look to the future, there are a number of clinical trials that are occurring internationally, looking at the role of immunosuppression, usually with our more advanced biologic agents, for the treatment of pulmonary hypertension. And I suspect as we move forward in time, we will see continued improvement in function and survival. Thank you for your attention.
Thanks, Dr. Johnson. I think we're going to hand over to Dr. Moric now.
Thank you, Dr. Harvey, and thank you, Sindhu. This talk actually provides great symmetry with Sindhu and I as we work together in the pulmonary hypertension clinic to treat some of these very complex rheumatologic patients that have pulmonary hypertension. And some of you may be asking, as a respirologist in a cardio-rheumatology symposium, what am I doing here? But fear not, I have an undying love for the right ventricle, as this is the mainstay of trying to keep these people in a good place. These are my disclosures. So some of the objectives that I'll go over today basically outline the most recent updated guidelines that were released in 2022. We'll go over some of the updated diagnostic and classification criteria. I'll go over some of the treatment of PAH in terms of the therapies that we use and how we use them. And then I'll also have a brief look at some of the complex PAH patients with a smattering of different looks at systemic sclerosis throughout, which includes screening and treatment going forward. Dr. Johnson had alluded to, it is the most common of the rheumatologic conditions that present with PAH. So in terms of the hemodynamic definitions, there has been an update compared to the previous guidelines. Prior to this most recent update, it used to be that a mean pulmonary artery pressure greater than 25 was the cutoff for what we thought was abnormal. And then if you looked at the guidelines from before, the most of the consensus opinion was that between 20 and 25 was probably borderline. Well, they've now dropped that number to include pH as anything above 20 as pulmonary hypertension. And then when you look at the different phenotypes, well, we have precapillary pulmonary hypertension, which includes a mean pulmonary pressure greater than 20, the wedge pressure being normal, so less than or equal to 15. And then you'll notice pulmonary vascular resistance also included in the guidelines of greater than 2. If you look at the next category, the isolated post-capillary pulmonary hypertension, these are your group 2 left-sided heart disease patients. You know, they have an elevated pulmonary arterial pressure greater than 20. Their wedge pressure is also elevated, while their pulmonary vascular resistance is less than 2. Where we get into a little bit more complex evaluation of hemodynamics is the combined post and precapillary pulmonary hypertension. So they have an elevated pulmonary arterial pressure of 20. They also have an elevated wedge, but they also have an elevated pulmonary vascular resistance. So these are people that are quite complex with multifactorial disease that are obviously important to be evaluated for potential therapies going forward. What's made its reintroduction into the guidelines is exercise pulmonary hypertension. So this was actually removed from the diagnostic criteria back in Dana Point in 2008, where as a cutoff, it was a mean pulmonary arterial pressure greater than 30. Well, what we know based on different studies is that normal people can get their pulmonary arterial pressure above 30 just with regular exercise. They looked at it a little bit differently and took a look at the mean pulmonary artery pressure over the slope between rest and exercise of greater than 3 millimeters of mercury per liter per minute. Now, if you look at the clinical classification of pulmonary hypertension, we're still talking about a rare lung disease with a prevalence of about 1% in the global population. Dr. Johnson had alluded to the different clinical classifications in the different groups. Those haven't changed. There's still 5 different groups. We mainly focus on group 1, which is the one where most of our targeted therapies are obviously involved in clinical trials and where we have most of our data. These include the idiopathics, the heritables, the associated conditions, including connective tissue disease, HIV, portal pulmonary hypertension. These are still a rare group that we're dealing with. And these are where most of our PH therapies actually lie in terms of treatment. If you look at the second group, this is your pulmonary arterial hypertension that's due to left-sided heart disease. This is your HFpEF, your left ventricular systolic dysfunction, your valvular disease. This is very common. We actually see a lot of these in clinic, and we actually spend a lot of time sending people back to the referring physician and say, look, there's not much we can do for this, just treat the underlying condition. Same goes for PH associated with lung disease, quite common. Once again, the standard of treatment there is optimizing their lung care. There's potential for drugs to be used for the management of their elevated pulmonary pressures. Group 4 is your chronic thromboembolic pulmonary hypertension. Usually there's a multitude of options here. There's surgical therapy, there's interventional therapy that's new, and medical therapy. And then your group 5 is your kind of unclear or multifactorial mechanisms where there isn't really any drugs that we use to treat that group. But what you can see from a rheumatologic perspective is that, and this was something that Sindhu had mentioned, is that you could see how any number of connective tissue diseases could have group 1, group 2, group 3, group 4, or a combination of all of them. So, that's where we see a lot of complex patients in our clinic because they're often not quite straightforward. So the diagnostic algorithm essentially starts from a person that presents with unexplained dyspnea with exertion. And then you would go through a full list of things that you would go through to try and figure that out. We're still not very good at picking this up early, as the time from symptoms to diagnosis is still over 2 years in terms of making a diagnosis of pulmonary hypertension. But as you go through the diagnostic algorithm, it kind of leads you through everything, and so you get to the 2D echocardiogram. And this is where I've noticed, at least when reading the guidelines and kind of going through it, comparing to other ones, we're becoming a lot more aggressive with screening. So you can see here at the top, looking at peak tricuspid regurgitation velocity, anything less than or equal to 2.8 meters per second, the PH probability is probably low, but you're still going to look for other echocardiographic evidence of PH just to make sure that you're not missing anything. And you can see as you go through that, when you see presence of other echo PH signs, what you'll see here is some of these other variables that we pay attention to. Now, I don't read echocardiograms. I'm getting better. I defer to my cardiology colleagues when looking at them for their report. But you can see here, there's 12 different variables that are kind of highlighted as this could show potential signs of PH. And so if you look at them, there's the enlarged right ventricle and the parasternal long axis view. There's the dilated RV with basal RV to LV ratio greater than 1. The flattened interventricular septum leading to a D-shaped LV. Distended inferior vena cava with diminished inspiratory collapsibility. The RVOT at less than 105 meters per second. Reduced right ventricular fractional area change of less than 35%. You have the TAPSE, the tricuspid annular plane systolic excursion, that's less than 18. Decreased peak systolic velocity of tricuspid annulus measured with tissue Doppler. Enlarged right atria greater than 18 centimeters squared. Looking also at the peak TRV greater than 2.8. And then also measuring the systolic pulmonary artery pressure, as well as looking for presence of pericardial effusion. If at any point you have some of those, plus the TRV, which is greater than or equal to 2.8, you should probably go on to do a right heart catheterization for full evaluation. Now, when you go on to do the complete workup of PH, this is often what we do in clinic. You'll do pulmonary function tests to exclude group 3 causes. You'll do a 6-minute walk test to get a baseline of their functional capacity. You'll do a CT scan of the chest to make sure they have no evidence of interstitial lung disease. You'll do a VQ scan to rule out any evidence of chronic thromboembolic disease. Blood tests and immunology to try and figure out whether they have any evidence of rheumatologic conditions. If you suspect any liver disease, you'll do an abdominal ultrasound. If their functional capacity can't quite be measured by a 6-minute walk test because they're better than just a simple walk, you may want to do a cardiopulmonary exercise test. You can also do a sleep study if indicated, if you're really worried about sleep disordered breathing. The other thing, often depending on the patient, we may do a cardiac MRI if we suspect a complex congenital heart disease as well. So these are some of the hemodynamic measurements that we obtain during a right heart catheterization, of importance for us, obviously, from a prognostic standpoint as well as a diagnostic standpoint. Finding out what their mean right atrial pressure is, their mean pulmonary artery pressure, their wedge pressure, their cardiac output. If required, obviously, we do a shunt run to ensure that there's no evidence of shunting. Through those numbers, we can calculate the pulmonary vascular resistance, the cardiac output, the cardiac index, and this all helps us make a diagnosis of pulmonary arterial hypertension. And once we've done that, we can come up with a diagnostic plan and management plan going forward. Now, for screening in systemic sclerosis, I do want to do this really quickly. In patients with systemic sclerosis, an annual evaluation of the risk of having PH is recommended. In adult patients with systemic sclerosis with 3 years of disease duration, and a vital capacity greater than or equal to 40%, a DLCO less than 60%, the DETECT algorithm is recommended to identify asymptomatic patients with PAH. Now, you may ask yourself, what is DETECT? This is based on Coughlin et al. In 2014. And essentially what it does is it's a combination of taking different types of variables to try and come up with a score to determine whether someone requires a right heart catheterization. So if you could see at the top, it says individual risk points in step 1. Step 1 requires you to take a look at the FVC percent predicted over the DLCO predicted, the current over past telangiectasias, serum ACA, serum BNP, serum urate, and then looking at the ECG for right axis deviation. Now, if you look at the kind of the composite of this, if it reaches a number that's greater than 300 based on the individual risk points, you should go on to do an echo. So once you go on to do an echo, you go to step 2. And if you look at the total points in step 2 are comprised by the right atrial area and the TR velocity. If those are greater than a certain number in total risk points from step 2, then you would go on to do a right heart catheterization. And the reason why that's important is because from this algorithm, we're doing a much better job in terms of less overall misdiagnoses. You can see the DETECT algorithm with an N of 319. There's only 4 that they miss compared to the DETECT algorithm with 65% specificity at step 2, which is they miss 15. And then using the ESC or the ERS guidelines, where they missed 29. So you can see that the overall sensitivity is 96%, which is much better. And the reason why that's important is because we know that with a progressive disease without cure, we want to catch this early enough so that we can prevent the pathologic changes from happening, because we know that once they've happened, they're almost impossible to reverse. So this is why this algorithm picking up people early is much better than the previous iterations of different screening methods. So going on to the treatment, this is kind of something we go through in our clinic in terms of a comprehensive risk assessment in pulmonary arterial hypertension. You're looking at low, intermediate, and high risk. You see the variables on the left-hand side. If they have signs of right heart failure, progression of symptoms, we take a look whether they have syncope. We look at their functional class, their walk distance, their cardiopulmonary exercise tests, their pro-BNP, their echo. If we have medical MR, then we look at that. And then we look at their hemodynamics. Now, sometimes we don't have all these things available to us initially, but this is where we classify people initially. And why that's important is because when we go on to do follow-up to treatment, we kind of change the tool, because most everyone that comes to our clinic will get a functional class assessment, a 6-minute walk distance assessment, and a BNP. We normally won't do an echo every visit. We will do it once yearly, or if there's any clinical worsening, and we'll usually do a right heart cath of diagnosis, as well as a response to therapy, and if there's clinical worsening. But these variables here, they get done at every visit. Now, according to the revised guidelines, unfortunately, with a mean pulmonary artery pressure greater than 20 and a PVR greater than 2, the efficacy of the drugs hasn't been looked at in that patient population, because most of the studies up until these most recent guidelines included people that had a mean pulmonary artery pressure greater than 25. And this is true of exercise pH. It really just hasn't been looked at as it's been reintroduced into the guidelines. For patients that are at risk for developing pH, such as systemic sclerotic patients, they should often be referred to a pH center for further evaluation because they can be quite complex. So general measures in terms of treatment. I recommend to all my patients physical rehabilitation exercise. This has a strong recommendation. Now, keep in mind, I don't tell them to do any strenuous exercise, but supervised exercise in a pulmonary rehabilitation program is fantastic for these individuals. I often tell them, you have an underlying lung heart condition that can limit you. Sitting on the couch and doing nothing, now you have another reason, you're deconditioned, where you won't be able to do anything. Anticoagulation, we don't typically start in our clinic. There's some data out of some of the studies out of Europe in Compara that may suggest to use it. We do not. And we definitely don't use anticoagulation in the systemic sclerosis group, given their risk of bleeding. Now, you can use anticoagulation in rheumatologic conditions that have antiphospholipid syndrome. That's a little bit different. But in systemic sclerosis, we don't do it. Diuretics are the mainstay of treatment. We obviously want to keep them a little bit drier rather than more wet to allow for the heart to function a little bit better. So volume assessments happen regularly at our visits. If they require oxygen and meet criteria for oxygen, they should use it. Correcting their anemia and iron status is important as well. Vaccinations, I usually tell them, get your flu shot, get your pneumonia shot, and get your strep pneumo shot. Often psychosocial supports. We often refer some of our patients to psychiatry, just they're dealing with a chronic illness, and often they may need support. We also direct them to different social group supports. Pregnancy is an interesting one in that, you know, the morbidity and mortality around that a long time ago was likely up around 50%. I think newer studies have it around between 11 and 25%. We have had patients that have gone through pregnancy with a multidisciplinary approach with obstetrics and gynecology. We still counsel them not to get pregnant. If they do, we obviously will take them off their ERAs, given those are teratogenic, and we will obviously guide them through their pregnancy as best we can. Surgical procedures, often we tell them to have their anesthesiologist reach out to us so that we can optimize their care, and obviously it depends what anesthesia they get in terms of their outcomes during surgery. And then with travel and altitude, if PH patients can travel, if they require oxygen on the ground, they usually require oxygen on a plane. So those are some of the general measures that I go through with each patient. In terms of the treatment going forward, there's three main different groups. There's the endothelin pathway. Those are endothelin receptor antagonists. Endothelin is a potent pulmonary vasoconstrictor. We have medications that counteract that. We also have the NO pathway, which essentially is the phosphodiesterase inhibitors and the soluble guanylate cyclase stimulators. These potentiate the effect of NO by preventing the degradation of cGMP. And the prostacyclin pathway, which is a potent pulmonary vasodilator. So these are all the medications that are available to us, which is quite interesting. And I don't know if you can see them or if it comes across as, that well, but if you could imagine in the late 90s, the only medications that we really had available were calcium channel blockers, and we had Flolan, which is an IV prostacyclin. We use the ones in red in our group. So we use calcium channel blockers. We usually use amlodipine. In terms of the ERAs, we've used any one of ambrisentan, bosentan, and macitentan. And the phosphodiesterase inhibitors, we use sildenafil and tadalafil. We have prostacyclin analogs. The oral one we use is selexipag. We have soluble guanylate cyclase stimulators, which is riasugat. Those we typically use in patients that have CTEPH. That's where the data is with respect to that medication. And then we also use prostacyclin analogs in terms of epoprostenol and treprostinil, which are IV or sub-Q and IV preparations. So what do we do? So this algorithm, if you look at patient without cardiopulmonary comorbidities, these are your group ones. They present. What you're going to end up doing is looking at their risk stratification. And then so when you look at that in patients that have low or intermediate risk, you're going to start them with an initial ERA and PDE5 therapy. So often what we do in clinic is we start them on one medication. We'll give them a couple of weeks to get used to it and start another one right away. Then once we've done that, we usually bring them back in 3 months, repeat their 6-minute walk test, their BNP. We'll have a look at the strata, see where they fall. We'll often do a right heart cath to gauge the response to therapy. And then from there, kind of decide what to do in terms of a third agent. Do they meet benchmarks where they're under good control and their prognostic factors are good? If not, then we have the discussion about adding in a third medication, which depending on their situation could be an oral prostacyclin analog or an IV or sub-Q one, depending on their status in terms of transplant. The reason why I want to bring up this study is I think this was the study that was the impetus for the aggressive approach to treatment where we went upfront combination therapy. The previous studies prior to this one all started medication sequentially. You would start one medication, you would see how they did, and then depending on their risk factors and where they were, you would potentially add in another medication. Well, Ambition was the first study where basically what it did was it took both medications and started them up front, compared them to monotherapy with ambrisentan and monotherapy with tadalafil. So they would use ambrisentan and tadalafil up front. They would compare it to just ambrisentan and just tadalafil. And what they would look at is a primary endpoint that was basically looking at hospitalization, death from any cause, disease progression, or unsatisfactory long-term response. And what you can see here on the right, any type of combination therapy, whether it's pooling the data from ambrisentan and tadalafil as a monotherapy group, it did better. When you looked at it in isolation, comparing it to combination therapy and ambrisentan, it did better. When you looked at combination therapy versus tadalafil, it did better. And then just as a subset, if you were to look at the same patient population but looked at systemic sclerosis, you can see that combination therapy still did better than pooled monotherapy. And this was something that was also looked at in terms of just connective tissue disease in the top one and systemic sclerosis in the bottom one. Another kind of retrospective analysis I wanted to bring up was points more to the trying to be more aggressive with treating pulmonary arterial hypertension. I often tell my patients, you have a progressive disease without cure. If I told you you had cancer, would you half treat it or would you full treat it? Now, when you look at this trial, what the French group did is they took and looked at 19 patients retrospectively, and these patients were all treated with upfront triple therapy, which included an a PDE5, an ERA, and IV prostacyclin analog. And what you can see here at baseline, most of these people presented very sick. Their NYHA 3-4, their hemodynamics are awful, their functional capacity is terrible. But if you look at these kind of parameters, look how well they do at month 4 and at their final follow-up visit. Most of the NYHA 3-4 people don't exist after their final follow-up visit. They're either NYHA 1 or 2. Their walk distance significantly improved. Their mean pulmonary artery pressure had dropped significantly. Their index had improved, and their PVR had also improved. So this is kind of the baseline for when you have someone really sick and you're trying to treat them. This is something that you can do going forward in terms of, we've had patients that we've treated quite aggressively with good outcomes that have presented either in hospital or in ICU where we've been, okay, let's give them upfront triple therapy. And then you can see here in these box and whisker plots, like just the improvement in 6-minute walk distance, mean pulmonary artery pressure drops, pulmonary vascular resistance drops, and cardiac index improves. So when you treat connective tissue disease, and Dr. Johnson kind of alluded to this earlier, you would treat the underlying condition according to the guidelines, and then also use the current guideline that we just used and I just went through to manage their pulmonary arterial hypertension. And so Dr. Johnson had already gone through this. You know, some require obviously immunosuppressive therapy. Patients with systemic sclerosis and connective tissue disease may have ILD or HFpEF, which needs to be considered when initiating PH therapy. And that points more to some of the stuff that Dr. Kuriya had mentioned, as well as Dr. Johnson had mentioned in terms of the vascular changes that we see in connective tissue diseases. And I already mentioned that we don't really use oral anticoagulation in systemic sclerosis, but could be used obviously in people that have a thrombophilic predisposition. This is an interesting subset of people because we're seeing a lot more of these in clinic. These are people that have PAH, but they also have other cardiopulmonary comorbidities. And when you look at the algorithm, it's kind of off to the right. But basically what they say is you can consider initial oral monotherapy with phosphodiesterase inhibitors or ERAs. And the reason why that's important is because, you know, clinical phenotypes in pulmonary hypertension vary, and particularly in systemic sclerosis, where you can have purely pre-capillary PH, but then you have a smattering of pre and post, you have a smattering of pre with lung disease, you have a smattering of pre-post lung disease. So it can be quite complex, which is why they should go to a pulmonary hypertension center for further evaluation. Now, the demographics of this have changed. If you look at the most contemporary of registries, we're seeing a lot more older patients with more comorbidities. If you remember the older registries from the 80s, a lot of people think of PAH as a young disease in females. Well, this is not necessarily the case anymore. And two main phenotypes have emerged. You have elderly, mostly female, with HFpEF, and 30% have AFib. And you also have elderly, predominantly male, low DLCO, smokers with risk factors for left-sided heart disease. These people usually respond less well to treatment. They're more likely to discontinue. They're less likely to reach low risk status given their multitude of comorbidities, and they have a higher mortality. These phenotypes, though, which makes it difficult, is that they've been excluded from a lot of the clinical trials, and that's why there's really no evidence for the recommendations of this group. And so what we kind of do is we evaluate this on a case-by-case basis. I tend myself, in people that have scleroderma that present with underlying lung disease, I appreciate the fact that they probably have vascular insult as well as their fibrotic changes. So I will try them on some of the PAH therapies, but I won't be as aggressive up front. I'll try them on one, see how they do. In people that have lung disease, you run the risk of further hypoxemia, given that I'm giving them a non-selective pulmonary vasodilator in areas of lungs that are quite fibrotic. I tend to not use ERAs in people that have risk factors for left-sided heart disease, as this can cause fluid retention and you can put people into failure. But there is some case reports for PDE5s working in that patient population. And this is just kind of a description of what a pulmonary hypertension center is. And I'm quite proud working in Toronto, because if you look at all these individual categories, we actually have a lot of that in Toronto. We have quite a diverse group in terms of the people that take care of PH. and a lot of the other groups that surround our clinic, we have at our disposal, which some other centers don't. So I'm actually quite proud of the program. And then looking at the guidelines, what I learned essentially was there's more of an aggressive approach to screening. We want to prevent the pathologic changes from happening and get to treating the disease earlier. There's a more aggressive coordinated approach on the front end with upfront combination therapy and adding in therapies as you're doing their risk assessments along the way. And if you have more complex patients with significant cardiopulmonary comorbidities, they need to be assessed in a PH medical center. Thank you for the opportunity to chat with everyone. It was quite an honor.
Thank you, Dr. Moric. We're right on time. Everyone's done very well this morning, keeping to time. And now we're going to be moving to the panel discussion. So I'm going to invite everybody who's joining the panel discussion to turn their cameras on. I will point out that Dr. Bindee Kuriya was not able to stay with us for the panel discussion. So Dr. Lihi Eder has very kindly agreed to step into to help cover any questions that may come specifically from what Dr. Kuriya had presented. Just waiting for Dr. Eder to jump in. I will remind people that you can enter questions into the chat so that we can address anything that may have come up during the morning session that you'd like to have answer questions or any further sort of explanation. I'll keep an eye on the chat as we're talking. While we're waiting for Dr. Eder, Dr. Moric, I am very pleased to hear that you have a love affair with the right ventricle, because I feel like it's something of an orphan. Dr. Osuntokun and I, being in cardiology, know that often we throw our arms up in despair when we're dealing with pulmonary hypertension and right ventricular disease. And I'd point out to people in the audience that we are actually privileged to be working alongside Dr. Moric and his colleagues in respirology, and we benefit from their expertise. It's not everybody has that benefit that we have. So Dr. Eder has joined us, as I said, to step in for Dr. Kuriya. It's really been a very interesting morning, both the year in review and the pulmonary hypertension. I must say, again, Dr. Moric, to say that this can be complex. I think you've demonstrated pulmonary hypertension in these disorders can be very complex, and we certainly need more expertise, because it's an area where there's only small pockets of expertise, I think, across the provinces and different countries. I'm actually wondering, when we look at these algorithms, how complicated they are and all the different values that have to be taken into consideration. While I must admit that I am, I'm not a technophobe, but I'm not a great meddler in technology. I'm wondering whether artificial intelligence is something that might be able to help in an area such as you work with Dr. Johnson, to be able to help the clinicians, perhaps without your expertise, work through some of those algorithms and think about the best ways of approaching patients and who should be referred on and who shouldn't. While we're talking about pulmonary hypertension, there are a couple of questions in the chat, which one is addressed to you, Sindhu. I'm going to read it out. It says, for Dr. Johnson, how would you differentiate mixed connective tissue disease from overlap as the diagnosis for your patient, and would it affect the approach to treatment?
Oh, okay. Well, thank you. That is a good and a little bit complicated question. So I'll start from the traditional simplistic point of view and sort of escalate up. So, you know, the most basic way to think about overlap versus a mixed connective tissue disease is that overlap is essentially overlap of two conditions. So you typically in this pulmonary hypertension space, it's systemic sclerosis and something else. Often it'll be systemic sclerosis lupus or systemic sclerosis rheumatoid arthritis, very rarely systemic sclerosis and sarcoidosis. Whereas traditionally mixed connective tissue disease is the overlap of at least three conditions. So lupus, scleroderma, rheumatoid arthritis, or myositis, so any 3 of those, plus the presence of an RNP autoantibody. I mean, these are the traditional ways of conceptualizing these diseases. But when you're facing the pulmonary hypertension patient with any one of these conditions, the most important differentiating factor is there evidence of inflammatory disease? Are there red cell casts on the urinalysis to suggest glomerulonephritis? Is there something that can be biopsied, like a skin biopsy or sural nerve biopsy, to investigate for vasculitis? Because once you have evidence of systemic vascular inflammation, then you have more of a reason to believe that the pulmonary vessels may also be inflamed, and then provide the justification for concomitant immunosuppressive therapy in addition to the pH-specific therapies. So now shifting to a little bit more modern thinking is we are increasingly relying on advanced autoantibody profiling in these patients. So if you see antisynthetase antibodies or the presence of an MDA5 autoantibody, well, now we start to invoke more aggressive inflammatory and fibrotic diseases. So if you have systemic sclerosis with just pulmonary hypertension, there's no role for immunosuppressive therapy. On the other hand, if you have the inflammatory manifestations that invoke lupus or vasculitis, then we would add our traditional immunosuppressive agents. And what's now probably the most forward-thinking or pressing issue of our time is that we've now come to recognize this entity of ILD called the rapidly progressive ILD, what respirologists formerly called AIP, or acute interstitial pneumonia. And this is a phenotype of a patient who has ILD evolving in the order of weeks, like over 4 to 12 weeks, where they go from requiring no oxygen to becoming oxygen requiring, dependent, and intubated. So that initial case that we presented to you is someone like that. She was stable on her pH for a long time and then rapidly progressed. Now in her case, I said the CT scan showed no ILD. But let's imagine she did. She'd had rapidly progressive ILD and is now intubated because of hypoxic respiratory failure. If she has MDA5 antibodies, that invokes this entity of rapidly progressive ILD. And while previously we would have used cyclophosphamide, more recently mycophenolate in the management of such patients, if she has pulmonary hypertension secondary to rapidly progressive ILD, the current management would be IVIG, tacrolimus, and ECMO as a bridge to transplantation in conjunction with their pH-specific therapies.
Okay. Hopefully that answers the question that was submitted. There's also a question, I think probably more for you, Jakov, where John Thompson has asked, why was the pressure threshold decreased to 20? Obviously paying close attention to what you were presenting there.
Yeah, so, when you look at the guidelines, there's a few papers actually that did systematic reviews of like pH or pulmonary artery pressures in people at rest and exercise in healthy and normal subjects. And they found that when they looked at it, most healthy subjects, the upper limit of normal didn't go above 20. So they had brought that pressure down in terms of a threshold. And even in the previous guidelines, we still viewed kind of 21 to 25 as like borderline. I think they just made the jump at this most recent guidelines. And, to be honest with you, my lens through which I look at pulmonary hypertension in terms of a progressive disease without cure, it's better to pick up any changes early. I think the issue going forward, though, is now the most recent clinical trials going forward are going to have to include these people to see if there's any difference with the medications that we use. Because right now there's no real guidelines on if you did a right heart cath on someone, what do you do with the mean pulmonary artery pressure of 22? So what we've been doing, at least in clinic, anecdotally, is we'll write, because our drugs are very, very strict in terms of who can prescribe them, given their cost and given the complexity of the situation. I'll often write to the ministry and say, look, the new guidelines have changed. I'll make the argument that I should put them on these medications and up front.
So that's implying that the government and their access for these specialized medications hasn't kept up with best practices.
No, so it's still greater than or equal to 25 in terms of allowing us to treat these people. And I can't really say anything against that, only because there's no real studies looking at mean pulmonary pressure greater than 20 and the outcomes and how they do. But like everything I know about the disease and everything about expert opinion across the globe in terms of pulmonary hypertension would suggest that we should start treating these people early. And you can see that in the guidelines. The screening is much more aggressive, and even the treatment up front is much more aggressive.
Mm-hmm. Is it impacting the cohort of patients that you're seeing in your clinic, Jakov? Are you seeing, is there a large group that fits into this lower threshold?
One of the things that I've noticed, at least recently over the last couple of years, is we're not only getting more referrals of these complex kind of, they have elevated pulmonary pressures on their echo. They have 3 risk factors for left-sided heart disease. They have like some mild ILD or some mild pulmonary issues. The complexity is just really ramped up. That's what I've noticed. And I've also noticed people that present with more exertional dyspnea. We're slowly starting to see changes on their cardiopulmonary exercise tests as well. And one of the things that we do to differentiate whether it's their PH or their left-sided heart disease that's driving their actual dyspnea is we'll do what's called a breath protocol. And Dr. Susanna Mack, who's a fantastic cardiologist, she'll put them through exercise while doing the right heart catheterization. If there's an abnormal rise in their wedge over their cardiac output and their mean pulmonary pressure over their cardiac output, it's likely their left side that's driving their issues. If you're just getting a rise their mean pulmonary artery pressure with no appreciable rise in their wedge, then we know we'll add in therapy because it's likely their pulmonary vascular disease that's actually contributing to how they feel. Some other centers across the world will also use fluid challenges to try and determine whether someone has any evidence of what's the actual main phenotype, right? The left side or the pulmonary arterial hypertension. And basically what you do there is you're just instilling like a bolus of 500 milliliters of fluid, and then over time just seeing if their wedge will rise above 18, and that'll give you a clue that it's likely due to the left side. So there's things that are popping up in the guidelines. They're not yet set in stone in terms of diagnostic algorithms, but like we're using different things to kind of differentiate these different phenotypes.
So there's a follow-up question from Natalie Langlays, I think also to you, Jakov, because it's following on from what you've just been discussing. Sure. So do we have to send every patient with mean pulmonary artery pressure of more than 20 to the right heart cath?
Well, if you already know their mean pulmonary pressure, I presume they've already had a right heart cath. Really, what I would point to is looking at the guidelines in terms of the algorithm at the echo. Like echo's great. Like it really does do a good job, and not just looking at the RVSP, but all the outlines, all the variables that I had outlined, can give you a good picture of whether you think someone should go for a right heart cath. So I'd really point to looking at evaluating the patient. If you believe that they have unexplained dyspnea, you get to an echo, there's an actual algorithm looking at the echo that would probably point you to the direction of whether you need a right heart cath or not.
Mm-hmm. Okay. I had one other question, not being an expert in this area. So, Sindhu, you were saying that in these patients that have the systemic sclerosis, you have to avoid vasodilators because it can actually precipitate deterioration. And then, Jakov, you were talking about avoiding anticoagulants in certain patients. Is there an easy way of explaining for the participants today what the actual underlying pathophysiology is there? Because it's kind of counterintuitive, isn't it, from what we've been talking about today? Why are vasodilators a problem, and why are the anticoagulants? Maybe Sindhu, you can start.
Sure, thank you. Okay, so for most people with scleroderma and or scleroderma-associated pulmonary hypertension, vasodilators are perfectly fine. It's the subtype of pulmonary hypertension has pulmonary veno-occlusive disease as a cause of their pulmonary hypertension that we need to be very careful about using calcium channel blockers or other vasodilators. And unfortunately, there's no clinically easily accessible test to help ascertain whether someone has PVOD. Really, the gold standard is a lung biopsy. And so that's why we've proposed that PVOD pentad. I mean, the easiest rule of thumb is hypoxia. Pulmonary hypertension is not a hypoxic disease. So if they're hypoxic and they don't have ILD or a shunt or some other reason to be hypoxic, that should be the cautionary flag that don't use vasodilators. But really, you need a respirologist involved in the care if you're questioning PVOD, because as rheumatologists, we have very little to do with the management of this, and they most likely need lung transplant. As for anticoagulation, that's a question that's near and dear to my heart because that was my doctoral thesis. And what we found is that, in fact, warfarin has no impact on survival in scleroderma-associated pulmonary hypertension, but rather there is a potential risk of harm because these people have luminal telangiectasia, they have gastric antral vascular lesions in their stomach, and these are very delicate vascular lesions that can bleed easily. So these patients are at increased risk of, at best, iron deficiency anemia, but at worst, massive GI bleeds. So if anticoagulation confers no survival benefit, but increases risk, well, then there's really no value into using anticoagulation. I don't know if Dr. Moric has more to add on either of these issues.
Yeah, if you could imagine, Sindhu, just to like kind of echo what you say, when you're looking at something like pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis, like these are all obstruction at the lever post capillary. So we're using non-selective pulmonary vasodilators to improve blood flow from right to left. The level of the obstructions on the other side of the capillary at the capillary, you invariably put these people into failure. So to Sindhu's point, we're not going to do a biopsy in these individuals because it's too high risk. And it's almost from the response to treatment that we determine that through, putting them in failure, looking at their CT scan to see some of those changes that Sindhu had described, where we can make a clinical diagnosis of PVOD. And often for these patients, they require aggressive diuresis. We often have to wean them off their pulmonary vasodilators, and then it's almost an auto referral to transplant as they progress quite quickly and they get sick quite quickly.
Interesting. I mean, just thinking about the patients, they must be at increased risk of atrial fibrillation, and the reflex response is to anticoagulate patients. And we do know that there are certain cohorts where anticoagulation, and this is one of the cohorts, can be problematic, and yet it really is something that people have become very comfortable with, appropriately so, with patients with atrial fibrillation. So that's certainly a bit of a warning there if people are managing these patients and they do go into AFib. And also thinking about how many patients are actually on calcium channel blockers for their Raynaud's. And that's also a bit of a reflex response that we're probably even, outside of cardiology and rheumatology and respirology, the family docs would feel comfortable with starting patients on calcium channel blockers and may not be aware of that concern. So that's really helpful.
Paula, so I have a question, if no one else, if I don't see any questions in the chat box, I wanted to ask Sindhu. Well, I think we are all aware of, scleroderma being associated with pulmonary hypertension, and we talk about prevention and treating early diagnosis. So, and many people in the audience are rheumatologists that are managing, have general rheumatology practice, and probably don't have a lot of scleroderma patients because this is such a rare disease. So, and we also have family physicians who some of them might be caring for scleroderma patients, lupus patients. And what would be your recommendations for the people in the audience that regarding screening in asymptomatic patients? What measures and how frequently, when should they start screening, who should they start screening, and what should they do when they found some findings? When should they refer to respirologists, for example?
Sure. Thank you, Lihi. So, we recommend that patients with systemic sclerosis or overlap conditions that have scleroderma as part of their features, that they undergo echocardiogram and pulmonary function tests yearly. Or during the pandemic, that was a little difficult, so we said every 1 to 2 years, because you're screening for pulmonary hypertension or interstitial lung disease. If the patient is symptomatic, then we would add high-resolution CT thorax to screen for the ILD. But we generally do not do a high-res CT in patients that are asymptomatic. Now, in terms of comfort in managing, we can't expect everybody to feel comfortable interpreting these tests or initiating these treatments, or may not have access to these treatments. But hopefully through days like today, people will be educated to at least screen and then refer to a center where you can have a respirologist, cardiologist, or rheumatologist further assess the patient with cardiac catheterization to make the diagnostic test.
Mm-hmm. One of the things that came across both in Tosin's presentation and in yours, Sindhu, was the pregnancy risk in patients with inflammatory rheumatic disorders, including systemic sclerosis. just, I mean, I don't have an answer to this, but I'd open it up to the panels. You know, what should we be doing, and with patients with lupus or with systemic sclerosis or some of the other disorders, who should we potentially be sending to high-risk pregnancy specialists, or should it be all of these patients going to high-risk centres? Probably for lupus and systemic sclerosis, that may be the case. I'm not so sure for some of the other conditions. Do any of you have any thoughts about that? Not everybody is going to have access, of course, to high-risk pregnancy services, particularly, you know, this is where we start thinking about equity of access, whether you're in a urban versus a rural or let alone more remote area. But any thoughts about that?
Yeah, I can start if that's okay. Thanks for that question. So definitely, you know, this is a multidisciplinary issue, and I would say it starts off with the person caring for these patients, the family physician. It starts off with risk management. We saw that in the data from the States, there was an increased risk of traditional risk factors, hypertension, increased BMI, gestational diabetes. Those things are going to be picked up by the primary care practitioner before they ever get to us. And, you know, if we look at some of the data that Dr. Kuriya presented, you know, we're not addressing risk factors as it is in people who have autoimmune inflammatory conditions. So in young people of childbearing age, before we ever get to this, we should really be addressing risk factors. I would say from a personal perspective, hypertension, definitely because there's an increased risk with preeclampsia, we need to address that. When we do have conditions like lupus and other rheumatic diseases, then yes, we should be doing multidisciplinary care. If we have it, we should refer to high-risk pregnancy, even, you know, for preconception counseling, really, because we know that the risk is very high. And, you know, again, for caring for these patients, they are actually not aware of this risk.
Mm-hmm.
You know, anecdotally, they do not seem to be aware of this risk. So really, that message, I think, can be shared by every healthcare professional that is looking after these patients.
Mm-hmm. Sindhu, are all of your patients sent for preconception counselling?
Well, so not at the first visit, but second, third visit in a person of childbearing age, we often talk about potential for future pregnancy because many of the immunosuppressive drugs we use are teratogenic. And so we need to let them know that if you plan to be pregnant, you know, you need to let your primary care physician know and let your specialty team know, because we may need to discontinue that medication, replace with something that's not teratogenic, and usually we need 3 months for the teratogenic medication to wash out. Right. Now, if the patient has PH, that's where I really depend on my pulmonary and cardiology colleagues, because what remains uncertain is this patient able to successfully carry through the pregnancy? And so usually it's, you know, I work most closely with Dr. Moric and his colleagues at the PH program. So this is where they weigh in about the viability of the pregnancy.
Mm-hmm. Right. Lihi?
Yeah, I had a question about the clustering of the pulmonary hypertension that you mentioned with the inflammatory and non-inflammatory mechanisms. And it seems like it's predominantly, maybe I'm wrong, but it's predominantly dependent on clinical features. So I wonder, maybe you can talk about, you know, how are we doing in terms of biomarkers, like laboratory biomarkers or imaging biomarkers or other more, I guess, objective measures to help classify these patients maybe early on in the course to help you, because as you alluded to, it would determine the course of treatment, right? So any advances there.
Yeah, no, right now we're very limited in our traditional biomarkers. So urinalysis, ESR, CK, CRP, skin biopsy. But, many people don't know to look for these things. So I hope if that's one lesson that comes out of today's session is that people know to look. And because, the case that we presented, she was treated with everything. She was treated with triple combination pH-specific therapy. She was treated with pulse steroids and mycophenolate because she declined cyclophosphamide. And 4 months later, she was NYHA class 1. She was not dyspneic anymore. And so for the vast majority of cases of pulmonary hypertension in the systemic, in the rheumatic diseases, that doesn't happen. We try to prevent progression of the disease, but we very rarely see reversal. But in that small subset of patients who have inflammatory pulmonary pathology, if you aggressively treat them with pulmonary hypertension, with immunosuppressives, you can completely reverse the disease. And so, that's why I think it's worth the extra effort to look, even if it's the most basic of biomarkers, because it really can change someone's disease trajectory.
And I can just hop on that. I can think anecdotally of the people that we've actually weaned off their pH therapies. They're mostly lupus patients because their lupus became quiescent. And to be fair, this isn't something we would take lightly of taking someone off pH therapies. We would repeat a right heart cath, pressures normalized, take them off one, repeat everything again, and we'd really follow them closely. But that group is the one that's probably responded the best to the overall kind of treatment of their underlying inflammatory disease. And to the patient that Sindhu presented, that patient's still being seen in clinic and doing quite well and still attending her Zumba classes. She's doing awesome right now.
Well, that's very relevant to one of our later sessions, Jakov, where we're talking about exercise as well as talking about diet and obesity. So Zumba is quite an energetic form of exercise for somebody with pulmonary hypertension. I'm just going to take the liberty of finishing off. We're almost at time. I just wanted to pick up on one other thing in the year in review, and that was what Bindee had presented about statin use when we're going back to sort of primary prevention in our patients. And Tosin, you referenced this as well when you're talking about patients and counselling and pre-pregnancy, etc. Just reminding people that even when we're talking about management of lipids, things have become a little bit more complicated. We've teased things out a little bit more beyond the LDL, and there are other indices that you can look at and can help you with making decisions about implementing statin therapy. So the Canadian Cardiovascular Society guidelines are a good start, and obviously we've got an international audience, and their societies in their own countries will have guidelines. But remember, LDL is important, but so is non-HDL cholesterol, and so are the apolipoproteins, and also coronary artery calcium score, something that we're finding really helpful here when we're doing risk stratification in our patients patients within our network. So a CAC score of above 0 is really important, particularly in the younger patients, as that does indicate that there's already the development of atherosclerosis. So if you haven't had a chance to look at those lipid guidelines, have a look, make sure you're familiar with the markers above and beyond LDL, and do think about a coronary calcium score. It's simple, it's quick, low dose, very low dose radiation. It can really help with guiding primary prevention therapy, and also helping counselling the patient when you can actually show that there is clinical evidence of atherosclerotic disease with plaques within the coronaries. So I've just taken that liberty to highlight that as we finish off the discussion. So I want to thank everybody for their excellent presentations this morning, and Lihi for stepping in for Bindee. So thank you very much, everyone, for your participation, and to the speakers for a great morning. Good morning, everybody, and welcome back to the second session of our Cardio Room Symposium today. We have an excellent second session where we're going to be discussing obesity in the context of cardio-rheumatological disorders, and we have 4 speakers. Our first speaker is Dr. Lihi Eder, and she'll be talking about perspective of obesity and arthritis. Then we'll be moving on to discussion of behavioural approach, diet, and pharmacological interventions in our patient cohorts. So if you weren't participating in the first session, I'll just remind you that any questions you might have, just enter into the chat. We will address the questions when we do the panel discussion at the end of the presentations. We're not taking questions after each individual presentation, but rather as an interactive panel. Feel free at any time, even during the discussion, to be entering those questions, and I'll be keeping an eye on those in my role as the moderator. Now, as I mentioned, our first speaker today is Lihi Eder. If you're familiar with the Cardio-Rheumatology network at University of Toronto and were at the first session this morning, you'd know that Lihi is the co-director of the Cardio-Rheumatology network with me, and that we are responsible for this Cardio-Rheum Symposium that's held on an annual basis. I just wanted to point out some of Lihi's achievements. Lihi is a clinician scientist, and she's an associate professor at the University of Toronto. In addition to her co-director role of the Cardio-Rheumatology network, she's also director of the psoriatic arthritis program at Women's College Hospital. She was awarded a Canada Research Chair in inflammatory rheumatic disorders in 2021, and with this chair she's researching barriers of equitable care in rheumatology, including the role of sex and gender as determinants of disease outcomes. She is an elected member of the GRAPPA Steering Committee, and she's president of the Canadian Rheumatology Ultrasound Society. She's also been the recipient of many awards and is known very well nationally and internationally for her work. So after Dr. Eder, we will be moving on to our next speaker, who I'm going to introduce now, just since Lihi's only going to be doing a relatively short presentation. And that's Dr. Susan Bartlett. Dr. Bartlett is a professor of medicine at McGill. She's a senior researcher at McGill University Health Centre and the Arthritis Research Canada. She's an adjunct professor in rheumatology at Johns Hopkins Medicine. She's a clinical psychologist who conducts research and counsels patients with inflammatory arthritis, so a very important area of specialty. Her research focuses on behavioural interventions to improve outcomes and the science and application of patient-centred measurements. She's president-elect of the NIH PROMISE Health Organisation, co-director of PROMISE Canada and the McGill Centre for Health Measurement. So we will be welcoming Susan after Lihi's given her presentation. So with that, I'm going to hand over to you, Lihi.
Thank you, Paula. And thank you for the kind introduction. I'm going to be giving an introduction to this very important topic that I think is relevant for all of us, whether we are rheumatologists or family physicians or cardiologists or any other specialist or doing other allied health work, which is the role of obesity in rheumatic diseases. These are my disclosures. I received some unrestricted educational and research grants that are not really relevant to this talk. So why should we care about obesity in rheumatic diseases? So as you all know, obesity is an epidemic of the Western world as well as the developing world. And many of the patients that we see in our practice suffer from obesity, but the association is even stronger in patients with established rheumatic conditions. The prevalence of obesity is higher in patients with rheumatoid arthritis, which is the most common inflammatory arthritis that we see in practice. And it's even more so prevalent in patients with psoriatic arthritis and in patients with osteoarthritis and gout. So many of the patients that we see in practice will suffer from obesity. Obesity also exacerbates some of the comorbidities that are known to be associated with inflammatory arthritis. And we are in a cardio-rheumatology symposium. We've learned that cardiovascular diseases are higher in patients with rheumatic diseases, and obesity is a known risk factor for cardiovascular disease. So that is the presence of obesity in the context of inflammatory arthritis will probably even elevate further the risk of developing these life-threatening events. Mood disorders and pain disorders such as fibromyalgia are also known to be associated with inflammatory arthritis and as well as with obesity. So again, in this context, obesity is associated with other comorbidities and multimorbidity, further complicating the care of patients. There are also practical aspects of obesity when considering the assessment of disease activity and monitoring of disease activity in the context of inflammatory arthritis. We know that patients who suffer from obesity have higher levels of pain and disability, but these seem to be disconnected from the risk of developing future radiographic progression. So despite the fact that obesity could affect patient symptoms and function, at least in rheumatoid arthritis, there seems to be a lack of association between obesity and the future risk of developing radiographic damage, which is interesting. Secondly, a common biomarker that we use in practice, CRP, which is a measure of systemic inflammation, is known to be higher in patients with obesity because the adipose tissue can produce pro-inflammatory cytokines. So in patients who are obese, CRP levels tend to be higher to begin with. And then this further complicates the assessment of disease activity because if the CRP is produced elsewhere and not in the joint, then this could mean elevated levels of composite outcome measures that are used to assess disease activity, such as the DAS28, and that may be irrelated to the fact whether the inflammation is active in the joint or not. Physical examination of the joints could also be affected by the presence of obesity. So especially in the context of morbid obesity, when there is a lot of adipose tissue around the joint, it makes it quite difficult to assess whether a joint is swollen or not. And this further highlight the potential role of imaging in this context to assess whether a joint that is painful is actually inflamed in this context, because our physical exam is quite limited. Obesity can also influence the chances of achieving low disease activity states. So this is a study that we've published using the University of Toronto psoriatic arthritis cohort, where we've shown that patients who have obesity have lower chances of achieving optimal treatment outcomes, which is in this case a minimal disease activity state. There was a dose-response association between BMI and future chances of achieving this outcome, with a 50% lower chances in patients who were obese to achieve this outcome. I mentioned the disconnect between patient-reported outcome and the arthritic process in obesity, and the fact that patients with rheumatoid arthritis who are obese have lower chances of progressing. However, they have higher chances of disability. And then again, there is really not so much an association between BMI and inflammatory arthritis when using MRI or more objective imaging devices. So this really further highlights the complexity of evaluating the active inflammation in the joints in the context of obesity, and the need to consider using imaging such as MRI or ultrasound in this context to discern whether the symptoms that the patients are reporting are due to inflamed joints or due to other comorbidities or other medical conditions that these patients are more likely to suffer from. What about treatment response? So there's been quite a lot of studies looking at BMI and the impact of responding to treatment. We are in the era of biologic therapies, and many studies looked into TNF inhibitors. This is just one of them that summarized the chances of responding to TNF inhibitors across different types of inflammatory conditions. And except from IBD, across the three types of inflammatory arthritis, there's been an association between BMI and higher chances of treatment failure. So there was a 60% higher risk of treatment failure with obesity, and again, a dose response association between BMI and lower chances of response. Interestingly, there was no clear association between a specific drug or TNF inhibitor and the chances. And this is important because some of these TNF inhibitors are dosed by weight. So infliximab, for example, is dosed by weight, and the fact that we use a higher dose in obese patients didn't really change these outcomes. So the mechanism of this is really unknown. Obviously, there might be some differences in pharmacokinetics, higher clearance. There's also been a suggestion of an antigen sink, which is basically production of TNF by the adipose tissue that might capture the medication, and then there might be effective lower doses of the drugs in patients who have obesity, and the management or how to address it remains unclear. Probably we need to monitor these patients more closely when they start treatment, because the higher chances of failure. Sometimes using higher doses in patients who showed some initial response might work, but again, there seem to be still a lack of understanding of what is the association between BMI and a lower response in these patients. What about weight loss? So we'll hear more from our next speakers about diet and other treatments for obesity, but specifically in patients with rheumatic diseases, there's been a few studies on diet, very few randomized trials that looked into the effect of diet. This is one of them in patients with psoriatic arthritis that were randomized to a very strict low-caloric diet versus standard of care. They show that among patients who were starting TNF inhibitors, there was a higher chance of meeting a low or minimal disease activity state in the dietary group. So these patients were able to achieve weight loss through diet. And they also show that the chances were directly associated with the amount of weight these patients were able to achieve. Bariatric surgery is clearly a more drastic approach to patients with morbid obesity. And this is obviously not a randomized trial, but before and after, but still they've shown that in patients with rheumatoid arthritis, patients who underwent bariatric surgery showed a marked improvement in measures of disease activities, including both inflammatory markers, but also patient-reported outcomes with a reduction into low disease activity states of their rheumatoid arthritis following the surgery. So I hope I convinced you that considering obesity is important, but we as rheumatologists are facing many challenges when managing obesity, such as lack of time, lack of knowledge. It's not entirely clear who should be responsible. Is it we as rheumatologists or the family physician that should manage obesity in these patients? And I think the largest challenge is a lack of care coordination and the difficulty in accessing many of the obesity programs. So I hope that with the next speakers, we will be able to educate all of us and learn more about these different approaches. And just to kick in the next talks, I'll present a case that will be addressed by the next speakers. This is a patient, a female who is 45 years of age, with a BMI of 36. She has psoriatic arthritis for 2 years, some comorbidities including hypertension, and she comes in with worsening joint pain, limited function, and flare of her psoriasis. For these reasons, she's starting a biologic therapy called adalimumab, which is a TNF inhibitor. And she comes back 3 months later with some improvement, although not how we would like her to be, so only about a 30% improvement in her symptoms. But on physical exam, despite the resolution of swollen joints, she has still some tender joints, and she reports ongoing disability in function. She's limited in her ability to perform physical activity. She's quite sedentary in her lifestyle. And she also reported having some mental or psychological challenges, being socially isolated because of her ongoing skin condition. So I would turn it now on to Dr. Bartlett to discuss the management of obesity in terms of behavioral changes. So,
thank you, Lihi. When Paula introduced me early on, what she talked about was my experience as a clinical psychologist in working with people with inflammatory arthritis. But long before I did that, when I did my initial training, it was in the area of weight and eating disorders. And so spent a lot of time, my research actually was in the area of helping physicians do brief counseling with their patients to focus on weight. So that's what I'm going to draw on. And rather than go into the research, there isn't a whole lot of it, to be honest, in the area of rheumatic diseases. But what I hope to do is leave you with some practical strategies of what works, what to think about, what to focus on. And, you know, if you remember nothing else, I hope that one of the things you'll take away from this is that your words really do matter. And even brief conversations can make a huge difference. I want to start first by talking about the bias that we as health professionals hold. We have negative views on obesity and obese patients. That's clear even in 2023. For physicians, physicians tend to view heavier patients as being non-compliant, dishonest, lazy, lacking in self-control, weak-willed, unintelligent, unsuccessful. Psychologists are not immune from this either. We have the same kind of biases. We tend to see patients who are heavier as having more pathology and more severe psychological symptoms, more negative attributes. What does all of this bias really do? Well, what it does is it inhibits us from talking with patients. And yet we know one of the single most important things you can do is simply bring up weight with patients. We have a really, really important role in validating their experiences and helping them to feel less isolated, and then walking through with them what they're saying to themselves about their weight and what they can do about their weight and where they can get some support. Now, what I'm going to talk about is what is going to work for about 80% of people. It's certainly not going to work for everybody. There are those that are much more complex, and they really need to have a specialized team. But what is remarkable and what we've learned over 40 years of research is that even brief conversations, as brief as 30 seconds with your patients, can make a real difference. And Lihi brought up this idea about, is it the rheumatologist's responsibility? Should primary care be taking care of this? Well, one of the things that I can tell you, having done a lot of focus groups in Canada and the United States, is that your patients feel more bonded to you and feel that you understand them better, the rheumatologists in the audience, than the primary care docs often do. It is their rheumatologists who they really see as their primary care providers. And so I think that gives you a very unique opportunity. Here's one of the more recent studies. This is coming out of the UK, but it shows us that, you know, patients continue to view their doctor as their trusted authority on their health. And for individuals, a conversation as brief as 30 seconds between the doctor and the patient resulted where the doctor encouraged the patient to join a weight loss program. I'll speak about the importance of programs in a few minutes, but they encouraged them to go and just join a program. And you know what? 40% went on to attend the program. And of those who attended the program, a quarter lost 5% and kept it off a year later. And you might be thinking, well, 5%, that's not a big deal. Actually, in weight loss, it's a huge deal. to get people to focus on losing weight, but also to keep it off for a year. The best estimates we have still are that about 10% of people can lose, at best, about 10% of their weight. So look at this. This is a brief intervention, just the rheumatologist, or rather the primary care doctor having the conversation, a brief conversation, and it motivates people to go and at least try. So that's really important. Remember that point. What do patients want you to say to them? Well, it's easier to tell you what they don't want to say, don't want to hear. They don't want to hear the word obese. Obese to them is very, very pejorative. So talk to them about their weight or unhealthy weight, or talk with them about their body mass index, but try and stay away from the more medical terms like obese, morbid obesity, severe obesity. And how to begin the conversation? Well, I think have a natural in, because what always works best is to link it back to the symptoms that they're experiencing. They're coming in to you because they're joints. And we know that weight has a huge impact on the health of the joint and the experience of joint pain. So that's a great place to start the conversation. In the US, the CDC data suggests that adults who get weight loss advice are 4 times more likely to go on and try to do something about their weight. And yet the reality is, even in 2023, less than half of overweight and obese patients ever have a physician raise this with them in the office. You know, not talking with them about their weight sends a message as well. So it's important to find the right day, the right time, and to recognize that this is a conversation that needs to unfold over time. I liken it a lot to conversations about stopping smoking. It's never going to happen, or it's rarely going to happen, that you'll raise the conversation once and the patient will say, well, of course, I'll go ahead and do that right away. But think of it as planting seeds. You're getting them to start to think. When they ask, what can I do to help? What can I do that's going to make a difference? This is one of the things that we know really does make a difference. Losing even small amounts of weight has a huge impact, for instance, on the amount of force that goes through the knee joint. It's really important, I think, to ask permission to talk about weight. And what you can do is start with understanding their awareness of the importance of changing behavior, of nutrition, of physical activity. It's pretty unlikely that you're going to have a heavy person in your office who's never tried to lose weight. Most people have made several attempts with varying degrees of success. And so that's a natural place to start talking. Ask them what they've done. Ask them what's worked. Ask them what hasn't worked. These are drawn from the Canadian obesity guidelines, this slide here. And it does note that comprehensive programs are going to have aspects that touch on exercise, on diet, definitely, but also on the psychological aspects, because what patients are thinking, what they're saying to themselves, how they feel, all of that is going to influence their behavior. And then I think this is the area that actually changed the way I interact with patients the most, and that's this whole concept of readiness. And readiness will vary. Your readiness to start an exercise program, your readiness to adhere to the Mediterranean diet, your readiness to focus on and to look at the sources of stress and do what you can to mitigate some of those sources. So start where people are ready. There's no ideal place to begin, but certainly you want to begin with where they have higher confidence and higher self-efficacy. This is the stages of change cycle. You may or may not be familiar with it. We use it a lot in health behavior because it helps us to understand that it is a process that people go through when they change behavior. It's one of the most complex things that we try to do, quite frankly, to change our behavior. If you need any evidence of that, I'll remind you of the last time you tried to drink less coffee, or you wanted to exercise more regularly. I mean, we have these ambitions, which we're often able to carry out for a couple of days, but then things begin to fall apart. I think where we really began to advance in our understanding of behavior change was when psychologists stopped studying people who were unsuccessful and instead looked at that smaller minority of people who were actually successful. And what they learned is that there is this process that everybody goes through. You go through it in a linear fashion. You can't skip ahead, unfortunately. The stages of change begin with the first stage, which is pre-contemplation. That's that light blue arrow. Pre-contemplation, the person isn't even thinking about changing their behavior. And the reality is that about 60% of the population who are overweight and need to lose weight are in pre-contemplation. So nearly 2 out of 3 people aren't thinking about what they could do to lose weight. The goal with these individuals is not to get them on a weight loss program. The goal is to move them into the next stage, contemplation, and just get them thinking about what would it take? What would you want to do? Would you want to be meeting with a dietitian? Would you want to be part of a program? So in that 30 seconds, again, you're not trying to find ways to match someone who's not thinking about losing weight with a weight loss program or approach. What you're trying to do is just get them thinking and have them come back for the next visit so that they can tell you a little more about where their thinking has taken them. About 30% are in contemplation, and this is the group I think that is in some ways the most challenging. They like to talk to us a lot about what they think they should do or what they shouldn't do or why they can begin or can't begin. And what we really need the contemplators to do is to stop thinking. This is the group we need to just do something. We need to move them into action. And by doing that, actually, it's as simple as saying, what are you prepared to do right now? What kinds of things, what kind of changes could you make this week, next week? That's taking the contemplator and getting them out of that sort of where they get lost in their own thoughts and helping them move forward in the cycle of change, move towards preparation. Preparation is this very brief stage, anywhere from 1 to 3 weeks. People are doing some, maybe not enough of what they need to be doing, but that's where they build the momentum. So keep that in mind. The first thing you want to do is find out what people are ready to do, and then just move them along the cycle a little bit. Either get them thinking more, or in some cases, you're going to ask them to stop thinking about it so much and just try a few things. What else is important is to talk to them about what's realistic. I love this slide because, people often do come in with the expectation. I need to get back to the weight I was when I got married, when I went to the prom, when I was wearing, for women, that beautiful red dress. And that's probably not realistic. What is realistic are smaller amounts of weight that they can keep off over longer periods of time. They didn't gain a significant amount of weight in a short period of time. And so helping them to understand and feel good about setting as a target, even a target as small as 5 pounds. That's 5 pounds of weight loss contrasted with what might have been more weight gain. And the way that we go about doing that, of course, is talking with them about goals and setting SMART goals. I'm not going to spend much time talking about that. We've all been exposed to the concepts of SMART goals, that they need to be measurable, they need to be timely, they need to be actionable. But it's really just helping patients appreciate this really is hard. It's complex and it takes a whole lot of work to lose as little as 5 or 10 pounds. And yet losing as little as that amount of weight can make a huge difference in how people feel. And you'll want to talk to them about what's on their mind too, because what's on their mind, what they're saying to themselves about this process, is probably every bit as important as what's on their plate. I'm going to finish up by talking about the notion of, should patients be directed towards programs? Would your patient be better off being in a comprehensive program? Well, the reality is that for most people, the answer is yes. We do better with support on average, but that's not true for everybody. Some people really do prefer and manage quite well on their own. A recent head-to-head study was done comparing a commercial weight loss program versus trying to do it on their own. The participants were not charged for the program, and the control condition included, really some brief instructions in an evidence-based approach, sort of choose your own approach. But what was clear from the largest study that's been done so far, is that the participants who were in the commercial program did significantly better, both in the short term and in the long term. And for the 35 years that I've been sort of working in this area, That's what we've seen very, very consistently. Most people are going to do better with some type of support. Does it need to be in person? No. Can it be online? Absolutely. Where do I send everybody that comes to me that hasn't been through any kind of program? Frankly, I send them to Weight Watchers, because I think that in many ways, nobody does it better than Weight Watchers, to give them the basic kind of information that they really need to have. Last time I was doing this talk, somebody said to me, what about Noom? Like, you're a psychologist, don't you believe in Noom? Yes, I believe in Noom. Noom is more expensive. It's a very good program. But I think if you want the basic information, if you want to make sure your patient has the basic information of where to begin and all of those elements that are important to touch on, nobody is doing it better or more efficiently or effectively than Weight Watchers. I want to finish up by asking, would Michelle benefit from additional support, not just from a program, but maybe from a mental health provider? You know, especially with psoriatic arthritis, psoriasis, it has a major impact on quality of life. And it's associated with a much greater risk of depression, anxiety, and even suicidality. The visible effects on the skin really do put people at much greater risk from a mental health perspective. And the effects seem to be worse in younger patients, in males, and in those with early onset disease. What tends to happen is these folks get even more isolated. And the truth is, even when we clear up their skin with the great therapeutics that we have these days, they still, in their own minds, continue to often wear the long sleeves, to not go to the pool in the summer, to be completely covered up, because there's a psychological scar that seems to come with the psoriatic arthritis. So for many individuals, some additional support can be quite helpful. It doesn't need to be from a psychologist. It could be from an employee assistance program. It can be through a religious organization. Most pastors, most imams, most religious leaders now get training, specific training in psychological counseling. Wherever they can get support, that's a place to start. But for a minority of individuals, working with a qualified mental health professional may be very important. And, you know, I think one of the things that's most interesting to me is we're beginning to understand why depression and mental health is so important. And we're seeing that there are real common pathways that are implicated between the development of an autoimmune disease and the development of depression. You know, when we have inflammation in the body, I know this is putting in very simplistic terms, but it's a way I think that many people are beginning to think about it. When that inflammation is in the joints, we call it arthritis. When the inflammation is in the gut, we call it Crohn's disease. When the inflammation is in the brain, we may call it depression. So there are absolutely those common pathways that are being activated with this. And the other thing that I would remind you of is that very strong link between cardiovascular disease and depression, because about 20% of people who have heart disease are also depressed. 20% of people with heart failure are depressed. So mental health is not only associated with the risk factors for developing both heart disease and autoimmune disease, but it also appears that it may be very important overall in how well people do. Expect that about 1 in 3 of your patients with psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, about 1 in 3 will meet criteria for clinical depression. And depression is so important because it influences not only their quality of life, but also the health behaviors that they engage in. So people who are depressed tend to smoke. They tend to have a much more inactive lifestyle. And depression is our best marker of people who are going to be non-adherent to treatment. So just, I think, some more reasons to think about with individuals when you're talking with them around their weight, getting them as much support as we can. And I think with that, I'll stop here and turn it over to Kim, who will be talking about some of the specific aspects of dietary counseling.
Thank you, Susan. It's such an important area, and as you pointed out, adipose tissue and the inflammation related to it is really underpinning also many other chronic conditions. So I'm going to take the opportunity to introduce our next speaker, Kim Arrey. Kim is a registered dietitian nutritionist whose focus is on taking complex scientific information and simplifying it so that the clients can actually distill out of that information what they really want and what they need. Telling a great story is important for helping patients understand about healthy eating and changing their sort of life habits. Kim was actually a collaborator on a best-selling book with Dr. Michael Starr. The book was called The Complete Arthritis and Health Diet Guide and Cookbook. And in this book, they were able to explain to patients and their families how to diagnose, treat osteoarthritis and rheumatoid arthritis, while giving explanations and examples of how diet could help people with arthritis reduce their pain, stiffness, and actually improve their energy levels, so their overall well-being. She's also worked for the Arthritis Society of Canada as a spokesperson in advocacy. And she's also worked in media as a writer for publications such as the National Post and Canadian Living, and also has been a regular and special guest on radio and television shows. So we're very pleased to have you with us today, Kim, and I'm very much looking forward to what you have to tell us during your session.
Well, thank you very much for that lovely introduction. And yes, I work with a lot of clients who have arthritis and who are obese. Interestingly enough, we do have to, as much as Susan loves, and Susan and I discuss this a lot, Susan is pro Weight Watchers. I'm a little less pro Weight Watchers and a little more pro medical nutrition therapy. And I think we'll go into that in a little more detail today, why you would choose medical nutrition therapy for weight management, why it's so important. I think one of the things that studies tell us about weight management is that we're going to get more bang for our buck. People are going to lose more weight because of the changes they make in their diet than the changes they make in their level of physical activity. So it's really important for our patients with arthritis. Yes, we want them to be active for all the great reasons that they can't be active, but we don't want them to use that lack of physical activity or that inability to run marathons to say, well, I can't lose weight because I can't exercise. We really want to focus with them on what they're eating. But we want to make sure that our patients with arthritis are not already at a nutritional risk. So we did a study in Montreal where we looked at the longitudinal data from Canada, and we were able to see that arthritis, because of the reduced budget, often leads to poor food choices. We know many studies have indicated to us that people manage their pain with food, and people have a lot of pain and are depressed and feel their lives are limited will often say, well, food is my only pleasure that's left in life, so I'm just going to keep eating whatever I feel like. And people with arthritis often choose easily prepared foods that are also ultra processed, which means they're low usually in nutrients. And when you have obesity, you tend to already have nutritional deficiencies, vitamin D, vitamin B12, iron, not a lot of fiber. So because of this, we have to be very careful that our patients with arthritis are not already at a nutritional risk before we start putting them on some kind of reducing diet that might put them at an even greater nutritional risk. So I think that's the first thing that we want to remember. We also want to remember, we want to look at what treatments they might have upcoming. Somebody who's going to have surgery, potentially have surgery very soon, we might not want to suggest they go on a reducing diet because depending on the reducing diet they follow, that might actually set them up to delay wound. Low calories will set up delayed in wound healing and more risk of complications and infections. So we really need to look at globally. Yes, we know weight management is important, but we need to look at the timing of that for our patient's health and the timing of it and how they can actually manage it given their conditions. It's really important when, again, when we looked at the barriers that people would say they had. So when we actually eat, there's a lot of steps that go into eating. It's not just about eating. It's about what food I'm choosing. How did I get that food? How did I prepare that food? Where and when am I consuming it? And a whole myriad of other things that go along with that. And all those things can play a role in leading to excess weight. When you have arthritis, you can, what we see is the pain and fatigue of arthritis influences what food choices you're going to make. How are you going to get your groceries? How are you going to prepare them? How are you going to consume them? I have one client that has very bad osteoarthritis in her knees. And so she cannot stand for many hours to prepare. So she buys everything that she can. That is, she's going to open the box and put it in the oven, and it's going to be ready for her. So she has almost no time standing in the kitchen. And when we talk about no time standing in the kitchen, not to prepare, but part of preparation is also the cleanup. So you've also, got to do the dishes afterwards. So that is huge to think about when you're talking with your clients. What are they going to do with this? We know that the social support and the knowledge is really important. That's going to help clients make better food choices, get hold of their groceries, the preparation, everything about the social support makes a difference, and knowledge makes a huge difference. The interesting thing, and what is very, very, very important, is clients with arthritis get a lot of conflicting information about nutrition. And so because of that, sometimes they're very confused about what is the appropriate food choice. And when you get really confused about the appropriate food choice, then you just fall back on your default. At least I'm going to consume the food that I like eating, even if it's all bad for me. So what difference does it make? I'm just going to eat whatever I feel like. So we also asked people in this group, what would you look for in a weight loss program? And I think this is really important to think about when you're suggesting to your clients that they do go to a weight loss program. They want something that's flexible. So the time is flexible. They want something that's low cost. If people with arthritis already don't have a huge food budget, they certainly don't want to be spending $5,000 on a program. They want something that's interactive. They want hands-on activity. They want to try food. It's very important. When we did these, we had focus groups. And when we did this study, we offered people to come in for a meal that we prepared together. And they just loved being together with other people who had arthritis. And they loved getting all the information. And they enjoyed the meal together. They got a chance to try something new that they might not want to make at home because, now you have to go out and buy 16 different spices that you might never use again. Maybe you spent 2 hours cooking and you didn't even like it. So it was really nice to have the opportunity to try something on kind of like on somebody else's time and energy. They also enjoy having something to take home. So information to take home. So now this really sounds like they would really like an online program because that can be very flexible, can be lower in cost. They can have hands-on activities that they have to do. And of course, they can have all the information that they take home. What they don't like is something that's is too costly, something that's a super long time commitment. So they wouldn't want a 1 year or 2 year program. Don't like lectures, like participating. And last but not least, they really want to have scientific information. So they really did not like the idea of going to something that was not supported by science. They really wanted to make sure that whatever recommendations they were getting was based on something very airtight and scientific. So what do you tell your clients to eat? Well, very interesting. When we're looking at arthritis, Basically, the one diet that kind of comes up most often is a Mediterranean style diet. And I say a Mediterranean style diet, and I'm careful to use that word because I think we also know that all over the world, there are other culturally appropriate diets that will give people the same nutrients that are in the Mediterranean diet. They just choose different foods that are available in those regions. So somebody who is from a different part of the world and is used to eating, doesn't eat black olives, maybe you can find something in their culture that's going to be giving them the same nutrients, but we don't have to say, no, if you don't start eating black olives, none of this is going to work. I think we want to understand that our diet has got to be based on plenty of vegetables, fruits, whole grains. So it could be bread, it could be different cereals. Yes, potatoes are included. Beans, peas, lentils, nuts and seeds. So I think these are all really important foods. So it's basically a plant-based diet. We want to, yes, have olive oil as a primary source, but we could use any other oil that has the same or a similar fatty acid composition as olive oil. And so we see in the northern diet, the camelina oil gives pretty well the same results. Dairy products, particularly fermented dairy products. So in the Mediterranean diet, there's not a lot of milk drinking, but there is a significant amount of cheese eating and yogurt eating. Eggs, fish, and poultry are consumed, but maybe not in the ginormous amounts that we're used to in North America. And there's minimally processed foods. The diet is based on minimally processed foods. We're not having a lot of processed sweets, cakes, chips, whatever foods. And we're also not consuming a lot of red meat. And we're also in the Mediterranean diet, there's also not a lot of sweets. We also know that in the Mediterranean diet has been linked to, if we see the study that the low inflammatory diet is linked to weight loss, reduced markers of inflammation, and improved joint pain measures. But we also know the Mediterranean diet or the Mediterranean style of diet is linked to lower risk of heart disease. It's also linked to less mood disorders. And so it becomes a kind of a great path for most of our clients because they're going to see some improvement in different factors. So medical nutrition therapy is nutrition therapy for chronic disease, and obesity is a chronic disease. So ideally, we would like all your clients to be seen by a dietitian. Notice I said ideally because I know that is not the reality. Access to dietitian is often quite limited. But interesting, in the guidelines, and I wanted to go over what the Canadian guidelines for obesity suggest in terms of medical nutrition therapy. And that is that there's no one size diet that fits everyone. So we can't be looking for the right diet. We have to help our clients do what they can do. As Susan was saying, what are they able to do? If all they're able to do is say, I'm going to eat one extra portion of vegetable a day, then that's a great place to start. And if adding that extra portion of vegetable a day took away, filled them up a bit, and so now they ate a little less dessert, well, we've done a really good thing. How much weight are the guidelines suggesting people lose? Well, they're suggesting people with glucose intolerance lose between 5 and 7% of their weight. And with type 2 diabetes, they lose between 7 and 15% of their weight. And I think to echo what Susan said, that's really a lot. 5 to 7% is really a lot. And so you really want to encourage when your clients have achieved this amount, and I know they're going to be going, oh my God, but I still don't fit in that pink dress that I wore to the prom or my wedding dress, or I still don't look, I can't go back into my Speedo to wear on the beach. I think it's really important for you to focus down with them how important that 5% of weight loss is to their health, because they lose sight of that and they're only seeing that they're just not getting what the goal that they wanted. So I just wanted to kind of focus in on this client, our Michelle, who at 5'4" and 210 pounds had a BMI of 36. But if she loses 5% of her body weight, that's only going to be bringing her to about 10 pounds lost. So that's going to bring her to a BMI of 34. 7% is only bringing her to losing about 11.5 pounds. So her BMI is down to 33. And losing 15% of her body weight brings her total weight loss to about 32 pounds, which is a BMI of 31. So it's not ideal for us either to look at the body mass index and say, oh, let's go for a body mass index of 25 when somebody's got a body mass index of 36 or 40, because that's very difficult for them to attain and maintain. We're still looking, except for weight loss surgery, at basically 5 to 15% weight loss. So when we see Michelle and she's lost 5 or 7%, we get to say congratulations. Get to focus with her on all the improvements she's seen in her joint pain, her mood, her self-confidence, her sleep. We focus on how well she's eating and what she's doing, and is she enjoying her food choices, and what are we able to do to help her to make it easier for her to get that food on the table. We focus on the idea that she's at her best weight, which is the best weight she can be at, given the changes she can make in the time frame, given her other comorbidities and her other issues. So given the physical activity that she can do, given her sleep, given her stress, given all these other things, she's at the best weight she can be at for now. Doesn't mean she can't do something else later, but it means right now she's at the best place she can be. And then now we do have the option of discussing with Dr. Wharton or with our clients, okay, would you like to have pharmacotherapy? And I think that's a great new option that we have, but I think we always have to remember that our clients still have to eat well, and so we still need to help them to do that. Obesity Canada has some great resources for you, so you might want to go look and see. They have some great resources for physicians and helping them to talk to their patients and to open the conversation. And the guidelines really give a great idea of, again, some of the things you can do and how to talk to people. And lastly, here are some resources that you can suggest your clients read if they're into reading. And with that, I'll turn it over to Dr. Wharton.
Thank you, Kim. I hope everybody in the background is eating a healthy Mediterranean-style diet and haven't defaulted to the processed foods that we all have a tendency towards. I'm going to move on and introduce Sean now. Sean Wharton is really a national and international expert on obesity management. So Dr. Wharton has his doctorate in pharmacy and medicine that he earned at the University of Toronto. He's medical director of the Wharton Medical Clinic. And this is a community-based internal medicine weight management program and diabetes clinic. It's amazing. It's an evidence-based weight management clinic, which is with the medical expertise. He's an adjunct professor at McMaster University and York University. He's also, I'm pleased to say, academic staff here at Women's College Hospital and clinical staff at Hamilton Health Sciences. His research focuses on bariatric medicine and type 2 diabetes, and importantly, he is the co-lead author of the 2020 Canadian Obesity Guidelines that Kim just referenced. He's also, I think it's very important to say, he's involved in activism to achieve health equity in Canada. And he founded the Black Medical Students Association at University of Toronto in 2000. And this is now recognised as a really important mentorship organisation across Canada. So with that, I'm going to hand over to Sean, who's going to talk about pharmacological management of obesity, which is an area that I think is mysterious to a lot of us because there's been so many recent advances. Thanks, Sean.
Thank you very much, Paula. This is exciting to be here. I'm reaching you from Poland. I'm here for my friend's wedding, and my family are, my wife and my child are out on a tour of Gdańsk. So if anybody in the audience is from Poland, I'll tell you that your country is beautiful, sensational. Gdańsk is beautiful. So I've been asked to speak on the pharmacological approaches within obesity medicine. Here are my disclosures. And the objective is going to be to discuss the new advances in obesity medicine, primarily focusing on the pharmacological approach. But first, I want to say a little bit about the fact that if we look at these multiple medical conditions, we all know this. Osteoarthritis is at a higher risk. Every medical condition is at a higher risk with elevated weight. Type 2 diabetes is 90% in terms of the risk of people living with obesity. Now, what we'll start to see is that most type 2 diabetes drugs have weight management as part of it. So I want to start with a little bit about me here. This is my wife, who's a family doctor in Toronto. This is my baby. This is baby James. James was born September of 2020. And right next to us is the obesity guidelines, the Canadian obesity guidelines, which were launched August of 2020. So my two babies are here, and they both were born about the same time. Now, it took 62 authors and 3 years for us to complete the Canadian obesity guidelines, and I will say that it ended up being the #1 article in the CMAJ in 2020. We did not expect this. We didn't expect it to go across the world the way it has. Every country that we go to, they're adopting the Canadian obesity guidelines. We don't exactly know how this happened, but we're definitely pleased. In a year where COVID was the biggest deal, for some reason, the guidelines were up there. And I believe the big focus was because we focused on obesity, bias, and stigma. So it was great that Susan spoke about this, and this was the first chapter in the guidelines. If everybody online does not recognize and understand what bias is, which can be looked at as prejudice, and stigma, which is sometimes a stereotype, if they don't recognize that they have biases and they have stigmatic aspects of their own practice towards people living with obesity, then we can't start. There's no real starting point unless we start there. So why is everybody online, everyone who's listening here, has bias or negative attitudes towards people living with obesity? A study was done here looking at preschoolers, and they showed preschoolers pictures of a child living with obesity versus a child with a disability. The preschooler never chose the child with obesity as a playmate and started to attribute negative attributes to them, such as a lack of intelligence, etc. All the things Susan actually talked about. Now we are, and why? Because of the stereotype and the stigma and the cartoons that they watch and the things that they hear. So we are essentially the adults from those children, and patients living with obesity experience stigma from us, from our offices, from our office staff, and recognizing this is the important part. I don't expect anybody here to get rid of their bias. You can't, by the way. Can't get rid of your bias. Even if you're living with obesity, you're biased against people living with obesity. So what do you do when you have bias? You put things in practice to be able to deal with it, rules in place to be able to handle the fact that your practice has biases, your own mindset has biases. Somebody living with obesity walks into your office like, oh, I'm biased. How can I treat this person in an appropriate way that shows some compassion? And compassion is the important word here. To show compassion, you have to understand a little bit about where their bias is actually coming from. Okay, so what is weight stigma? Weight stigma is stereotypes. So if you think of it as a social stereotype, a misconception. So essentially, if everybody has a phone right now, if you Googled the word man, obesity, and images, tell me what images you end up finding. And this is on your phone, on your internet. These are all negative pictures, and the internet is filled with them. So if you see these pictures, that's a stereotype or a stigma, and that reinforces your bias that you either already have or didn't have and now you definitely have it. So that's what this is all about here. So this was the activity that I was talking about. So what I'd like most people to do, if you're doing a presentation or a talk, you're thinking about putting up an image, go to the Obesity Canada image bank. There's free images there of people living with obesity who are moving, who are smiling, or laughing. They're not stuffing food into their mouth. They're not looking depressed. They're not bent over. So people living with obesity are people. They are doctors, they're accountants, they're researchers or scientists, and we need to treat them as such. So as a result, the Canadian Obesity Guidelines determine the treatment algorithm after dealing with stigma and bias. The treatment algorithm is essentially the support of nutrition, dietary interventions, and physical activity. Supporting those two things. There's no weight loss without less calories. There's no weight loss without less calories. So you have to have that. The problem is that that's not easy to actually do over the long term, and no diets really work to actually do it. But what does work is having the three pillars that support lower calories. And that's psychological interventions such as CBT, ABT, pharmacological therapy, and bariatric surgery. Now, the reason, so I really like the psychological intervention piece, and Susan talked about this very nicely. The way that I really focus this is to understand love. Love is one of the most important words in obesity medicine. So a person, and what do I mean by love? Not that you are telling the patient that you love them. You're telling the patient that love is important in obesity medicine, that they need to love themselves now at 350 pounds, not when they get down to 225 pounds. They deserve love now from other people, from their spouse, at their highest weight, before they get down to their acceptable weight or weight that they want to actually be. So and they also need to understand that they should expect good treatment. And that's another part of love, that we, the community, love them enough to ensure that they are treated properly. They should expect that. And if it's not there, then that's a problem. They need to advocate for it. So psychological intervention is primarily understanding the aspects of love. Why? Because a lot of times we won't be able to treat them the exact way we want to. They won't always get to their goal. They may regain weight. But if we have love and compassion, they're in a much better space. So the medical nutrition therapy, as Kim nicely stated, there is no dietary intervention that decreases weight and keeps it off over the long term. Everybody needs to eat healthy, everybody. People at lower weights, medium weights, higher weights. If you have high blood pressure, we know the dietary intervention that works for high blood pressure. Again, medical, hypertension, nutrition, therapy, DASH diet. We know the diet that works for coronary artery disease, the Mediterranean diet. Again, these have very little to do with weight loss. And when Kim was talking about that, there's some weight loss that comes with the Mediterranean diet. That's in the initial phases, and it eventually ends up wearing off, as most dietary interventions do, if it's just dietary intervention. But what doesn't wear off is the idea of eating healthier food and making that nutrition improve your chronic condition, the chronic condition of coronary artery disease, of psoriatic arthritis, of osteoarthritis, and the inflammation, of hypertension. But there's no diet that keeps calories down over the long term in an effective, efficient manner. So we do not recommend any. So what's happened over the long term, I had to take the build out of this, is that the long-term analysis of lifestyle intervention is that people end up losing weight for the first 6 months or so. All interventions, you lose some weight, everybody's happy and giddy and they're losing weight, it's exciting, and then they regain weight after that. So there's a V-shaped curve here. So essentially that big star there was the fact that we've failed. We've been failing in obesity management forever, up until about 5 years ago. So over the past 5 to 10 years, we finally started to see success in obesity management. Prior to that, we did not have it. No matter what diet we used or what intervention or who was doing what and said that I've got this great program that does such and such. Nope, it all failed. So, and what we really needed was a scalable intervention, just like we needed a scalable intervention for multiple other chronic medical conditions. So it started out with some of these medications, and they failed. They caused bad things, and so eventually, so they were all stopped. But just because these failed, it didn't mean that we had to stop looking for scalable pharmacological interventions. It just meant that we had to try harder and do better. To try harder and to do better, we needed to understand the science of obesity, and that's what was missing all of those previous times. So if you keep trying a diet and exercise, or you recommend that to your patient as their primary way to keep their weight off over the long term, you've missed the science. You've missed the biological aspects of it. If you tell your patient to rub their knee with their osteo or rheumatoid arthritis, then you've missed the science. So that's kind of what we were doing when we told people to go on a diet and just work harder with it and do more activity in terms of weight loss. We missed it. So what is that science? It is genetic, first of all. It says genetic as your eye color is. And that the genetics live in your brain. They live in the hypothalamus, which are the easy parts to understand. The hypothalamus is physiologic hunger. Ghrelin makes you more hungry. All the other hormones make you less hungry. So clearly people living with obesity have too much ghrelin and too little of the other hormones, i.e. let's get a ghrelin blocker, or let's make some congeners of those other hormones. So when you're thinking pharmacological intervention and you're a scientist, you're thinking, let me look at the hypothalamus and make leptin, make PYY, make GLP-1. Let me block ghrelin. Also, now let's move over to the mesolimbic system. This is the God-given hedonic part of our brain that says overeat, or that says to do two things really, really well. And those two things are not going to be left to soft hormones. They're going to be left to intense hormones, dopamine, opioid, cannabinoid. Those two things for survival of any species is sex and eating. So sex and eating had to be intense. You have to have a drive for it. You have to have a want for it. You have to have a hunt for it, and it can't be stopped. And that is, and if you have a genetic predisposition within the mesolimbic system, again, genetics from your parents, from other people that are that causes an intensity within this part of the brain, then you're going to have an overdrive in our world of excess that will cause your obesity. Again, not understanding this means you can't treat obesity. The executive lobe is very helpful to shut off these things, but the executive lobe is exhaustive. It doesn't work a lot of the time. It works really well at 10 o'clock in the morning, doesn't work at 10 o'clock at night. And that's not your fault. That's the way the executive lobe works. It gets tired. That's why we go to sleep. And that's why in the evening are vulnerable times. Vulnerable times for what? Let's go back to the mesolimbic system. What are the two things? Vulnerable time for sex, which is a good thing in the evening to continue the species, and eating. Another good thing if you're going to live in a famine-driven world, which is what we had forever until now. Two main things: executive lobe can't control it well, particularly if there's a genetic predisposition to have that highway not working properly. Okay, so understanding that drove us towards understanding pharmacological intervention and why bariatric surgery works, again, in the brain. Orlistat was one of the first medications out there. It doesn't work, right? Because it doesn't work in the brain. It's approved for weight management in Canada, but nobody uses it. Why? Because it doesn't work. It was an error. All the other medications are brain-related medications that work in the hypothalamus, increasing one of those hormones that I said is needed to go up. People living with obesity have low levels of PYY, leptin, GLP-1. Let's increase it. And also working in the mesolimbic system, being able to deal with that hedonic aspect of eating. Remember, the hedonic aspect of eating isn't wrong. It's just if it's overly intense due to your genetics, then your drive to eat will be well beyond any dietary or exercise intervention you could ever do. The emerging medications are super important here, because we're moving away from injectables, moving towards orals. Orals like multiple other chronic diseases. Think about hypertension, think about hyperlipidemia. And the oral peptides are big molecules, so they're harder to take and deal with, taken in the morning, et cetera, et cetera. Oral non-peptides, smaller molecules, they are going to be the big splash. I highlighted this because it's a big deal. Oral non-peptides. So here are the 3 generations of weight management medications. So we have phase 1, which gave us about an 8 to 10% decrease in weight. So that's liraglutide, the naltrexone bupropion combination. Phase 2, 15%. So, and in Kim's talk, we're talking about how much weight you need to lose. Bottom line is you need to lose a lot of weight. If you're living with obesity, you need a lot of weight loss. Why? Because people regain weight. Even these systems here, which are very good, there's redundant mechanisms that push the weight back up. Trying to keep off 5% of your weight down, which is a very nice amount of weight, means 10, 15%, because you're going to float back up. So you want to try to give yourself as much buffer as possible. More is better. Phase 2 is the 15% that we have, the injectable and the oral semaglutide. In phase 3, we're getting to 20% in the tirzepatide, which is a dual agonist. So we saw here with liraglutide being introduced in around 2016. So remember, this world of weight management is new. And this was the first time in Canada that we saw some relief from the people who are having so much brain activity in terms of trying their absolute best and failing when it comes to keeping weight off. Not failing when it came to life, but failing when it came to keeping weight off, because they didn't have an intervention. This is like life of psoriatic and rheumatoid arthritis before the biologics. So liraglutide comes along. We're seeing a placebo arm of about 3 to 5%. That placebo arm, 2 to 3%. Every placebo arm should be 2 to 3%. If it's more than 2 to 3%, that's not a good study. So we're at about the intervention arm showing about a 9% decrease in weight. Very positive. The naltrexone bupropion, again, working in a combination of places, hypothalamus and the mesolimbic system. Again, the placebo arm looking normal, about a 2% decrease in weight. And then the intervention arm, about an 8% decrease in weight. Again, very positive, way better than the best that anyone else can do, which is about 3%, 2 to 3%. The question is can we keep this long term? So the idea is anyone can do weight loss, right? To give somebody some liquid drinks for a little while. Everybody loses weight, but can anyone keep it off? So all we're talking about here right now, this entire presentation, is not really weight loss. It's the ability to keep weight off over the long term. The ability to keep weight off over the long term starts with how you did the weight loss in the first place. So this is a 2-year trial, and this is the step 5. So I'm one of the authors in this, and we were able to, over 2 years, show that semaglutide 2.4 kept that 15% off. 15% was a big number for us, but keeping it off was even bigger. So, and why is 15% so important? Because that's the average. It means that 1/3 of patients got to greater than 20% weight loss. That's bariatric surgery territory. 1/3 of patients got to greater than 20% weight loss, bariatric surgery territory. This is a scalable intervention. And so now, of course, with weight loss, what do we see? We see all the cardiometabolic factors getting better. We expect that. If blood pressure didn't go down, it wouldn't be a weight loss trial. So the big deal isn't the blood pressure going down. The big deal is it's staying down. It stays down because the weight stays down. Main side effect, nausea, and GI side effects. Can we get past that? That's the big issue. No real problematic side effects, just this the GI issues. Getting past it is important. And that's the titration schedule. Enter now the bigger guns. So we published this in New England last year. This was a big deal. This was exciting. At ADA, I was able to present with this, and let me tell you, it was great, because here we see that a dual agonist was able to get weight down over 20%. So we're at 22% weight loss. 22% weight loss as an average means that, nope, I didn't have that slide. it means that a third of the patients got to greater than 25% weight loss. Some were at 30% weight loss. Again, well into bariatric surgery territory. Now, the idea here is, again, keeping the weight off over the longer term. My last few slides here is really about what's this all about, losing this weight. As an internist, I want people to lose the weight so they don't die of a heart attack, or they have it a lot later, that their type 2 diabetes doesn't happen at all or has a significant benefit. So, but the big deal for coverage will be cardiovascular outcome, less people dying from cardiovascular events. Can we achieve that? Well, previously we failed horribly because we were using interventions like lifestyle intervention only that caused the weight to go down initially. Look at that 1 year weight loss, like who can't lose weight, right? Being told to eat less and come every single week in a free program. Of course, you're going to lose weight, but what's going to happen over the rest of the years? You're going to regain the weight. Your A1C goes down nicely in the first year, and then it starts to go back up. So those are the number of people who their diabetes remission end up coming back. So you can see that by year 4, we're having a lot of people where they're no longer in diabetes remission. The return of the metabolic conditions equals no cardiovascular benefit. This trial was a failure. It was a cardiovascular. The look ahead is a cardiovascular trial with dietary interventions. It failed to show any benefit in hard mortality and morbidity outcomes. So now we have the new medications that can keep weight off over the longer term. So we're trying again. Here we've got some HFpEF studies that are going to be cardiac studies, but here are the CVOT. So the SELECT trial is going to be the largest CVOT outcome trial ever done in patients without type 2 diabetes, just looking at weight management. It's going to be announced later this year, 17,500 patients. Will we make it? I don't know. I hope so, but we are, with all the positive outcomes that we've seen and the longevity of it, again, the longevity, we may be able to see it. Right above the SELECT trial, I didn't put a red circle on it, I should have, semaglutide in knee osteoarthritis. Of course, it's excellent. There's a trial in it. We'll be looking at the inflammatory markers also. Again, so this is the SELECT trial here, and then also tirzepatide will have a CVOT outcome trial also. Again, hard outcomes is what will be important for coverage. I do not believe that hard outcomes of CVOT is what is needed for us to prescribe these medications. If SELECT or SURMOUNT MMO fail to show hard cardiovascular outcomes, there's still significant benefit from keeping weight down over the longer term, and everybody knows that. So the last part is that when you stop the medication, the weight comes back, and it should come back. When you stop the biologic, should the inflammation come back? When you stop your hypertensive medication, should it come back? Absolutely, because of the biology. If we don't believe the biology, then we would believe that, oh, I got to my stable weight and I'll stop the medication, everything's going to be fine because I'll just keep eating well. Well, you're only eating well because of the medication, because of the biology, the counter-regulatory effects. So God, whoever she is, designed the body to have counter-regulatory effects to losing weight. So at that lowest weight that the person has, where they're living well, they're enjoying their life, they're taking their injection once every week, they have tons of counter-regulatory effects happening, but they're being held off by the medication. As soon as the medication stops, all those counter-regulatory effects are now there, and the weight will go back up. And what else is going to go back up? All the blood pressure and the hemoglobin A1C. As a result, you're not going to get the cardiovascular outcome measure, and it's a failure. So that's what we're looking at is not stopping the medication. These are long-term, so don't stop me now. In conclusion, obesity bias, stigma, and discrimination should be recognized. We need to become as compassionate as we possibly can, and that involves asking the patient, can we talk about weight management? Can we talk about interventions above and beyond lifestyle interventions? And if that's okay, you can move forward. If it's not okay, don't move forward with it. Still be kind to them. Obesity is neuroscience and genes. It's a genetic disease. Obesity pharmacotherapy is effective and scalable, and treatment has to be maintained to achieve long-lasting results. Thanks a lot for your time.
Thank you, Sean. Such a fascinating area, the neurobiology, the genetics, as we've heard, the behavioural component. So I have lots of questions. I will ask the other speakers. So Susan and Kim and Lihi, could you turn on your cameras and your microphones, and we will commence the panel discussion. So just, there was one comment in the chat that I thought I'd address just straight up. Well, there's two actually. One was about the Weight Watchers. And so thank you, Sean, for jumping in there and explaining that Weight Watchers has moved from being in person to virtual, using a virtual platform similar to what we're doing here today, I guess, so that it is still an available resource, but using technology to, sounds like that's a more effective way of engaging the clients. There is a question about whether or not we should be using BMI regarding determining obesity. And I know that this has been a subject of debate. Does anybody want to jump in and give us an idea of what we should be doing when it comes to, you know, trying to provide objective measurement that we can track for weight and weight loss, or should we not be using anything? Anybody got any ideas?
Well, we have lots of ideas as Canadian Obesity Society, for absolute sure. We really moved away from talking about size. So BMI just tells us about size, doesn't tell us about the comorbidity the person has or the impairment of health. So if you're an African-American woman and you have a BMI of 32 and you don't have any medical condition, your knees are perfect, you don't have any type of diabetes, you shouldn't be called somebody living with obesity. You should be called beautiful. And that's what we need to try to remember, that the BMI cutoffs, BMI is just a number, just like height and weight is a number, right? It's just a number calculation. Well, so BMI isn't the problem. The BMI cutoffs are the problem. They were developed with Ansel Keys running a lot of the show, and Adolphe Quetelet, a Belgian psychologist in 1850, to look at white European males. So that's who they define. The cutoffs define white European males, not women. That's half of the world, not ethnic groups.
More than half.
That's right. That's more than half, etc. So you can see where the challenges are. So we don't like using BMI. It's easy to use. There's some population aspects that are okay with it. But in general, if you're looking at a person, look at their health, do their blood pressure, do their blood work, look at their knees, talk to them about their psychological issues. We ask people not to do their weight. At the clinic, we beg them, don't weigh yourself. Just when we talk to you, we'll ask you, how are you? How are you feeling? Do you feel that you're on track with your behaviors, with your the things that you are doing, not your weight?
So if I can just comment on that, though, and I'm going to put my researcher hat on for a moment. Sean, I welcome and embrace everything that you're saying, but I can tell you that when we've tried to do research and work, when we go into charts, we find nothing. We find no information whatsoever. We never find a weight. We don't find height. And so that becomes really, really challenging. So, you know, I think we need to embrace this movement away from a focus on the number on the scale. On the other hand, from my years of working in eating disorders, I can tell you that nothing leads to a 100-pound weight gain faster than somebody who refuses to get on the scale and never. So we got to find a balance. You got to find a balance, as with all things here.
I think
that's
true.
There's maybe go ahead, yeah, Kim.
And I wanted to say that the only time I ever use BMI is when I'm talking to doctors. I never use it with my patients, but all the doctors seem really, really keen about using BMI, and they seem to understand that number, and they seem to be able to relate to it. So when I'm talking with my patients, I focus on what habits have you changed? How are you feeling? You know, habits you can take charge of, you can do something about. You can't control your weight no matter what you do. So you have to take charge of what you can take charge of and manage those things. So that's what I talk about with my clients.
Beautiful, Cameron. That's what we try to emphasize is you can't control your weight. You control your behaviors, and you can control how much you feel loved and where you're getting love from, and the attention. The BMI is for research. So we do need to have a height and a weight in the patient's chart. So that's at the beginning. And afterwards, in terms of how a patient's doing, we don't really need it afterwards. We don't need it clinically. We need it for research. We need it for research. But that's a research hat on. But for the patient, we don't actually need it and in a clinical sense. Most of my patients will do it. 95% of my patients refuse to not do a weight. We don't push it, of course. And they all want to weight. So we're all part of this biased world of that weight matters and the BMI matters. If you're an African-American woman with a BMI 32 and you're telling me that you're in class 1 obesity and that's a problem, you need to get out of it, then I've got a problem with that. I've got to change that mindset and tell that person that they're beautiful and they need to not pay attention to a BMI that was not defined for them.
Yeah, and Helen Batty has asked in the chat about waist circumference, and I'm sure that there's issues with ethnicity. It's based on white, middle-aged waist and hip circumference measurements as well, where someone, a black woman or someone who's Southeast Asian, they're not necessarily we need to have corrected weights and, sorry, not weights, waist and hip measurements presumably as well, I would think.
It is better. So the waist circumference is better. It's just harder to actually do. So if you're the waist to hip ratio, especially, I mean, if you've got thinner hips and you've got a bigger belly, then things are likely going to start heading south, regardless of whether your BMI is 24 or your BMI is 34. So the waist circumference does work out a little bit better, but as a ratio, not necessarily always as just a waist circumference, because then we have to do the adjustments, obviously, but yeah, it does tell us sometimes a little bit more, but it's harder to do. BMI is super easy, and you can get population values on it, and the waist circumference, you get to the variation, and people just don't know how to do it. They don't know where to actually measure it. So that's our challenge.
Yeah, it's one of those things where people talk about doing it, but they don't actually know how to technically do it, myself included. And we're just being reminded by Margaret Furman that we do need to do weight in other situations, such as obviously heart failure, where it's actually every day you need to have that weight to be monitoring volume status. So it serves a purpose.
Right. Not for the adiposity, for the heart failure. Awesome.
Yeah. While we're talking about the stigma side of things, I'd like to just have a look at what Jeannie Zhao has written here, and I think it's an interesting question. And I'm going to read it out so everybody's aware of what we're being asked. There's a lot of conversation on social media about body positivity, attempting to raise awareness of internal biases of weight. Have you found that social media, especially TikTok, has impacted the way weight management conversations in healthcare are perceived, both in patients and healthcare providers? Has it been positive or negative? And I wanted to just add on to that, where I was wondering whether our implicit bias against patients who are overweight, obese, feeds into the fact that we're all taught to kind of be ashamed of our bodies. Everybody's kind of being told, or has been told, that we're overweight, and how much, if we're not even body positive about ourselves, how we feel about people who we then see that have the weight issues. I sort of feel like that's a bit of that's built into that question. Has that improved with social media or gotten worse? Anyone got any idea? Kim, I know you work a lot in the world of radio and TV.
Yeah, I haven't seen a huge, amazing improvement. There's a little tiny improvement, but I haven't seen a huge improvement. And of course, it also depends a little bit where you look, right? If you there are whole areas of the internet and TikTok and social media that are devoted to how anorexic you can be. And so if you go there and you spend all your time there, you're going to get those messages. And if you go to the body positivity pages, you're going to get those messages. Some of the mainstream media is getting to be a little bit better, but it's, now you're starting to see, in some ads, models of all shapes and sizes. but you know, you still see the plus size clothes store, right? It's not really that body positive when you have to go shop somewhere else at a different store at the back of the mall that doesn't necessarily have the clothes and the nicest material and the whatever, you know, or you have to go to the special. I have a brother-in-law who has to go to the big and tall store. He gave up and just gets everything made because it's like ridiculous.
Yeah.
Can't even get to the store, never mind. So we're not there yet. We're better, but we're not there yet.
I would completely agree with Kim. I think that someone who has had a very positive influence most recently is Lizzo. She has, I think she has changed the conversation in really, really important ways. And we need so much more of this. I was smiling when you were talking a little bit earlier, Sean, because my training was in inner city Philadelphia and inner city Baltimore. And so many of my patients that we were working with in the weight loss program were African-American women. And they were the first to tell me, I know you think that 120 pounds would be right for me, which I never did. But, you know, I love my body at 180. I love the way I look. I love the way I feel. So all of this body positivity, there are really important messages that I just continue to champion and hope we hear much, much more of.
Excellent. Yep. I would also agree with both of you that the conversation needs to be had. It's getting better. There's different facets and components of it, and the health at every size movement, the body positivity from the Dove ads and Lizzo being very positive. I think that's been a real help. And there has been controversy between treatment options and like the lack of real understanding. If somebody's living with obesity, which means that they have an impairment to health, they have type 2 diabetes, they have high blood pressure, then treatment would be needed. Somebody's not living with obesity, they just live in a larger body size, then they don't need treatment. They need just what everyone else needs, which is healthy eating, activity, to be loved, to be cared for. And that is where there should not be a disconnect. The word obesity is for healthcare providers, for researchers, for us to talk about, and the word weight and beautiful is for people.
I would like to think that social media could have something positive because we hear so many negative effects, but you sort of think about the demand for Ozempic for people who are not even living with obesity as a chronic disease without the metabolic adverse effects. That's not very body positive. And I'm sure that it depends on which algorithm somebody's locked into as to what actually is being fed to them and how that affects their self-perception. Very interesting.
Yeah. It has been a challenge for us. Our field, our research and academic field, I mean, I've been working this for years and did a lot of the research. It was hijacked by Elon Musk and Kim Kardashian with the Ozempic world of so it's been a real challenge for us to navigate the people who are not living with obesity using it for cosmetic reasons. So either we understand it, we push against it, we understand it, or we embrace it. And so one of those three, and I don't think we absolutely need to push against it because I'm not so sure it may end up coming into the aesthetic field the way Botox is used for migraines. It was used for a strabismus in the eye. Now it's got an FDA approval for a cosmetic component. So will that be what we'll see eventually? I don't know. I'm not an aesthetic doctor. I'm over here where we're doing internal medicine and trying to stop heart failure. So that is, but the hijacking has been a challenge.
Can I ask, you mentioned Kim Kardashian as a person who is living with psoriasis and psoriatic arthritis. I find it interesting as going back to the rheumatology setting, for us as rheumatologists, managing obesity is quite difficult with all of the competing challenges and comorbidities that you mentioned, depression, and there are many others. What role can we play, considering all the difficulties, accessing programs like yours or others that manage obesity, the difficulty in, should we start prescribing Ozempic or other medications to our patients, who should take ownership of the management of obesity?
Yeah, excellent. I think you would start with saying that the way that we managed weight in the past was wrong. And so the grand the apology is there, the grand apology that all doctors were doing it wrong, all clinicians were doing it wrong. We now know how to do it right. So now the patient's like, oh, there's a right way to do this. Great. Doesn't mean that it's coming from you as the rheumatologist. You're going to be prescribing it, but at least now they're hearing, okay, there's a right way to do this. And you're like, absolutely, there's a right way to do this. I can introduce you to some places and some ways that we can do this. Looking at Weight Watchers, they're a good dietary program. So I agree with Susan. I like Weight Watchers as a commercial-based program. They have the most evidence, and they're good dietary components. But they're not going to keep your weight down over the longer term. This is going to be pharmacological intervention or bariatric surgery. Of course, bariatric surgery is intense. It's for people living with morbid obesity. It's got risk. Pharmacological intervention is scalable. It's what we need to use. Just like if you're not on a biologic agent and you have severe rheumatoid arthritis or psoriatic arthritis, then I don't know where you are. You're not in a first world country. So again, this is what the intervention needs to be. And you can say that I can start this for you if you'd like me to, but I strongly recommend your family doctor do it because it's a long-term treatment. They need to titrate it appropriately. They need to watch for your side effects. They need to look at when you stop it because you went to Greece for a couple of weeks and how do you restart it? You may not want to always do that. Their GP is responsible for it the same way they're responsible for their mild antidepressants, the way a psychiatrist isn't, right? I mean, if the psychiatrists were responsible for all antidepressants in Canada, we'd be in trouble. So this is where it has to land in the family doctor's hands, but you as the specialist can inform the patient and direct them, and you're taking the lid off a bit so that the family doctor, when they take the lid off totally and say, here's the medication, you should advocate for coverage, you should take it, they can now say, as recommended by Dr. Eder, she clearly said that this is going to be beneficial. I believe it will be too. Would you like to start this?
You know, one of the things, though, I realize that we haven't talked about that I would like us to touch on is the notion of prevention, and which is catching, you know, we're talking about strategies to deal with severely overweight people for the most part here. That's who the medications are indicated for and going to be most effective for. But, you know, the average person is still continuing to gain about 30 pounds between the age of 30 and 60. We have this slow creep as we become more and more sedentary. And there's a lot of room for the very positive effects that the conversations can have on just the importance of healthy lifestyles. We're, as with everything, we're so much further ahead if we can, whatever we can work towards preventing, as opposed to trying to play the catch up, because the treatment of obesity, as we've been discussing, is very complex. It's very costly. It's very resource intensive.
Excellent point, Susan. And I'm going to, because this is a favorite part of what we deal with. We did not call the obesity guidelines the prevention guidelines. The previous one was in 2007. That was a mistake. The authors made a mistake because there's no prevention. And currently, we couldn't do a guideline on prevention because there's no prevention. There's no prevention for obesity at the current state. Not eating better, not exercising more, not having better psychological intervention, not having family therapy. There's nothing. Not putting on there's more calories at in this drink at McDonald's versus another drink, or even huge school programs for more activity. Absolutely nothing, which is frustrating, right? How can this be? So what we may be seeing is that for polygenic obesity, you have a parent who's living with a BMI of 40, another parent with 40, and a bunch. We may be looking at early intervention in terms of pharmacotherapy with a child. So we know that the medication's already indicated for age 12 and up. These are injectables once every week. We're going to be, that's why the discussion about the oral non-peptides is so important, because people living with polygenic obesity with both parents and other people, family members, are going to be living with obesity and disease. That they will be the people that we can significantly intervene on. Healthy eating and more activity and all those interventions will make healthier people, but it won't stop obesity. We currently have nothing to stop obesity.
I might push back a little bit on that with you, Sean. Our rates of obesity have escalated dramatically. There has been a lot of work trying to understand what the heck happened in the 70s, that everything shifted. We have some ideas about high fructose corn syrup, the pervasiveness of it, the sedentarism that has come to characterize everybody's lifestyle. So I hear your message loud and clear. And again, what you're saying is so important. And I think it's especially important for the segment of the population for whom this is an inevitability. But I do think that on a much broader scale, there are many more people who, if we can get them into healthy habits and retaining healthy habits earlier on, we're going to blunt the effects of just the pervasiveness that we see right now. There's no downside to.
There's zero downside to it. There's only upside. There's only upside, but the idea is that there's no prevention from that intervention. So but there's health from it. There's togetherness. There's community. There's the recognition that that when Governor Cuomo back in the day put in the fact that we should have calories on banners on wherever you're going to a restaurant. David Ellison, one of the smartest guys on the planet, who was head of the Obesity Society, said that that's not going to decrease obesity. Guess what? He got fired from the president of the Obesity Society. He was right. He was not even kind of right. He was completely right. But was that a good message for him to send? No. That was a dumb thing to do, to say that, because it's still a good social intervention. So social interventions of activity and exercise and love and preventative measures from living in an unhealthy fashion are hugely important. They don't stop obesity. And that's been our challenge, is that we haven't figured it out, because we're not going to stop cell phones. We're not going to stop air conditioning. We're not going to stop running water. Those are the things that cause it, not the high fructose corn syrup. Although the high fructose corn syrup was also part of the progression. Every progressive step in society that makes us more efficient increases obesity rates. And there's no stopping any progression within society. High fructose corn syrup was a part of the progression. So getting rid of it is not going to change things. There's going to be something else, and another progression. So that's our challenge. I don't know how to fix it, which is why we have these discussions.
I think
very interesting discussion. Sorry, Kim.
I just want to say, it just goes back to everybody has the right and needs their body to be functioning in its optimal capacity. And to do that, the body needs sleep, it needs good nutrition, it needs exercise, and it needs good psychological care. And love, care. So we need to make sure that our clients are getting that. And if that has an impact on their weight, oh, great. But it's going to make them healthier. And that's really what our goal is.
And maybe we can think about weight a bit like blood pressure, where it's a bit of a surrogate marker. It's the background inflammation is really concerning. That's what's going to contribute to the osteoarthritis and the worsening of OA and inflammatory rheumatic disorders and blood pressure. And so in the blood pressure world, we know lowering population blood pressure just by a few millimeters of mercury actually has benefits when you're looking at cardiovascular outcomes. I'm sure that if we can, through preventative measures and good eating, and as we heard, a Mediterranean-like diet, reduce inflammation, that's going to have benefits in the cardio room world, just like we would be seeing in other areas of chronic disease. I just want to finish off.
Yeah, I think we're going to have healthier. I think we're going to have healthier people in larger body sizes. I think that's what we need to have. Healthier, beautiful people like Lizzo in larger body sizes that eat healthy, that move. That's what I want to see.
I just want to finish off with just from the pharmacotherapy area, because it's very important for the family docs to feel comfortable with this. There's a question about, can you reduce the dose of, for example, the GLP-1 agonists? I presume you're going to see some weight increase, Sean, and I guess people are going to be on these for life. So can you answer the question about reducing dose?
Can you decrease the dose? Maybe, right? I mean, I think everyone is a individual. So a person gets to weight that they want to be at, which is rare. No, everyone wants more. So, but let's just say they actually do. Then you can decrease the dose, you can intermittently dose, you can give it a shot, you can do whatever the person wants to actually do. The evidence is that as we get older, our mitochondria dies a little bit. So it's harder and harder to keep on losing weight as we get older. So it's going to be harder to keep that weight off. So therefore, the likelihood is that whatever maintenance weight you get to, and that dose is the dose that is your maintenance dose, not a lower dose, but that dose. That's the likelihood. But we've not done the research to show, can you go down to a lower dose and keep maintaining? I'm not sure that we can, but I think that it's worth a try in every patient.
It reminds me so much of the controversies in rheumatology about what we do with the biologics and for whom and when and how. And
yeah, a lot of unanswered questions. So stay tuned. I think this is an important topic that we need to keep revisiting in the cardio room field. There is this emerging evidence about dietary composition and the effect on inflammation, and across the board what that means for morbidity from the inflammatory and non-inflammatory rheumatic disorders, and also the associated comorbidities. So this has been a really good session. I really appreciate everybody's contribution. Lots of comments that have been coming into the chat, so a lot of engagement from the participants. So with that, thank you, everybody.
Good afternoon, everyone, and welcome back to the last session of the Cardio-Rheumatology Symposium. We had a very live discussions in the morning sessions, and I'm sure we'll have very live discussion in this last session, where we have a wonderful local and international speakers that will be talking about different topics. They'll be talking about exercise in patients with rheumatic diseases, about plaquenil-induced cardiomyopathy and cardio-rheumatology. We'll start with the first session. So these will be back-to-back talks. So please think about questions, put them in the chat box. We'll be monitoring the chat box, and we'll be addressing the questions at the end during the panel discussion. So the first session will be on exercise in the context of rheumatic diseases, and it's my great pleasure to introduce the first speaker, Dr. Lauren King. Dr. King is a rising star in the field of osteoarthritis, both nationally and internationally. She's a staff rheumatologist at St. Mike's Hospital in Toronto and an osteoarthritis clinical researcher. She completed a PhD in clinical epidemiology and healthcare research at the University of Toronto, and her research is supported by grants from the CIHR, as well as a Philipson Scholar in Clinician Scientist Training Program. And her research focuses on improving clinical care in patients with osteoarthritis, including identifying ways to optimize physical activity. So, Lauren, the floor is yours.
Thank you very much. It's really exciting to be able to speak today. And I'm going to start off with more of the theoretical perspectives on exercise in the context of rheumatic disease. And I'm so delighted to be presenting alongside my colleague, Angelo, who's going to go through a bit more of the practical elements. I have no relationships with commercial entities. I should say I do hold some strong biases towards or in favor of exercise. So here are the learning objectives. On the slide, we're going to discuss a bit more about the role of exercise in the management of rheumatic and musculoskeletal diseases, some of the barriers and enablers in our patients, and some approaches to consider around prescribing and monitoring of exercise. And for the purpose of this talk, I'm going to refer, when I speak of rheumatic disease, I'm going to be referring to both inflammatory arthritis and osteoarthritis. So here's the outline. And I'll get started with describing the role that exercise can play in our patients with rheumatic disease. So I want to first be clear around some terminology. I was asked to speak about exercise in rheumatic disease, but I'm also going to be using the word physical activity. And physical activity and exercise are not the same thing. So physical activity is a broad term defined as any bodily movement produced by skeletal muscles that requires energy expenditure. So it's anything in your day. It could be going up and down the stairs when you're doing laundry. That's physical activity. And exercise is a subcategory of physical activity that's planned and structured and repetitive and purposefully focused on improving or maintaining physical fitness. So kind of like that run that I did this morning before starting work. And both are important when it comes to our patients, and we'll get into this. I think we can appreciate there are many targets and potential benefits of physical activity. I'm going to split these into both disease-specific and benefits for whole person health. And over the next few slides, I'm going to give you or reinforce the so what about the role of exercise and physical activity in our patients, thinking about these broad categories. A systematic review and meta-analysis published in the British Journal of Sport Medicine that included 26 randomized clinical trials with about 1,300 participants, and these included people with rheumatoid arthritis and spondyloarthritis, showed a benefit of exercise on disease outcomes with small to moderate effect sizes, and I've listed effect sizes as standardized mean differences on the slide. There was high to moderate quality evidence for a small beneficial effect of exercise on disease activity scores and joint damage. There was moderate quality evidence for a small beneficial effect on ESR, although no effect found for CRP. And there was a small to moderate effect seen on symptoms of rheumatic disease. Aerobic and resistance exercise programs were both included in most exercise interventions for a duration of 12 weeks. So based on these data, these don't suggest, I'm not advocating for exercise being the primary treatment for inflammatory rheumatic disease, but there's a signal that it might be an important adjunct to pharmacotherapy and all the other aspects of comprehensive care. I want to discuss two Cochrane reviews in osteoarthritis, so for the knee and the hip. So for knee OA, results from 44 trials show that exercise reduces pain and functional impairment with moderate effect sizes. So compared to being a control group, those who were in exercise groups improved their pain and physical function by the equivalent of about 10 points out of 100. And there was also some evidence for a small effect on quality of life. For hip OA, there were fewer trials. High quality evidence from 9 trials showed that exercise reduced pain and functional impairment with a small effect size. So this would be something like a difference of 8 out of 100 between those who had who were in the exercise group compared to the control group. There were only 3 small trials looking at quality of life. Overall, there was low quality of evidence for no benefit of exercise and quality of life in those with hip OA. So there's been a big chunk of data that's accumulated to show the benefit of exercise over no exercise in people living with osteoarthritis. Although, the magnitude of the benefit isn't huge, in absence of any disease-modifying OA drugs, we need to harness all of the benefits we can get to try to improve people's symptoms in the lives of people with osteoarthritis. Hot off the press is a study just published this week. It was an individual participant data meta-analysis focusing on the factors that might make someone with OA who engages in an exercise program more or less likely to improve. 2 key points from this study. One, again, we see the evidence of this positive effect of exercise on pain and physical function compared to non-exercising controls. The effect here was a bit smaller though. So on average, participants in the exercise group reported pain scores at the end of the intervention. They were only about 5 to 6 out of 100 points better compared to the non-exercise controls. The second point is that the study found 2 moderators of the effect of exercise, so baseline pain and baseline physical function. Those with higher levels of osteoarthritis-related pain, so worse pain and worse disability, benefited more from exercise, and so these might be particularly important people to target. Okay, so why do we see these disease benefits of exercise in both inflammatory rheumatic disease in addition to osteoarthritis? And so we don't know the exact mechanism by which exercise exerts its effects in any given individual, but there are likely multiple mechanisms at play, and we can make some hypotheses about what these are. We can view rheumatic disease through a biopsychosocial lens where we can think about the biological, psychological, and social factors and their complex interactions, potential biological effects, including improving the strength of the muscles that surround the joint and support the joint, in addition to systemic anti-inflammatory effects of exercise. In terms of psychological and social benefits, exercise can help address low mood, poor sleep quality, and fatigue. We know frequently co-occur in people who live with rheumatic disease, and these things impact the illness experience. And then finally, exercise can offer an important avenue for social connection and support, factors that are associated with better chronic disease outcomes. And then finally, I want to underscore the role of exercise in restoring physical function. And this can be viewed sometimes separate from disease control. So in, say, someone with rheumatoid arthritis, if there's been a long time to diagnosis and perhaps to start a therapy, hopefully not, but in this example here, there may be some substantial deconditioning that's occurred. So even when the RA is in remission with no tender joints and no swollen joints, rehabilitation is crucial to be able to improve general conditioning and restore function. So I now want to review some of the benefits around exercise for whole person health. I think this provides this added rationale when we counsel our patients. So not only will exercise be helpful for your arthritis, there's actually a whole host of added benefits, X, Y, and Z. And this is really important since our patients with rheumatic disease are already at a high risk of adverse health outcomes like cardiovascular disease and all-cause mortality compared to people without arthritis. Physical activity, even at moderate levels, can substantially lower the risk of all-cause mortality. This figure is from a meta-analysis of 15 prospective cohort studies that included about 50,000 adults and more than 3,000 deaths. The hazard ratio for all-cause mortality is on the vertical axis and the steps per day on the horizontal axis, and the thick lines indicate the hazard ratio estimates, and the shaded areas show the 95% confidence intervals, and this is for individuals 60 and over in the blue, and those under 60 in that kind of orange color, compared to the reference values. And so this was the median of the lowest quartiles of physical activity. Taking more steps per day was associated with progressively lower risk of all-cause mortality, and it was up to a level that varied by age. So in those 60 years and older, so in the blue, there was a progressively lower risk of mortality until about 6,000 to 8,000 steps per day, and in those under 60, up until about 8,000 to 10,000 steps per day. So these findings show the mortality benefits occur at levels less than that kind of popular 10,000 steps per day. And for those who are inactive, every little bit matters. And in fact, this greatest return on investment is going from being inactive to some activity. You can see that's the steepest part of the curve. So how much does the intensity of exercise matters? And this is an important question. Intensity probably does matter to some degree, although probably not as much as volume, just getting in any activity, doing something. So for example, in a large cohort study among people who met physical activity guidelines of 150 minutes of moderate to vigorous physical activity per week, the more vigorous physical activity you did was associated with lower all-cause mortality. So those performing over half of their physical activity as vigorous physical activity had about a 17% lower risk of all-cause mortality compared to those doing no vigorous activity. Results have generally been similar for associations between physical activity and exercise and risk of cardiovascular events. And that analysis published in Circulation found that taking about 6,000 to 9,000 steps per day was associated with a 40 to 50% risk of cardiovascular events compared to people taking 2,000 steps per day, so those who are quite sedentary. There have been associations between physical activity and exercise and lower risk of a whole host of other conditions and complications, but obviously too much to go through for a short talk. So in summary, exercise has an important role as this adjunct treatment in inflammatory arthritis and as a primary therapy in osteoarthritis. It's recommended as a core treatment in our guidelines, and to improve control of the rheumatic disease. But also we talked about some of the benefits that exercise has for overall whole person health. Okay, so I want to just describe some of the barriers and enablers to exercise and physical activity that our patients can encounter. So I've just told you about all these wonderful benefits of exercise, but what proportion of our patients are actually engaging in physical activity and exercise? And it's pretty low, and it can be really challenging to accurately measure physical activity, but it's less than half of our patients, and maybe even less than a quarter of our patients. In 3 US nationwide surveys used to monitor physical activity that also collected data on arthritis, few individuals met recommended levels of physical activity, and the prevalence was lower among people who reported a doctor diagnosis of arthritis. In studies using accelerometry, results are similar. So for example, a study using data from the Osteoarthritis Initiative, where patients wore an accelerometer for a week, found that only 22% of women and 44% of men with NEOA met public health guidelines of that 150 minutes of moderate to vigorous physical activity per week. There are a number of well-described barriers to physical activity, and of course this will vary person to person. Many individuals will feel that their joint pain makes it too challenging to be active. There are still a lot of inaccurate health beliefs around exercise, that exercise might be harmful to an arthritic joint. And so that can lead to a lot of fear around exercise. Lack of direction from health professionals about what patients can and can't do and what's safe has also been repeatedly cited as a barrier. There are a bunch of barriers that are not unique or distinct to people living with arthritis. So motivation, emotional distress, costs like memberships to gyms, access to pools, sporting equipment, running shoes, and even access to safe walkable spaces, issues with our built environment, limitations due to weather in Ontario, the ice in the winter. All of these can limit people from engaging in exercise. On the flip side, there are many enablers to exercise, and these include having prior experiences with exercise, like having previously played a sport, getting enjoyment out of exercise, and understanding the benefits that exercise can have, both for rheumatic disease, but also for overall health. Having a resilient attitude, adequate support from health professionals, and having a strong, high levels of social support, like from family or peers, are also been cited as key enablers. So are we doing our part as health professionals? And I really like what Susan said earlier this morning about, your patients feel bonded to you. So are we, they're turning to us. Are we doing our part? In a scoping review that we did a few years back, even in NEOA, where exercise is a fundamental recommended first-line treatment, less than half of primary care physicians and rheumatologists recommended physical activity to their patients with NEOA. Key barriers from the perspective of health professionals included this perception of lack of time, the expectation of poor patient adherence, well, they wouldn't do it anyway, lack of knowledge and skills to prescribe exercise, and the lack of reimbursement for exercise counseling, realizing that it can take a lot of time to adequately assess and counsel people around this. So clearly there are many barriers that we need to try to tackle, and these barriers are at the patient level, but also at the health professional and the health system level. So we are up against quite a wall, but we can overcome it. All right, I'm going to talk a little bit about prescribing and monitoring now. And when it comes to physical activity in our patients with rheumatic disease, there are some overarching principles we can draw on from the recent recommendations from EULAR, or the European League Against Rheumatism. First, physical activity is key to optimizing health-related quality of life in our patients. Second, physical activity has demonstrated health benefits. Third, all types of physical activity, aerobic resistance, flexibility, and neuromuscular, are safe and appropriate for people with rheumatic disease. And finally, the planning of physical activity should be a shared decision between the health professional and patient, taking into account patient preferences, capabilities, and resources. The paper goes on to make 10 specific recommendations, and I encourage you to read them. And part of these recommendations include that the health professional, should have a responsibility for physical activity promotion and collaboratively work to support exercise as part of rheumatic disease care. I want to speak to some important resources to consider when supporting patients in being physically active. So the Canadian physical activity guidelines have recently been updated and actually been replaced by the new 24-hour movement guidelines. And these specific recommendations are absolutely appropriate for people living with rheumatic disease. It still recommends 150 minutes of moderate to vigorous physical activity a week, as well as the 2 days of resistance exercise, but also describes how, or encourages incorporating additional light activity, reducing sedentary time, and ensuring adequate sleep to facilitate the engagement in physical activity. And so what I put up there are the recommendations for those under 65, for those over 65, additional activities that challenge balance are recommended. So I've shown you the evidence already, but a key principle is that progressing towards any of these targets will result in some health benefits. There's no stipulation of how long a bout of physical activity needs to be. Prior iterations had spoken about 10-minute bouts or longer. That's no longer the case. And so any amount of physical activity will have benefits, even if physical activity guidelines are met. There are various tools to go about this. You can consider using prescriptions. So, prescriptions aren't just for pharmacotherapy. You could even write out using a fit approach, a frequency, intensity, time, and titration. But there are also some nice resources from the 24-hour movement guidelines that can help with an approach to counseling. And you can find them at the CSEP guidelines website. I want to underscore the importance of teamwork and list some examples of resources available. So these are more what we have local to us. So GLAD Canada, but GLAD is actually rolled out around the world, an exercise and education program for people with hip and knee osteoarthritis, and delivered by trained therapists. So multiple countries offer this. In Canada, you can go to the GLAD Canada website and see all the centers that offer the program. We have at our hospital, we have a ministry-funded pilot program, so people don't have to pay out of pocket for this. In Ontario, we have the Arthritis Rehabilitation and Education Program. So again, no out-of-pocket cost to patients. So arthritis care delivered by OTs and PTs with additional training in arthritis, and they can help guide a physical activity program. And of course, for those who have coverage and access, considering private physical therapy, those partnerships can be really beneficial, particularly with a community physical therapist or occupational therapist who lives close by, and so something to harness if possible. I want to highlight a Cochrane review indicating the important role that health professionals have with respect to exercise. So health professionals are really crucial to helping patients engage in exercise. So without adequate information from health professionals, people don't know what to do. And as a consequence, often avoid activity for fear of causing harm. So with health professionals, we can provide better information and advice about the safety and value of exercise, provide exercise tailored to individuals' preferences, abilities, and needs, and challenge some of those inappropriate health beliefs and provide and offer ongoing support. So in summary, we spoke about the important role of exercise, both from a disease-specific and whole person health perspective and how it's recommended in the care of people with rheumatic disease. There are a number of barriers at the patient health professional health system level, and these are things that we need to address to promote better uptake and engagement in exercise and physical activity. As health professionals, we can work to try to overcome some of the barriers and enhance the enablers. As health professionals, we need to think about physical activity and aim to individualize these recommendations to according to patients' preferences, resources, and then consider drawing on a team. And my colleague Angelo will speak to some of the nuances around personalized exercise prescription. So thank you very much, and looking forward to the panel discussion at the end.
Thank you so much, Lauren. And we will continue on this same topic of exercise, giving the perspective of the physiotherapist. So it's my pleasure to introduce Angelo Papachristos, who is advanced practice physiotherapist. He works at Unity Health at Toronto St. Mike's Hospital. He completed the ACPAC program, Advanced Clinician Practitioner in Arthritis Care, in 2006. To those of you who are not aware of this program is an excellent program that started in the University of Toronto and trains allied health professionals such as physiotherapists and nurses to work with people with arthritis. So Angelo works as an advanced practice physiotherapist at St. Mike's Hospital, and he specializes in hip and knee joint assessment, sports and orthopedic trauma, as well as patients with rheumatic diseases, in particular those with early inflammatory arthritis and spondyloarthritis. And he also holds status position as a clinical lecturer at the University of Toronto. So, Angelo, the floor is yours.
Well, thank you very much, and thanks, Lauren, for that intro into exercise. So I'm going to go through and maybe talk about some of the practical examples of what happens when we approach these patients from an exercise perspective. I have nothing to disclose related to the topic material. Lauren brought up some of the challenges and barriers in some of the literature, and I'm going to go on to how do we prescribe and monitor some exercise in patients with rheumatic diseases. And we're talking predominantly osteoarthritis as well as some inflammatory conditions. I'm going to start off with a case just to make it real. These are two patients that we've seen in the last 18 months. 53-year-old female, Mrs. OA. She had moderate severe right knee pain for 3 years. Timed up and go, functional outcomes 15 seconds, sit to stand, difficult for her to do more than 4 repetitions. She's got moderate degree of pain at the end of the day, was referred from orthopedics because of a joint arthroplasty consultation, and she's got hypertension, type 2 diabetes. The A1C was 9.8, elevated BMI of 44.8, very elevated, and she was on 2 grams of Tylenol and CBD oils as well as the other medications. Personal support worker at Brampton, no hobbies, no exercise. She basically said, I walk and work all day. There's no point for exercise. And this is what we see in real life, right? She tried therapy for about 3 months, about 2 years ago, and said it was completely useless, made no difference. So that's what's referred to me on a daily basis. Here are radiographs quickly. She has a varus knee on the right, atypical of what we normally see in females. Medial compartment OA, moderate to severe severity. Went to orthopedics, said, we need a right TKR. Once your A1C is under 7 and your BMI, and Sean will love this, is under 40. And there's the cutoff. A lot of orthopedic surgeons, at least at this site, would like, because of the complication rate related to obesity, diabetes, and infection rates, wants your BMI under 40 prior to booking you for surgery. So they referred over to physio and do some exercise therapy. That was the script. Second case is spinal arthropathy, marketing executive, 5 years with diagnosis on adalimumab, Vimovo, progressive stiffness and pain. Everything was pretty essential, baseline within limits at the time when I saw her. Had some intermittent pain as well as fatigue. But the caveat here is since COVID and lockdowns, essentially all of these executives started working from home over 8 hours per day on the computer, 1 day per work at a shared office space downtown. She stopped exercising at diagnosis. Life got busy, work got busy, got married, have 2 kids under 7 years of age, referred from rheumatology for posture and exercise. So this is what we typically would see. Lauren mentioned physical activity. That's everything, active daily living, occupation. Exercise is a planned activity and structured activity. Therapeutic exercise is specific exercises that a health professional would give you. So we're going to focus more on that. What do we do for recommendations? We use the American College of Sports Medicine recommendations on guidance for prescribing exercise. There is nothing specific to rheumatic disease. And they came out with a strong statement that the beneficial effects of exercise is indisputable and the benefits of exercise far outweigh any of the risks in most adults. The caveat is here, regular exercise that includes a cardiorespiratory component, resistance, flexibility, neuromotor, above and beyond activities of daily living. And that's something that patients have a very difficult understanding of. Here are the guidelines. They're the same: cardiorespiratory 3 to 5 days per week, strengthening 2 to 3 days per week, flexibility 2 to 3 days per week, and they give you some direction on intensity. Lauren mentioned the moderate degree of intensity, 150 minutes per week is the recommendation, or vigorous intensity of cardiovascular exercise, 75 minutes per week. Additional resistance exercise of major muscle groups over the course of the week, Neuromuscular motor exercises for balance, agility, and coordination. That's your yoga, your GLAD programs, etc. And then flexibility component. Those are the recommendations. Moderate intensity exercises, dancing. We talked about Zumba this morning. We talked about gardening, brisk walking. That is moderate. Severe or high intensity is METs greater than 6. You're talking about aerobics, cycling at a fast pace, swimming, competitive sports. So that is the recommendation. Now, I don't know about whatever everyone else sees in their community. Most of my patients can't even start moderate type of activities. So that we say moderate is the end goal or the target versus where we start patients. Now, the benefits and the guidelines are exactly the same for every chronic disease condition that's listed over here. They're no different. So there's no specifics for rheumatic disease. The guidelines for diabetes, osteoarthritis, chronic fatigue, depression, fibro, they're all the same. 150 minutes, moderate exercise, add a flexibility component, add a stretching component, and that's it. So how do we approach these patients? When you're looking at spinal arthritis, we have physical therapy on the left and exercise and regular exercise on the right side and smoking cessation. So these are the EULAR guidelines. Once again, very broad statements. Supervised group therapy and daily home exercise is better than any one of them. Very broad statements, no specifics. Now, what is the problem? Problem is 100% of our patients should be exercising to some degree. 100% of our rheumatic disease patients should be exercising 100% of the time. But in reality, this is a graph from the States. I couldn't get one from Canada. Dark blue is good. Lighter is poor. 23% or higher is the dark. There is the percentage of patients that are actually just general average population is not exercising more than 23% of the time on a daily basis. So they're not meeting the criteria. We talk about bias earlier with Sean. There is a bias. There's a bias between geography, right? You see the West Coast versus the East Coast. Furthermore, there's inactivity prevalence is different. You look at this chart over here, dark brown is greater than 30% inactivity rates versus on the bottom, you have the white population in the US. West Coast is green, that's good, less than 15%. So are we taking into these biases when we're prescribing an exercise program as clinician? Obesity, BMI comes up again. There are geographic and location issues that we need to address versus do we take into account rural Canada versus being in close proximity to a city where you have major centers. Again, here, dark blue is BMI over 35. The green is optimized BMI. There's a difference between men and women. We're talking about strength training. The top yellow line is males. The bottom green line is females. Even though there's been a substantial improvement and a trend going from the left to the right over the last couple of decades, there's still about a 10% almost interval change between how much females are participating in strength training versus males. There's a discrepancy or a bias if you have an education, bachelor's degrees versus high school diploma. And do we take this into account? Is that an inherent bias when we're prescribing exercise or access to care? There is a gender difference. Females and males participate in different type of activities. And this just shows you the red is women, the light blue is men. They participate and enjoy different types of activities. Do we take that into account when we prescribe exercise? Finally, the majority of the population in North America participates in a few type of activities that can be lumped into walking, weightlifting, cardiovascular equipment, running, swimming, and water skiing. All the other sports diminish and are less than 5% of what we typically would get. Do we take in age when we prescribe exercise? And I'd say that it's a clinician bias. It's a one-off and done. When you're younger, you see a younger client, they might be interested in baseball, softball. As they become middle-aged, maybe they're into weightlifting, dancing, and as they age, they might move on to walking, hiking, and golfing. So there's an important ability to reevaluate the client as they age, be very specific in when we prescribe something to these clients. We talked about a little bit of the barriers. We talked about motivation, lack of time from patients, but I'd like to argue that maybe as clinicians, physios and rheumatologists and other clinicians might have a bias in not spending the time or the expertise or inherent biases that we have in prescribing the right amount of exercise for that client. Facilitators of exercise is having knowledgeable clinicians in rehab centers, in gyms, community groups, and sporting activities. And that means reaching out to finding the right clinicians in different areas and referring your patients to those individuals. It takes a lot of time and effort to do that. Strategies to improve adherence, booster sessions, group work, behavioral interventions, coaching, internet-based supports, etc. So it's that whole, how do we move the needle that Susan was discussing? How do we get them even to baseline to get them to exercise? We give this out to every client that comes in through our OA clinic. Very simple. It's basically be active, sit less, build strength, and improve balance. Nice little cue card. 150 minutes, twice a week of the rest. How do we get them going into this? We've simplified the sports medicine guidelines. We just found that most of our patients just need to get started. The end goal is 150 minutes, but we really have a philosophy of just trying to get them to do anything is difficult and challenging. So we have a 2, 2, and 2 criteria here, which 2 days a week of cardio, 2 days of strength training, 2 days of flexibility. And we really target 8 repetitions of one exercise, one set, 8 different exercises. It's very simple for clients to facilitate. So we don't follow the guidelines to start. The goal is to get them to that end stage, and that might take anywhere from 6 to 12 months. Mental health burden, so too much or too little exercise is challenging from a mental health perspective. Less than 3 times per week versus greater than 5 times per week is an additional mental health burden. So we try to have that sweet spot of 3 to 5 days per week of exercise therapy. Now, specifics. How do we get patients just to start? There are, for seronegative spondyloarthritis, there's a lot of information online that's vetted by organizations. National Association of Spondylitis Society in the UK, as well as SAA in the States, have pamphlets, brochures. There's videos that they are free for patients to interact with that include a cardio strength component, stretching component, and a yoga component. Patients can start from day one with a vetted program. They can try for about 3 months and then go to a therapist after to have that therapeutic intervention where we can specify the exercise to their impairment. There's also an exercise sheet where you can just hand out in the office to get them started. The UK, the NSS Guide to Effective Exercise is important. And I really like this because patients can go online and print this PDF or just look at it. But it's got this great green, orange, red. So good, the bad, and the ugly. So the exercises that are really safe for patients to just get started with are in the green. The ones that are in the orange or the red are exercises that if they want to do sport specific, that is something that we recommend working with the therapist and trying to facilitate appropriate time for them to intervene. It's really laid out well with the cardiovascular component, stretching component, working on theraballs for core strengthening, choosing a gym ball. So all of those sort of how do I get started are all there for the patients to do right from day one. So we don't start on any of the physiotherapy specific type of therapeutic exercise till at least they've had 3 months of trying these interventions just to get used to a good exercise routine, have some questions and come back to us with modifications. So we just give them this information, start the program, they're vetted, easy to go, low cost or no cost for any of these patients. For the exercise therapists and rehab clinicians out there in the office, there's an excellent article by Janet Milner et al. That basically gives you some recommendations on how to devise a program, dosing frequency, etc. And if you could pull up this article, it's fantastic. So back to the case quickly. How do we approach these patients? Mrs. OA, referred for knee OA and exercise therapy. She wasn't convinced on therapy would be beneficial, not worth the time, not worth the expense. Have to spend the time in there and go in and ask, what did you do in your previous clinic? And this is what she received: passive modalities, ultrasound, TENS, taping, acupuncture. None of those are recommended modalities for treatment of osteoarthritis. And we try to defer and have that education session with her to try to move more towards the therapeutic exercise. So none of this is indicated for this population, and that's probably why she didn't get any benefit from it. We had started her on the GLAD exercise program, which is a group session that Lauren mentioned earlier. It's 10 exercises, 12 sessions, group format with education. Excellent program. It's available in Ontario, but there's nothing special about the exercises. You can get them all online, but the group interaction and trying to get them good patterns and getting them initiated in the program is critical. She came back, she had a symptomatic knee. We sent her to rheumatology for an injection to allow her to exercise. We put her in lateral heel wedges, which, yes, are not indicated in the guidelines, but unloaded her pain in her medial compartment by about 50% and was enough to get her through the program. We initiated a very low level introduction to step, not the 6,000 to 9,000 that Lauren was talking about, 5,000 steps at night with an increase of 500 steps every 2 weeks up to a target of 3,000 steps. So we set the bar very low to ensure that we have success. And I will keep them at 3,000 steps until they're able to demonstrate at least a 70% success rate with the intervention. For example, she has to be able to do that 3,000 steps consecutively, at least 70% success for 3 months before I will start titrating up. We sent her for dietitian counseling online, went back to family practice, started on Ozempic up to a dose of 1 milligram that she's on currently. And over 8 months, she was down to 215 pounds. BMI, which we don't want to talk about, was down to 33, but allowed the surgeons to sort of have her in that target range. Her A1C went to 6.7, which again was safe for surgical consideration. But the patient, from a functional perspective, improved in their walking, in their ambulation distance, as well as ability to go from sit to stand, as well as ambulate up and down at her home. She also went down 2 scrub sizes for her from a body image perspective, was fantastic. So these are all the interventions that we implemented at the same time. She ended up with a total knee. This was April of this year. Same day surgery, which 5 years ago for a 285-pound female, we would never contemplate. She did extremely well, went back to work early, typically 3 months off work. She went back after 6 weeks, managing with minimal work restrictions. And I think this is where Susan hit it on there. We moved the needle. She came back and asked me, what are the next steps? What hobbies can I now get into in the summer? What am I going to move on to? So this is what this is the optimal patient, and this was a success for us. Quickly moving into our marketing executive, different approach. We took a inverted pyramid approach where we start with postural exercises, range of motion and flexibility, and we targeted the cardiovascular exercises for the end of the, the end after about 12 months. We started on a walking program, the videos Monday, Wednesday, Friday, and told her don't do anything on the weekend, enjoy your time off at home. Funding wasn't an issue, so we recommended ergonomic assessment, added a home stretching program, Pilates sessions over 12 months, and then we added Monday, Wednesday, Friday of the cycling for the cardiovascular. And that worked. We got her into a program Monday to Friday while she was at home, and then we included all the components slow over a course of 12 months. So she was very compliant with the program. And now she's asking for an assessment to see her get her back into golfing because she wants to play that with her husband and her kids. Here are some resources that are available that you can hand out in your office. And again, the approach, I think, for the rheumatic disease patient is the target is the end goal, the 150 minutes, as well as the American guidelines for sports medicine. That's the end. Start really slow and move up gradually over an extended period of time to get the patients to buy into the program for long-term benefit. And thank you.
Thank you so much, Angelo. That was great tips. And you'll be joining us for the panel discussion. We will then now shift gears to a different topic, which is antimalarial-induced cardiomyopathy. So it's my great pleasure to reintroduce Dr. Paula Harvey, who is the co-director of the Cardio-Rheumatology program. She's also the physician-in-chief of the Department of Medicine at Women's College Hospital and FM Hill Chair in Women's Academic Medicine. Dr. Harvey's clinical and research focus is on cardiovascular diseases in women, with a special interest in hypertension and complex blood pressure disorders, autonomic disorders, as well as cardiovascular diseases in autoimmune and inflammatory rheumatic diseases. So, Paula, please.
Thank you, Lihi. So this presentation is going to be a change of topic, hopefully not a change of pace, because we've had a great amount of enthusiasm with the talk so far today. But I'm going to be talking not about lifestyle issues, exercise, obesity. I'm going to be talking about antimalarial, that's chloroquine and hydroxychloroquine induced cardiomyopathy. We use the acronym AMIC, which we are seeing now in our patient cohorts and are concerned that it's an emerging complication of long-term antimalarial treatment. My disclosures, I have received a couple of honorarium in the last 12 months for CMEs that I've done for National Pharmacy Group and for Cardio-Rheumatology. And I have grant support, not from industry, but from CIHR and other societies. So with my talk today, I want to first go into detail of actually the first case of antimalarial-induced cardiomyopathy that I ever saw, to examine the pathophysiology and explain it to you, and then look at what we're doing to try and develop strategies to screen and more effectively and implement early diagnosis of AMIC in our patients. So I don't need to tell you that antimalarial was widely used in inflammatory rheumatic disorders, particularly in patients with lupus and in patients with rheumatoid arthritis. I'm particularly interested, or have been, in the lupus cohort, and in these patients, antimalarials, we know, reduce the rate of clinical flare. They reduce damage accrual and thrombotic manifestations, lead to a more favorable metabolic profile. They have anti-arrhythmic properties and overall increased survival. They've been a very important tool in the pharmacological armamentarium in patients with lupus. In large cohorts, about 70% of patients are using antimalarials long-term in lupus. There are important recognized side effects, including retinal toxicity, which we know occurs with long-term use of antimalarials and for which there are screening strategies in place. Now, AMIC is an infiltrative cardiomyopathy, which has been considered rare or idiosyncratic in the past, and was reported really as isolated cases, but we are actually seeing it as a more common entity in our patients, and I'll be discussing that today. So this first case that I'm going to go into in detail was my first case of AMIC, and it was back in 2015, when a 74-year-old woman with a very long history of lupus, more than 30 years, and antiphospholipid syndrome, was seen in my clinic. She had a history of multiple complications in the past from her lupus with a relapsing remitting course. So she'd had arthritis, pericarditis, endocarditis, Raynaud's, and thrombosis. She'd been on hydroxychloroquine since 2002, and additional medications with prednisone at variable maintenance doses, warfarin for her antiphospholipid syndrome, ramipril and amlodipine because she had hypertension, and thyroxine. Her lupus was actually inactive from 2005. This is both clinically and serologically. Despite that, she did have continued increase in CPK from 2006, but she had no clinical muscle disease. In 2012, she was referred to me for workup of, for want of a better term, atypical chest pain. And at that time, she had an ECG that had left axis deviation, possibly mild LVH, recognizing ECGs are not great for LVH, but she did have known hypertension. Her troponin was in the normal range. Echo, she had normal LV systolic and diastolic function, including an ejection fraction of 65%. She again did have mild LVH and with which we assumed was due to her hypertension, mitral valve prolapse, and just some non-clinically significant mitral regurgitation. She had a cardiac MRI, making sure she didn't have myocarditis, and this was normal other than the mild LVH that we'd seen on echo. Her symptoms resolved, and she didn't need any further follow-up. However, in 2014, she contacted the clinic and said that she had new onset shortness of breath and quite significant shortness of breath. I remember this very distinctly. I spoke to her on the phone, and she lived remote from Toronto, and I told her she needed to come in and be evaluated. She decided that she had the flu and that she would be fine, despite my encouragement to come and be reviewed. She came a few months later and clearly had clinical findings of heart failure and very concerning new findings on investigation. Her ECG now showed new left anterior fascicular block and left bundle branch block, so conduction disease. Her echo showed new severe concentric left ventricular hypertrophy, but also right ventricular hypertrophy and septal hypertrophy. Her EF had decreased to 35% from previously normal values 2 years before. She had diastolic dysfunction, severe new biatrial enlargement, and a restrictive filling pattern. She also had new elevation of her cardiac biomarkers with a brain natriuretic peptide, BNP, that was elevated, and her high sensitivity troponin was elevated. I'd remind you this was previously normal. So I referred her also for a cardiac MRI to make sure that she didn't have myocarditis. And on this occasion, 2 years from the previous MRI, she had dramatic LVH. She now had late gadolinium enhancement in a non-vascular pattern, but no edema, suggestive of perhaps myocarditis. And there was no definitive diagnosis as to what was going on here. And I was very concerned because she had class 4 symptoms, all of these new findings. And I sent her to my colleague, Dr. Mack, who was mentioned by Dr. Moric earlier today, a fantastic heart failure specialist, because I wanted further specialty evaluation. She was extensively evaluated for all potential causes of this hypertrophic restrictive cardiomyopathy, including HOCM, amyloid, sarcoid, hemochromatosis. We sort of thought she might have Fabry because this can affect women in the middle age where they get hypertrophic restrictive cardiomyopathy, but all of her genetic testing for Fabry's was negative. She went on to have a biopsy, a cardiac biopsy, and this was diagnostic for AMIC. She had endocardial and interstitial fibrosis and significant findings on both light and electron microscopy, and I'm going to show you her images now. So on the left of the screen, you have light microscopy. On the right is her electron microscopy, and she had pathognomonic findings. The black arrow on the left shows that she had vacuolation of her cardiac myocytes, and on the right, on her EM, she had what we call lamellar phospholipids in stacks and whorls, and she importantly had curvilinear bodies, which are very pathognomonic for AMIC. So why might this occur in patients with antimalarials? Antimalarials have a very wide volume of distribution and they have a long half-life. They do accumulate in lysosomes in the cells. These inhibit the phospholipases and hydrolases. By this mechanism, it generates what's really a lysosomal storage disease phenotype, very much like Fabry's, with a hypertrophic restrictive cardiomyopathy. And so her findings of endocardial and interstitial fibrosis with hypertrophic fibers and marked vacuolation were very concerning for AMIC. And again, these stacks and whorls on electron microscopy were pathognomonic for AMIC. This was the first case seen by my specialist colleague in her heart failure clinic. We stopped her antimalarial, treated her with usual cardiac medications for heart failure. She had gradual improvement over the next couple of years with decreased hypertrophy and improvement in her symptoms. Her biomarkers improved, but were not normalized. Her CK normalized. She did continue on heart failure management, and many more cases like this incident case have now been seen in our clinic. So this started a journey with myself and my colleagues in the lupus clinic at Toronto Western Hospital, where they see very large number of lupus patients. They're recognised as national experts. And we started to think, well, what do we know about AMIC? Lots of patients have been on long-term antimalarials. Are we missing a complication here? So first up, we did a systematic review of the literature, and we found 48 cases reported. There was a female predominance, 43 females, 5 males. That's not surprising considering that antimalarials are used mainly in patients with lupus and rheumatoid. Mean age at diagnosis was around 56, 57, but with a wide range. The diseases were lupus, rheumatoid, with a smattering of other conditions where antimalarials had been used long-term. Mean duration of antimalarial was around 13 years, but again, a wide range of doses from 2 to 35 years. But I would say that patient that had been on for only 2 years was on very high dose antimalarials and was preceded sort of the use of weight-based dosing. And both chloroquine and hydroxychloroquine were implicated in these 48 cases. 6 of these patients also had retinal toxicity. These patients had presented with clinical heart failure in nearly 80% of patients, and also syncope in 17%. In those that had biomarkers measured, not all of them did, 9 out of 10 had elevated tropes, 10 out of 10 had elevated BMP, and 11 out of 14 had elevated CPK. Conduction abnormalities, like in our patient, were very common, with 50% having complete AV block, and in fact 50% had pacemakers, with many of them having the pacemakers pre-diagnosis of AMIC. Left bundle branch block and right bundle branch block were also common. On echo, they had restrictive cardiomyopathy with LVH 74%, RVH, like we saw in our patient, 50%, septal hypertrophy, again, 43%. Atrial enlargement biatrial was common. That was seen in 43%, restrictive filling pattern, and reduced left ventricular ejection fraction. So in the MRIs, 83% had LVH, 50% RVH, and nearly 60% had LGE. High mortality of 18 patients, while around 22 survived, but 2 of these actually had heart transplants. As far as reversibility was concerned, there was some recovery in ejection fraction in 64%, regression of LVH in 64%, and none of them had resolution of conduction disease, which is important. So we looked at our experience at the University of Toronto. One of the first things we did was do a retrospective review of the lupus cohort to look at the patients in detail that had had pacemakers and versus those with lupus, so with similar disease and that were age matched without pacemakers. So looking at the patients that had pacemakers, the disease duration, lupus duration, was around 22 years. The pacemaker patients did have a degree of risk factor burden, including CAD, hypertension, dyslipidemia, and myocarditis. But there were 8 patients that had no identifiable risk factors. And the majority of these patients actually had quiescent lupus. The insertion of a pacemaker in these patients was associated with duration of antimalarial treatment. And in fact, most had already had retinal toxicity. Unfortunately, the majority of these patients had not had MRIs prior to the pacemaker insertion, and none of them had biopsies. They did on ECG have a lot of conduction disease that preceded the pacemaker that was for either heart block or sick sinus, similar again to what we saw in our incident patient. So then we started wondering, well, what's the case with biomarkers in our patients in the lupus clinic? So what we did was we measured biomarkers, troponin and BNP, in 51 consecutive patients attending the lupus clinic at the Toronto Western. And these were just patients coming into the clinic at their scheduled appointments We did exclude patients that had a known prior history of heart disease or pulmonary hypertension, or sort of previously established ECG abnormalities that might suggest coronary disease. And we found of this 151 consecutive patients that 10% had abnormal biomarkers. The abnormality in biomarkers was associated with older age, longer duration of antimalarials, and longer disease duration. Using multivariable logistic regression analysis, we showed that prolonged antimalarial therapy, actually not that long, greater than 6 years, and a persistent increase in CPK were predictors of elevated biomarkers. We actually completed a workup in these 10% of patients, and we had 6 patients with definite and or probable AMIC, all of whom had elevations in troponin and BNP. And the remainder had no other cause identified, such as renal disease, and we started to follow them closely. So already a number of these patients had AMIC that hadn't been identified. We then started to think, well, so that's biomarkers. What about MRI in patients with lupus? At the moment, you know, we really are identifying the early detection of AMIC is important because the systematic review and others have shown high morbidity and mortality in patients who develop an established cardiomyopathy due to antimalarial therapy. Cardiac biopsy is the gold standard, but it's invasive, so there's a risk with the procedure, there's problems with accessibility, etc. And we were thinking, well, could cardiac MRI provide reliable diagnosis? So our team retrospectively reviewed all patients with lupus at the University Health Network and Mount Sinai Hospital who had cardiac MRIs performed from 2008 to 2018. We did exclude patients that were known to have had myocarditis. We identified, based on biopsy and consensus statement, 11 patients with AMIC and 29 patients that were not considered to have AMIC. And when we compared these two groups, we found that those with AMIC, 91% of them had LVH, that was primarily concentric LVH, versus the 25% without concentric LVH. 100% had LGE versus 21% where they didn't fulfill the criteria of AMIC. And the LGE was basal infralateral, so non-ischemic, but in this particular region, in 90% of these AMIC patients, and mid-wall in 8 out of 10, or 89% of the patients. So LVH, LGE, and this pattern of LGE was very important. This is an example of one of the patients, a 68-year-old woman who had was diagnosed with antimalarial-induced cardiomyopathy, and this is her MRI and the short axis view. And on your left, you can see figure A. That's actually showing the imaging where the patient had the LGE in the mid-wall, most prominent in the basal infralateral wall. Next to that is her electron microscopy imaging, and this shows from her biopsy, and this shows myeloid and curvilinear bodies, again, typical of AMIC. And then we see at the bottom the color-shaded bullseye plot that actually represents the location of the LGE in patients with AMIC. So this patient, but the others all combined, versus those without AMIC. And you, I'm not an MRI imager, but you can see there's a difference in distribution of the LGE and intensity in the patients with AMIC. So we then started to think, well, these findings of AMIC are very similar when you're just doing an MRI to patients with Fabry disease, and you need the biopsy as a gold standard to be 100% sure that it's AMIC and not Fabry's, although you can, of course, do genetic testing. And we started to think, well, can we do specific mapping on an MRI to better differentiate between AMIC, Fabry's, and other causes of this kind of phenotype? And this study was led by Kate Hanneman, who's an expert in MRI imaging. And the purpose of this particular study that was published just in May last month was to look at T1 and T2 mapping in patients with lupus in relation to antimalarial treatment. And so all patients who had lupus who'd undergone MRI imaging with T1 and T2 mapping between 2018 and 2021 were evaluated and compared with sort of healthy controls, those without lupus who had MRIs. For those of you who are imagers, T1 and T2 values were converted to Z scores because there were some scanner-specific differences in the software, but it's all done within the one organisation. And patients were classified into 3 groups: AMIC, myocarditis, and other, so no AMIC and no myocarditis. And the results were that there were 45 lupus patients, 80% were female. 8 of them had AMIC, 7 had myocarditis, and there were 30 that had neither AMIC or myocarditis. And there were differences between these groups in their T1 and T2 imaging. And this slide actually shows the imaging, the LGE distribution on the left, going from AMIC to myocarditis to other SLE and normal patients, and then their native T1 and T2 mapping. Again, I'm not an imaging specialist, but what the findings were that there was a relationship between T1 mapping and antimalarial treatment duration that differed between the 2 groups. So native T1 decreased with longer treatment of antimalarials in patients who did not at that stage have AMIC and in patients who had myocarditis. And this is thought due to accumulation of the sphingolipids, so fat accumulation, to put it in simple terms, in these patients as they were treated with the antimalarial but had not yet developed AMIC. Once they developed AMIC, the T1 started to go up, and it was thought that this actually represented fibrosis. So we're starting to look at these mapping strategies to better define the diagnosis and an early diagnosis in patients with AMIC. Lastly, there's not much information about follow-up of patients with AMIC, and it's unclear which patients may have stability of disease, which patients may progress, which we actually are seeing in a number of our patients, and those that may have improvement and regression of disease. So in this study, again led by Kate Hanneman, and again just published last month, we did a case series of 9 patients with AMIC, and we looked at their baseline MRI that was done at the time of diagnosis, and then the MRI that was done in follow-up. The median duration of antimalarial therapy in this cohort was 22 years, and 100% of them were female. These are all lupus patients. I would point out that the antimalarial was ceased at the time of the baseline MRI, so there was no continuation of antimalarial therapy after that first baseline imaging. What we found at a median follow-up of 1.5 years after the baseline imaging, there was an interval increase in late gadolinium enhancement in 89% of the patients. There was an interval decrease in left ventricular ejection fraction in all of these patients. No change in LV mass. The troponin remained elevated, although there was some decrease in the magnitude of that elevation. And there were adverse events, with 1 death that was followed the second MRI, and 2 patients that actually required pacemaker for complete AV block. These patients tended to have the highest burden of LGE. So despite cessation of antimalarial therapy, there was progression of cardiac abnormalities in these patients. And we feel that this is what we're seeing clinically in a lot of patients, and it underscores the important role of the imaging in early recognition of antimalarial related treatment changes. And this is just the imaging from one of the patients, a 50-year-old woman who had the baseline MRI on the left and then follow-up on the right. Even the non-imagers, I think, can see that there's an increase in the LGE on that imaging on the right in this patient. On the bottom are the graphs that show the baseline versus follow-up for LGE on the left, ejection fraction in the middle, and LV mass on the right. And you can see increase in LGE, reduction in ejection fraction, and stability of LV mass. So just to finish up, this is sort of an algorithm to try and explain what's happening when you're on long-term, I emphasize long-term antimalarial therapy, and you have a cumulative exposure to either chloroquine or hydroxychloroquine. This leads to accumulation within the cells of the heart, and you get decreased lysosomal phospholipase and hydrolase activity. You get accumulation of phospholipids. You get vacuolated cytoplasm, hypertrophy, fibrosis, inflammation, and apoptosis, so death of cells. You get a lysosomal storage disease phenotype. Some may progress, some may be reversible. And what we see clinically, along with heart failure and conduction disease, is elevated troponin representing ongoing myocardial necrosis, elevation in BNP showing pressure and volume overload, conduction disease, as we saw in that incident patient, and the morphological changes that we're seeing on echo and cardiac MRI. So is AMIC rare or under-recognized? I would say under-recognized, and that's been our experience. We really need to raise the level of surveillance for patients with lupus and Arrey. Be aware of any new heart failure, conduction abnormality, any changes of hypertrophic changes on echo, particularly if the patient doesn't have uncontrolled hypertension. These patients can be mistaken for other pathologies. I would say that it took a while for my heart failure colleague, Dr. Mack, who's very experienced and very thoughtful, to really accept that I was sending her more AMIC patients after that first incident case. It was still like, no, it can't be AMIC. Yes, it was. So we would suggest that what we're doing now, at least, is looking at CK, cardiac troponin, BNP, history of retinal toxicity, ECGs for any development of any conduction disease, echo, and if necessary, if the echo is abnormal, there's conduction disease or elevated biomarkers, consider an MRI. Be aware that the outcomes are not predictable. You have to follow these patients very carefully, even after you stop the antimalarial. We are working to develop predictive tools to improve detection and identification of patients at risk of this entity. And all of our work at University of Toronto has been really in the lupus cohort, but we are starting to look at the rheumatoid patients too, including here at Women's College Hospital. So just with that, I'd like to acknowledge the AMIC team. That's myself, Dr. Aktari, and Dr. Osuntokun in cardiology here. Particularly in rheumatology, Kostas Silias, who was at the Western and is now at McMaster, Dr. Murray Urovitz and Dr. Daphne Gladman, and Zahi Tuma, Susanna Mack at Mount Sinai, Kate Hanneman and her cardiac imaging team at UHN. Thanks, Lihi.
Thank you, Paula. That was great. I think this really demonstrates the importance of cardio-rheumatology, interdisciplinary collaboration. All of these publications had critical involvement of cardiologists, rheumatologists, and imaging. So that's great. And this is really good time to move on to the last session that we'll be discussing cardio-rheumatology, which is an emerging interdisciplinary field that is now getting more recognition in cardiology and rheumatology fields. And I can say from a personal perspective that I truly enjoy this collaboration with colleagues from other disciplines and in particular cardiologists, learning a lot about what's going on in the field and getting a different perspective. So it's my great pleasure to introduce our next speaker, Dr. Annegret Semp, who is a true pioneer in the field of cardio-rheumatology. She's a consultant cardiologist and a senior researcher, as well as the founder and leader of Prevention Cardio-Rheumatology Clinic, in the Division of Research and Rheumatology at Diakonment, I probably pronounced it incorrectly, hospital in Oslo, Norway. She has been a leader in many initiatives in the field of cardio-rheumatology. I'll name a few of them. The Norwegian Cardio-Rheuma Register. She's also been involved in international surveys in Arrey, lupus, antiphospholipid in the field of cardio-rheumatology. And she's been involved in the task force for EULAR for developing recommendations for cardiovascular risk factor management in patients with inflammatory joint diseases. So Dr. Sam will present on international perspectives and lesson learned from cardio-rheumatology clinics. Hi, the floor is yours.
Thank you for that kind introduction. It's the Deaconess Hospital Diakonium, so sorry for that. I'm thoroughly very, very happy to be invited to speak for you and to share with you international perspectives and lessons learned from a cardio-rheumatology clinic in Oslo and internationally. So these are my disclosures. So from the from the large Norwegian Cardio-Rheuma register, including the whole Norwegian population, 4.7 million persons above 18 years of age, we have found in a contemporary cohort between 2008 and 2017 that the all-cause mortality in Norwegian patients with Arrey and axonal spondyloarthritis are increased with about 40%, as you see from the left on this figure. The three main causes of death is circulatory and cancer and respiratory diseases. They have Arrey and axonal spondyloarthritis and a 40% increased risk of cardiovascular death as well. This was not so in patients with psoriatic arthritis, although women with PSAR had slightly reduced survival. The younger ones, though. So, the increased risk of cardiovascular disease in this high-risk patient population has been known for 4 or 5 decades. That's a very long time. And despite this high-risk patient population has received limited attention. They are both underdiagnosed of their cardiovascular disease and they're undertreated regarding preventive measures. So why can this be? Well, they have lower lipids compared to the general population. Risk calculators developed for the general population or specifically for example Arrey inaccurately predicts future risk in patients with Arrey. Furthermore, they have a higher frequency of premature asymptomatic atherosclerosis compared to the general population, which leads to inaccurately risk prediction by the common risk calculators. Furthermore, there are more smokers among patients with Arrey or inflammatory joint diseases compared to the general population. Now, in the Moric study, 480 persons were followed for approximately 8 years, and we picked out those with rheumatoid arthritis, nearly 1,800. And as you see from the left panel, that patients, both female and male in the blue bars with Arrey, had lower total cholesterol compared to the non-Arrey comparators. And despite the low level of lipoproteins, patients with Arrey had a higher rate of myocardial infarction, as you see from the right figure. The blue panels depict the female and male Arrey patients compared to the non-Arrey corresponders. This was also so for ischemic stroke. Now we evaluated population attributable risk, that is the weight of a risk factor for a risk of 10-year cardiovascular events. And we found in the attack Arrey cohort, where we followed 5,640 patients for approximately 5 years, we found that smoking, as you see from from the top of the figure that current smoking and hypertension were the most important risk factors, as it is in the general population. But what is not known is that disease activity and seropositivity, as you see from the next bars, they were comparable in magnitude to the par or the weight of the risk for lipids for a future event. And this is new knowledge. And it was shown by Cindy Krausen, who did her Dr. Floss on this. She is a statistician and works at the Mayo Clinic. When we compiled all the traditional CVD risk factors, as you see from the table at the bottom to the left of the image, the traditional CVD risk factors accounted for 49% of all the risk. And what is new is that all the Arrey characteristics encompassing disease activity and seropositivity accounted for 30% of all the risk. So furthermore, you will recommend that it's the rheumatologist's responsibility that patients with inflammatory joint disease have a CVD risk evaluation performed. So we're thinking, how can we get hold of these patients and how can we make this happen? Therefore, we made the NOCA project, the Norwegian collaboration on atherosclerotic disease in patients with rheumatic joint diseases. And this was based on an electronic patient journal called Go Treat It, or GTI. And when we started this project in 2014, 15 centers in Norway had the GTI, and 11 of these said that they would participate in the NOCA projects. And if you look to the right, CVD risk assessment was performed in rheumatology outpatient clinics by that secretary and nurses. They took and recorded blood pressure and lipids and recorded into the GTI, the electronic patient journal. And because we had embedded the SCORE risk calculator into the GTI, the risk for CVD in coming 10 years was automatically calculated, and this risk was present for the rheumatologist when the patient came to this consultation. Thus, the rheumatologist could refer high-risk patients to PCP, the primary care physician, or cardiologist. And we think that the beauty of this, it takes only 10 minutes and is divided by 3 categories of health personnel. So we thought this is plausible. We can do this. Can I ask the technician, there is no animation. I have put a lot of animation into my presentation. Why is that? Okay, no one's listening. Okay, so we also advised in the NOCA project about modifiable lifestyle cardiovascular risk factors. And as you see, this little dot here is one of my sons. He has a non-modifiable lifestyle risk factor, although not cardiovascular. We used brief intervention, ask, advise, and assist on cholesterol-friendly diet and smoking cessation. So I have developed a brief advice on heart-friendly diet, taking 4 minutes. And we evaluated or compared the brief 4-minute advice with an extended 60-minute dietary advice by a dietitian in a pilot study, because we wanted to see if this was effective. And we used, excuse me, the technician, can you give me the correct, this is not the correct slide modus. I want to have things coming into the slide. You're showing me.
Okay, yeah. Just one moment then. Change over. So you'll just have to prompt me in a moment for advancing your slides. I'll host them from my slide. So just one moment. Let me catch up to you, and then we'll go from there.
Okay. So I can just continue speaking then. So we compared the brief advice with the extended advice. Me as a cardiologist giving a brief advice and a dietitian giving the extended advice. And we evaluated the change in diet by SMART diet score, which is a validated, thank you, which is a validated questionnaire. So this is not correct still. That's it, yes. And a change in 3 or more points in SMART diet score is evaluated or considered a significant change in diet. And as you see from the figure, that both those who got the brief in the pale gray and the extended advice had comparable or significantly change in SMART diet score. And we think that this is important because we don't have resources to send everyone for an extended advice by dietitians. So we're now going to, we are now performing a non-inferiority RCT where the primary endpoint is change in LDL and the secondary endpoint change in SMART diet score. It's an international multi-center study, including Umeå Center from Sweden, Aarhus from Denmark, and us in Norway. And we will report on this in 2026. So we know that smoking is a very heavy risk factor for future CVD events. If you have genes for RA, and you smoke, you have 50% increased risk of developing the disease. If you have the disease RA and you smoke, we know that you have poor response to anti-rheumatic medication. But on the other hand, no one knew if smoking cessation would give you a lower disease activity, i.e. a better response to anti-rheumatic medication. So we evaluated this in the ATTACK RA cohort. In this cohort, we used 3,311 RA patients followed up for 3.5 years, and we evaluated smoking status as former, previous, current, or never on the future CVD event. And we found that smoking cessation was associated with lower disease activity, as you see from this left figure. If you look at the middle here, this is previous smoker, and the disease activity is comparable to never smokers and is significantly lower as those who are current smokers. Furthermore, we found that as in the general population, as you see from the right figure, that smoking cessation was a predictor of reduced CVD event rates in patients with RA. Next slide, please. So in the NOCA project, we also evaluated the indication for antihypertensive treatment. And if you concentrate on the left bar here, you see that 53% had an indication for antihypertensive medication. Only 53% of those who had an indication got such medication. And furthermore, to our astonishment, it seems only 1 in 4 and 1 in 5 of the patients on antihypertensive treatment obtained blood pressure goals. I cannot move these myself now, so it's pretty awkward for me. So we also evaluated the indication for lipid-lowering treatment. And as you again focus on the left bar, you see that 36% had an indication for lipid-lowering treatment. And as you see, can you advance now? Among patients whom lipid-lowering treatment was indicated, only 63% got it. And to our astonishment, only 1 in 4 and 1 in 5 obtained recommended lipid goals. So the NOCA project has been a pilot of the SURF-RA, the Survey of Risk Factors in RA. I'll firstly say that surveys are important. Surveys and audits are important in establishing how treatment or guideline recommended treatment is instituted. We first start doing RCTs to produce evidence-based medicine. We then produce guidelines. Then we try to implement the guidelines. and then we evaluate them. So the surveys are an evaluation of the implementation of recommended guidelines. So this is what SURF-Arrey was about. This was a large international survey. We obtained data on 14,503 patients from 53 centers, 19 countries across 3 to 5 world regions. The SURF-Arrey is member of a big SURF family. It's been done in primary care, in coronary heart disease patients, in stroke, in chronic obstructive pulmonary disease patients, and we just finished the SURF in lupus patients and antiphospholipid syndromes. It was completed this year in January, and the data are now being processed. So I will report on this later on. It was Professor Maria Tectonerou from Athens who was the daily leader and in charge of this survey. We have started, please go back one. We have started the SURF PSA in January this year, and if you want to participate, please contact me on ann.sem@yahoo.no. Next slide, please. So we go back, please. So we evaluated the cardiovascular health index, CHI score, and this is defined by 6 risk factors and the obtainment of the blood pressure below 140 and hello, what happened here? And there are certain technical problems here, I see. Blood pressure below 140/90, or if you have diabetes, 140/80, LDL below 2.5 millimolar per liters, glucated hemoglobin below 7%, or glucose below 7 if glucated hemoglobin was not available, non-smoking, BMI below 25, and moderate and vigorous physical activity. The number of risk factors were summed, and if you had 0 of these, it was characterized to be poor, and if you have 4 or more, it was characterized to be good. Please advance. And we found that only 27% had a good CVD risk factor control measured by the CIH score. Please advance, as you see here. And these bars are the various health regions or world regions: West Europe, East Europe, North America, Latin America, and ASEAN. Please, next slide. We also evaluated how many patients attain blood pressure and lipid targets. And if you see at the top figure, only half of the patients attained recommended blood pressure goals. When we evaluated high risk class patients and very high risk class patients, we observed that lipid lowering target attainment was lower than recommended than previously reported. Next slide, please. I'd like to share with you some results from the Preventive Cardio-Rheumatology Clinic regarding treatment of cardiovascular disease in inflammatory joint disease patients. Next slide, please. Now, chest pain is a vital symptom of cardiovascular disease and is also asked about during cardiovascular risk evaluation. In 335 consecutive patients, only 31% seen in the Preventive Cardio-Rheumatology Clinic reported chest pain, and only 1.8% had atypical angina pectoris, as for example, pricking pain at rest. Please advance. 109 of them underwent coronary angiography. And as you see here, that of the patients who reported no chest pain, 3/4 of them had coronary atherosclerosis, and this was equally distributed in patients who reported chest pain. Next slide, please. In a logistic regression analysis with coronary atherosclerosis as the dependent variable, chest pain was not associated with coronary atherosclerosis. And as you see from this figure, about 30% of coronary atherosclerosis was explained by any of the 3 following CV risk calculators: SCORE, Framingham, or Reynolds risk calculator. Please advance. So chest pain was of limited value during CVD risk evaluation in patients with RA and ankylosing spondylitis. Next slide, please. So I'll not go into why CVD risk calculators developed for the general population or RA-specific risk calculators inaccurately predict future CVD events in patients with RA or other inflammatory joint diseases. I'll just say something about risk modifiers of such risk calculators, as for example, that patients with RA have more often, to compare to the general population, asymptomatic atherosclerotic plaques which can be determined by carotid ultrasound. Advance, please. And as early as the 2016 European Guidelines of CVD Prevention in Clinical Practice, it was highlighted that patients who had atherosclerotic coronary plaques or atherosclerotic carotid artery plaques identified by ultrasound, they were to be considered a very high risk class patients. Advance, please. And at the same time, in 2017, the recommendations on cardiovascular risk management in patients with RA and inflammatory joint diseases from EULAR, recommendation 6, said that screening for asymptomatic atherosclerotic plaques by use of carotid ultrasound may be considered as part of the CVD risk evaluation in patients with RA, although the level of evidence was only 3 to 4 and the strength of recommendations CD. Next slide, please. So therefore, we evaluated the effect of identifying carotid plaque on reclassification to correct risk class. We used a score for RA, the modifier score, that is multiplying the score by 1.5 of the risk evaluated by score for RA patients, the score for all inflammatory joint disease patients, and the pooled equations from the states. I'll just mention that these risk classes were used when in 2016, when they were available in the 2016 guidelines. Can you advance, please? When we evaluated patients who had a risk below 5%, where no lipid-lowering treatment was recommended at that time, please advance, please. We reclassified 30, as you see here from the pool equation, 30 to 40% up to a very high risk class where intensive lipid-lowering treatment is recommended. Please advance. When we evaluated patients who had a risk of 5% or more, moderate risk, please advance. We reclassified up to 60% of the patients to a very high risk class. Please advance. So we conclude that patients with low or moderate risk of future CVD was reclassified up to a very high risk class in 30 to 60% where intensive lipid lowering with statins are indicated. And this is, of course, very important clinically for the patients. Now, I'll say something about blood pressure and lipid-lowering therapy and results from the preventive Cardio-Rheumatology clinic. There was a highly significant change in blood pressure from first to final consultation, and the proportion of patients achieving blood pressure recommended goals was approximately 80% across the various inflammatory joint disease classes. And we achieved blood pressure goals in approximately 3 consultations. Next slide, please. And similarly, the proportion of patients reaching lipid targets was 90% in, please advance, less than 3 consultations. Next slide, please. In 197 patients who obtained lipid goals, we evaluated this, if systemic inflammation or lipid levels at baseline did have an impact on intensivity of lipid-lowering treatment needed, but we found that there was no association with statin dose needed to achieve recommended lipid targets, as you see concerning, please advance. CRP advance, or ESR advance, or baseline LDL advance, or baseline total cholesterol. Next slide, please. And this was also so for anti-rheumatic medication when we evaluated synthetic DMARDs, biologic DMARDs, prednisolone, and NSAIDs. We found that this medication did not have an impact on the relation between baseline lipids and inflammation with statin dose needed to obtain LDL goals. Next slide, please. So are statins safe in inflammatory joint diseases? My answer to this question is yes. Advance and advance. We mostly observed gastrointestinal side effects and muscle aches, which were not more common than in the general population and what has been reported previously. We observed no increase in CK or liver enzymes 2 times or upper or more than upper limit normal, and no serious side effects. Next slide, please. So the overall summary, take-home messages: there is an increased risk of cardiovascular disease in patients with RA and axSpA in a contemporary cohort from nationwide register from Norway. There is still an unmet need for improvement of cardiovascular prevention in RA patients, and lipid lowering and antihypertensive medication in inflammatory joint patients have the same effect as in and can be used as in the general population. Please advance. And baseline systemic inflammation, lipid levels, and anti-rheumatic treatment did not influence certain statin dose needed to obtain lipid or blood pressure goals. Next slide, please. So I have a question for you. What are the reasons that patients with RA have increased risk of cardiovascular disease? A, RA patients have low lipids. B, risk calculators for the general population inaccurately predicts CVD in patients with RA. Due to premature asymptomatic atherosclerosis, they have an inflammatory burden on top of the high frequency of traditional risk factors. So, can I see a mental meter here? So thank you to all collaborators taking time and to all patients for participating and for your attention. Thank you. I didn't see any of the...
I think we are facing some technical challenges, and due to the interest of time, I think we have to move on. Thank you, Dr. Sem, for overcoming these challenges. It was great. And we'll thank you for the panel discussion, so please stay with us. It's my pleasure now to introduce our next speaker, who will provide her insights regarding cardio-rheumatology. Dr. Brittany Weber, who is a cardiologist and a director of the Cardio-Rheumatology Clinic at Brigham and Women's Hospital, an associate physician in cardiology and cardiovascular imaging, and instructor of medicine at Harvard Medical School. Her clinical and scientific interests are at the intersection of her 2 passions, immunology and cardiology, with a focus on cardio-rheumatology. So, Dr. Weber, please, looking forward to your talk. Thank you.
Thank you very much. And I'm hoping that everything is going to work with advancing. I'm a little nervous, but let me know if you guys can't see this. And I will get started. So first, I'd like to thank Dr. Eder, as well as Dr. Harvey, and everyone for the opportunity to talk to you about today, and also Dr. Sem, to talk a little bit about international perspectives at the Brigham and Women's. Truly, my passion is doing cardio-rheumatology. So I'll get started because I have a lot to cover. Here are my disclosures. So here's the content outline today. I'll spend a brief second on the overview of CV manifestations that was already covered today, and then I will go through some case-based patients from my clinic about how we identified and treated cardiovascular and cardiometabolic risk and systemic immune-mediated diseases. I'm focusing these 2 cases today, knowing that I don't have time to go through all the unique manifestations we see about coronary microvascular dysfunction and atherosclerosis. And then I'll talk a little bit about understanding the role of the cardio-rheumatologist and how we could use advanced cardiovascular imaging and risk stratification and management in these collaborative care models, much of what we've been discussing today. And so we all know that there's many diverse manifestations. I don't have to tell this audience this. I like to group it into buckets. I like to think about it in the vasculature, in the pericardium, in the valvular, the myocardial, as well as the electrical system. And then you can see here that these are all conditions that are associated with systemic immune-mediated diseases. We would need days of conferences for us to talk about most of these topics, but you can see certain things that were highlighted today, including the very important topic of hydroxychloroquine cardiomyopathy. And today I'm going to be focused more on the vasculature. We also know that in 2023, we are dealing with increasing complexity. Here's just a few snapshots to highlight this increasing complexity and the need for multidisciplinary care. In 2020, we had the height of the COVID pandemic. We all may have remembered, at least in the US, we certainly had concerns about hydroxychloroquine shortage in our patient, which is a main theme of therapy, as well as the risk that was raised due to the electrical arrhythmia burden. We also have the very vexing problem that I now face in my clinic of the cardiovascular risk signal that has come out with JAK inhibitors after the release of the New England Journal of Medicine trial, which led to a black box warning. This has become one of the most common referrals to my clinic now, and I think it's a big challenge as we still need mechanistic data moving forward about how we manage these patients. And then the very important problem that we can never forget of statins and intolerance that you heard from Dr. Sem's talk. But if I just did a quick Google search the other day, I did this last Sunday, you can see here how many million hits I get within seconds. And we are dealing with patients who chronically have muscle and joint pain. And this picture is actually from the New York Times article that I found that was actually an article talking about how statins make you exercise less. Not a message that we want to be giving our patients, but again, this is what our patients see when they go to Dr. Google. We also in 2023 have an expansion of cardiovascular imaging tools. And this is just to highlight the advancement of cardiovascular imaging tools. And as an imager, I am very excited about how we can use these modalities to detect subclinical disease so we can start to understand these cardiovascular manifestations. We have advanced much further beyond the exercise EKG and echocardiogram. Both still are mainstay stem therapies, but we now can coronary CT with really exciting technologies that have been developed to look at inflammation with the fat attenuation index. We have cardiac MRI, where we can look at both perfusion for microvascular dysfunction as well as myocardial and pericardium. This is a picture of one of my patients with lupus pericarditis. And then the bottom left is a true passion of mine, which is stress PET, which is where we can look at the abundant microvascular to the heart and calculate myocardial blood flow, which is prognostic, both in the general population as well as the cardio-rheumatology population. So I won't spend too much time on this slide because this was introduced a lot today. It's well appreciated by this audience of the increased cardiovascular risk with RA. And this is one of the main disease model I've studied in the laboratory. And we can think of this as a human model of systemic inflammation. And this just shows you the mean high-sensitivity CRP in patients in a longitudinal cohort at the Brigham compared to the general population. We are also recognizing in 2023 that many of the shared pathways between atherosclerosis and RA, and they kind of converge what we believe on these key cytokine pathways. This was a review that I wrote with Dr. Liao just recently, where we really try to hone in on the shared mechanistic relationships between what we're learning in athero, which is a very exciting time, and what we already know from the rheumatoid arthritis pathogenesis. And what we talk about in this is that it really does seem this convergent down to IL-6. And if we just look at drugs, we all know from the rheumatology community, we have a host of biologics that target these pathways. But what's very exciting in the cardiovascular disease is that we are now having targeted treatments for atherosclerosis. That includes canakinumab. That was the proof of concept trial for CANTOS. But more recently, it's been the release of the ZEUS trial, which is now testing the hypothesis of reducing cardiovascular risk with a monoclonal IL-6 inhibitor, ziltivekimab, which is currently enrolling right now and something I'm very excited to see about. And so I'm going to move on to case number 1, which is one of my patients who presented to the clinic after an abnormal stress test. She was 45 years old with rheumatoid arthritis. Here are her risk factors. She had Arrey. If somebody just can tell me if there's any issues here, I just making sure this phone call is not for that. She had moderate hypercholesterolemia. You can see right here, she was premenopausal. She had no hypertension, diabetes, smoking, or family history. Her medications were hydroxychloroquine and methotrexate. Here is her stress myocardial perfusion. I'm showing you here, and just in the sake of time, what I would like to point your area to, that if you look in the region, I'm not sure if I can use my pointer here, there was a medium-sized perfusion defect in the area of the mid-LAD territory. And she also had normal global systolic function. So she was then referred to my clinic for input and management. So let's talk a little bit about the rheumatologic history for her. She was diagnosed in 2017. She was started on hydroxychloroquine and methotrexate. She had active synovitis, and she was planned for anti-TNF therapy, and she was enrolled in a clinical trial that I've been working on with Dr. Liao, who's a rheumatologist at the Brigham called Lyra. And because you may ask, why was an asymptomatic even given a stress perfusion PET? These are pretty sophisticated advanced imaging modalities, and that's because she enrolled in this trial. And this is a study that's been ongoing for a number of years, which we've now finished recruitment, which was aimed at determining the effect of reducing inflammation on coronary microvascular function, myocardial injury, and lipids. We were enrolling patients that were about to start an anti-TNF as clinically indicated with moderate RA disease, and imaging them at baseline and then follow up at 6 months. So she had enrolled in this study and had an abnormal PET, which is how she ended up in my clinic. And that brings me to the concept of how we talk about coronary microvascular dysfunction and this idea of the coronary flow reserve that we get from a cardiac perfusion PET scan. And I really love this imaging modality because it truly is an integrative measurement that has the hemodynamic effects of both epicardial coronary disease, diffuse atherosclerosis, vessel remodeling, and microvascular dysfunction of myocardial tissue perfusion. This is just the equation. The way we do this with a perfusion PET scan is we vasodilate the arteries as if you as a stress test would, and we take the myocardial blood flow at peak hyperemia, and you divide that over the myocardial blood flow at rest, and that resulting ratio is your coronary flow reserve. This figure on the right is from my mentor, Dr. Carly. Multiple others have shown this relationship, but what this demonstrates is the relationship between coronary flow reserve and your maximum myocardial blood flow and coronary vascular outcomes. You can see here on the bottom left panel that patients with low coronary flow reserve, low peak blood flow, have the highest risk, and that as you go into the quadrants, you have a gradation of risk. And that is just one measurement of what cardiac perfusion PETs can give us. The reason I find this a very useful test in the cardio-rheumatology patients is that it gives us a lot of data. We can both look at epicardial disease. We both look at the LV function and volumes. Sometimes we don't have that information already. Then we get the myocardial blood flow, what I just walked through. And in addition, we always have non-gated coronary CT, so we can get the atherosclerotic burden, which is very important for initiation of cardiovascular prevention therapies. So going back to my patient that presented in clinic, remember this was a 45-year-old female with RA. These were her myocardial blood flows. And so you can see here that we show you per artery as well as the total myocardial blood flow, and a normal CFR value would be above 2. And you can see that she was quite low. And in addition, this is quite low for somebody at the young age of 45. And her peak myocardial blood flow was reduced 1.3 from a normal above 1.8. So what do we do in the clinic that day? Well, I initiated her on aspirin therapy and a high-dose statin. And she had these symptoms. She was attributing them to her rheumatoid arthritis, which is often in our patients, right? They blame their systemic inflammatory condition on their symptoms, and they don't think about sometimes the cardiovascular causes. But she did actually say she had chest discomfort with exercise. So we initiated a beta blocker, and I ordered a coronary CT to exclude high-risk epicardial disease, because if you remember back from her perfusion PET scan, she had that LAD defect. And so we wanted to make sure there was not a high-risk blockage there. And so here I'm showing here coronary CT. And what I'm showing here is representative images of what her data is. And what it showed is that she had a pretty diffuse amount of plaque. There was no severe stenosis. She had very minimal stenosis, in fact, but she had diffuse plaque, both calcified, but predominantly non-calcified, because remember, she's younger, in a multi-vessel distribution. So there was no high-risk epicardial lesion that would warrant intervention here. And this brings me to a new tool that I am like very excited about in terms of research that is up and coming, one that is utilized much more commonly in Europe called the Fat Attenuation Index. This has been developed by technology. This is a figure from Dr. Antonides. They have developed a group called Kuriya Diagnostics that's actually approved in Europe, where you can they have developed through this technology a risk score that incorporates the inflammatory index of the arteries to predict your future risk of cardiovascular disease. And the very brief pathophysiology of this is that when you have the inflamed artery, there's a release of cytokines, and that changes the aqueous content of the epicardial adipose tissue. And so what we look at with CTs is that shift in Hounsfield units. So it's a shift towards less negative in a higher inflammatory state. And through the Kuriya Diagnostics, they have developed this risk score called the CARI Heart. And this is a part of a research tool. This is not FDA approved yet in the United States, but this is my patient. Out of academic interest, I did get her data, and I'm what you can see here is they take the inflammatory index, that negative Hounsfield unit, and they plot this based on age and gender matched population. They have shown the prognostic importance of this risk score. And you can see that for her left circumflex, I'm just showing you her most inflamed artery, was the 80th percentile. So it's a very interesting research modality that we may be able to learn from in the future. But let's go back to our patient though. So we're always taking it back to her. So she's 45 and she was referred to me for a new diagnosis. Well, what were her traditional cardiovascular risk factors? She had a little bit of dyslipidemia, but otherwise she had no cardiovascular risk. So I plugged her in the standard ASCVD calculator that we utilize in the US, and she comes up 1.1%. We all recognize that as low. And here are our primary prevention guidelines in the US. And what I would like to point out was that the 2019 update, which was an exciting update, is they now released inflammatory diseases as a risk enhancer, that we can utilize this as a risk discussion for our patients with moderate risk, recognizing the notion that these risk calculators underestimate risk, something you've heard about today. But recognizing this is a key point, that these have become risk enhancers, our patient still would not have qualified because she had a 1.1% risk, right? So she's in that low risk category. So we still have work to do. And this is why we all appreciate these risk calculators and the limitations by them. So let's just summarize this case, as I have two cases. So we initiated her on those therapies, as I discussed, and the rheumatologist initiated her TNF therapy. I've been taking care of her now for about 4 years, and she's had persistent arthritis symptoms. And about 2 years ago, she has now switched to Rinvoq with an excellent control of her RA disease activity. Now, this could be a whole lecture in itself, but I wanted to spend one slide on JAK inhibitors and rheumatic diseases. And we're really at this challenge, cross point of a challenging situation where the release of the oral surveillance trial, which was actually a non-inferiority trial in rheumatoid arthritis that took patients greater than the age of 50 with one cardiovascular risk factor, and they were randomized to methotrexate and TNF or JAK inhibitor. And the results of this trial was that Xeljanz, tofacitinib, I always say that wrong, was not non-inferior for MACE and cancer. So there was the number needed to harm. And this has now led to the black box warning. But the rheumatology community on this audience knows that these are very effective treatments for many of our patients with inflammatory disease, particularly when they fail other treatments. And you can see here on the right, this is just the US data, but there's expanding indication of these drugs for multiple disease conditions. And so we still have more to learn, but it does raise the notion of how do we best manage these patients in 2023 with these limited data. A few important points we have learned from the oral surveillance trial is that when people have done post-hoc analysis, that this high-risk population, the baseline statin use was low, and that there was an abstract that was presented at EULAR last year, and that if you looked at the highest cardiovascular disease group, the patients who were on statins compared to those did not on statins had lower MACE incidence. So still recognizing of teasing out these patients in this, and this is just the hazard ratio shown here. So here are my learning points for case 1. I hope we all remember that the general population guidelines do not adequately capture risk in all of our patients. Is there a role for non-invasive imaging? This is an area of interest. I'm going to skip over this because I had to, I decreased this for the lack of time. And then so I cut off those slides. And then the recent evidence of the potential CV signal with JAK inhibitor raises a potential concern for the management of patients with known CV or at increased risk. So case number 2, this is a 46-year-old male with psoriatic arthritis who presented to the clinic after a STEMI. His disease began in his 30s. He didn't see a dermatologist and rheumatologist until his 40s. That's not uncommon. And he started a Premolast, which is a phosphodiesterase inhibitor. And then 2 years later, he presented with a STEMI. Here are his cardiovascular risk factors. He was an intermittent use smoker, maybe hyperlipidemia, is told that he never had it checked, and he was a little overweight. This was his lipids when he presented with the STEMI. And here is his coronary catheterization. I hope these images are working. This is the lesion that was shown here. There's an acute occlusion in the RCA, and this is showing you a beautiful revascularization. So the follow-up for this patient, he received 1 drug-eluting stent to his right coronary artery. He had an echocardiogram that showed LV function that was mildly reduced at EF of 45 to 50% with inferior hypokinesis. He was discharged on aspirin, ticagrelor, beta blocker, ACE inhibitor, and atorvastatin. He completed cardiac rehab, quit smoking, and he lost 30 pounds. Don't we wish all of our patients would do that after events? But he definitely had a great success rate. His psoriatic arthritis is now very well controlled with escalation to a TNF inhibitor. And you can see here that his LDL is 48 and his CRP is suppressed at 0.8 milligrams per deciliter. So psoriasis, a brief slide on this is that it is a chronic autoimmune inflammatory skin disease, which we are well aware with by now. It's common. In the US, it affects 2 to 3% of the population, and up to 30% have concurrent psoriatic arthritis. And we know this from many of others' work, including Dr. Lihi Eder's, that psoriasis is associated with an increased risk of cardiovascular disease and increased prevalence of cardiovascular risk factors. This is a very well-known study from Dr. Gelfand that was published in JAMA in 2006 that just highlights the notion of the increased risk of myocardial infarction in patients based on the severity of the disease. When you look at mild versus severe psoriasis, and it really hones in on this huge risk that's associated with psoriasis in the younger age groups. And you can see that as you get older, the concomitant cardiovascular comorbidities start to catch up with you. But again, you can still see this increased risk over time. And this is just a picture of the chronic psoriatic skin plaques we can see. But going back to the patient I presented to you, if you remember, he was young. And this is a statement out of the ACC/AHA guidelines on the primary prevention of cardiovascular disease for young that I really like to look at, because there's a statement in here that talks about patients who are under the age of 40. And what they say is that because of the young age of somebody under 40, these individuals would be very unlikely to ever exceed a 10-year risk threshold for which preventative drug therapy is recommended. So this raises a unique position we are in, for many of our patients with these conditions start out diseases when they're quite young. And we did look at this with one retrospective study at the Brigham. This is with my mentor, Dr. Blankstein, called the Partners Young MI Registry, which we looked at all patients under the age of 40 that had type 1 myocardial infarctions at the Partners, which includes Massachusetts General and as well as Brigham. And we identified patients with systemic inflammatory diseases, which included rheumatoid arthritis, psoriatic disease, and lupus. And we age and gender and risk factor matched those patients to their general cohort. And what we observed is that these patients had higher all-cause mortality when we matched them. This is just the log rank shown here. And so this does show you that we have much more to learn about what is driving this increased risk in these patients. We've also explored whether patients with psoriatic disease have an increased risk of microvascular dysfunction. This is data from a retrospective PET registry where we looked at the prevalence of microvascular dysfunction in psoriasis patients compared to age, gender, and risk factor match controls that presented to the Brigham for a cardiac perfusion PET. And what these data show you in the bottom left panel is you can see that the patients with psoriasis, they had a much higher frequency of coronary microvascular dysfunction. The CFR can be interchangeably used with MFR, which is myocardial flow reserve, just based on the clinical context. So this is the cutoff of 2 that I had introduced earlier. And you can see here of this elevated prevalence of 61% compared to 38%. And the panel on the B is just showing you the histograms of the absolute data here. But I mentioned in the beginning that coronary microvascular dysfunction is prognostic for the general population, but it was not established if it was prognostic for patients with inflammatory diseases. And this is an important question, because you can think about inflammatory diseases have increasing inflammation in disease valleys throughout their time course. So it wasn't clear that it would be equally prognostic. And so we did look at this, as well as another group from Yale, from first author Dr. Faher, and these were published at similar time points that we had both had similar findings, of which when we looked in our PET registries at patients with inflammatory disease, and we looked at the relationship between the coronary flow reserve and all-cause mortality, what we observed is that these patients with lower coronary flow reserve, they are associated with worse long-term outcomes. We also observed increased MACE. I'm only showing you the mortality here. And you can see here that in the Brigham cohort, we looked at both RA, psoriatic disease, and lupus. And in the group from Yale, they expanded to also include Sjogren's disease and systemic sclerosis. But the findings is that this is a prognostic marker for these patients of coronary microvascular dysfunction. And so here are the learning points of case 2. Psoriatic arthritis is a systemic inflammatory disorder that is associated with increased cardiovascular risk. We have increasing data. There's an increasing prevalence of coronary vascular risk factors. There's an increased prevalence of coronary microvascular dysfunction, which is associated with worse all-cause mortality and MACE. And cardiac prevention counseling should start early, and it should address the modifiable risk factors and lifestyle interventions. And I'd like to raise the food for thought for this audience. Could the use of imaging modalities early among asymptomatic patients help identify patients at the highest risk? And do anti-inflammatory therapies modify this risk? And if so, are there differences between the different biologic pathways and agents? And this is just one food for thought question, and highlighting a study of which we're trying to answer this in a small way at our institution, is specifically asking, is there a link in psoriatic disease between the role of Th17-mediated inflammation and cardiovascular disease? We know that for the psoriatic disease pathogenesis, that this is a key inflammatory pathway that is targeted by both anti-IL-17, anti-IL-23, and anti-IL-12-23, that is both dramatically effective at decreasing psoriasis as well as psoriatic arthritis. But it raises the question of whether there's the link between the cardiovascular system. There is small amounts of data of the role of Th17. And one way we are looking at this, which is a mechanistic study, where we're using imaging to try to understand the relationship between blocking this specific pathway to really try to get at that question, is it pathway specific versus inflammation specific? And we're doing this by 2 different studies, where we're bringing in patients where they're about to start either tildrakizumab for psoriasis or any of the Th17 agents for both psoriatic arthritis patients. And we're doing clinical assessment, labs, and imaging with both PET, as well as with one study, we're adding in coronary CT, and then they start their anti-inflammatory drug, and then we image them again at 6 months. And we're hoping to understand whether there's any relationship between starting these biologics and reducing these endpoints of coronary microvascular dysfunction as measured by the CFR, as well as looking at the coronary CT for that fat attenuation index that I mentioned earlier. And so these are some food for thoughts. These are patients that I take care of in my clinic, and really raises the question of what could we be doing now in 2023? Case number 1, how could we have avoided the development and the progression of a coronary artery disease? She presented to me because she came from a clinical trial that we found this disease. Case number 2, this patient came to clinic after they presented with a STEMI at the young age. Could we have prevented that? And this is why we all know on this conference that we still have a lot of work to do. And that's why these collaborations are so exciting. And what I believe is that it is impossible now for a rheumatologist, dermatologist to address everything in these short clinic visits we get. And so that is the need for these multidisciplinary care models. We need early recognition of cardiovascular risk. That includes weight loss, lipid management, blood pressure management, lifestyle, hence the need for collaborative care between all of us together. I still think we have a lot to do to advance the field of cardio-rheumatology, and these are just a few building blocks of things that I hope we can continue to see more work on in the future, including disease-specific cardiovascular risk assessment, how we think about these different anti-inflammatory therapies, the role of multimodality imaging, building this community as we are here by this conference today. Patient awareness and education is so, so important. Every week I meet a new patient that just did not know that their inflammatory condition was, had these risks associated, and then clarifying the role of our cardioprotection therapies. It is a growing field. We are still in its infancy in the United States, far behind the European countries as well as the Canadian countries. But you can see here is I'm excited that it is at least becoming recognized a little bit more. There are at least a few clinics across the US, as shown here by this recent Medscape article. And I'd just like to end here, and I'd like to thank all of the people who make the work we do possible at the Brigham, including my mentors, Marcelo DeCarli, and the Rheumatology and Dermatology Department, Catherine Liao and Joe Marola, as well as collaborators at outside institutions and members of my lab and my current funding. And so again, thank you all for this opportunity to talk today.
Thank you so much, Brittany. That was great and seamless, no technical issues. So I think you can relax. Great images, and I have lots of questions. We have time for a panel discussion. I'll invite all the speakers to join us and the audience to, there are quite a lot of questions in the chat already, and before we get into there are lots of questions about antimalarials and cardiomyopathy and cardio-rheumatology, but I want to go back first to the exercise and physiotherapy and to pose a question to you, Lauren and Angelo. You mentioned, Angelo, that some patients of us that have seen physiotherapists receive the wrong treatments from physiotherapy perspective. And I wonder, how important is it, do you think, that we refer patients to physiotherapists that are experienced in managing patients with arthritis, or should we just kind of refer them to whatever program is available? Because, obviously we cannot supervise what specialists are recommending, and then there are some important considerations in people with joint problems.
Thanks for that question, Lihi. I think it's important first to remember the two different forms. There's the exercise and the therapeutic exercise that requires physiotherapists. I think just from the start, you need to get them started on any fitness program. I think a lot of these patients, we're just trying to move the needle. We're just trying to get them to be active, trying to demonstrate that exercise is not contraindicated in this condition, and to try to change that behavior. But I think when it comes to the sort of little nuances of, they've done a little bit of a program, they've moved on to, and they have specific questions, for example, going back into pickleball or golf or something else like that. I think that's where you require expertise to make sure, A, that it's safe, that you're doing the right type of exercise therapies, adding other modalities that might be beneficial. So I don't think you need physiotherapy to start per se, unless you have them in the clinic. But I think every patient that comes through the clinic needs some form of exercise, because 80% of the people that come through our clinic, whether it's OA clinic, the AS clinic, or the early inflammatory arthritis clinic, are not even meeting any part or even close to any of the fitness guidelines. So I think there's enough material out there to get them started on general exercise, 3 to 4 months, and then go to a clinician that's experienced. Because as you can see with the first case that I did, having a bad experience with a clinician and a negative connotation can skew their perception of future therapies or future interventions, whether it's weight loss, whether it's behavior modification, smoking cessation, it kind of turns them off. So I think being a collaborative team, but to start, just send them off and get them walking. But again, start really low. Make sure it's a win for a patient at all times.
Can I add to that, Lihi? I think your question also, there's recognizing that there's a lot of low value care, and that's not, when we send someone to a rehabilitation specialist, we're not wanting them to get a therapeutic ultrasound for their osteoarthritis, as an example. We want them to work on a general conditioning program. So, you know, in a perfect world, we all have interdisciplinary care teams, and we work together, and we know, you know, what the evidence-based care is, and we can put it into practice. That's not always the case, and we have especially issues in Canada in terms of lack of universal funding for rehabilitation services that challenges that. One of the things that we can do as health professionals, or if I'm writing a prescription, irrespective of the type of arthritis, is I will write a prescription for physical therapy, but to for, you know, assessment and development of a graded exercise program with titration as tolerated, and I put that there, and I also educate patients around this is what the purpose of physical therapy is. You know, you're going to have to, it's good for this to make a difference for your arthritis. It will be active. You will be playing an important role here. This is what we're looking for, and that's what I'll check in about too. So, you know, there's not a perfect solution to ensure that we get the high value care, but there are things that we can do to, you know, try our best.
Thank you. And well, I guess I see quite a lot of questions on cardio-rheumatology, and I want to have a chance to discuss this perspective. So I think general question, because this is a question that I get, you know, we as rheumatologists, we cannot handle everything, and I think it's very hard. You've shown it in both of your studies that there are significant gaps in care. So how could we improve that? Like, where do you see the role of cardio-rheumatology clinics? Is it for primary prevention? Is it for management of complex cases? Is it for research? Who should be referred to these kind of programs? So Anne and Brittany and Paula, I would appreciate your opinions.
Well, thanks for that important question. Well, yes, in our hands, it's both, actually. So anyone can refer patients to me for cardiovascular risk evaluation, either if they have a cardiovascular event or not, if they have high risk. Any doctor, any nurse, I see everyone. I only have 2 clinical days a week, the rest is for research. So there is a little waiting list, but it's important, I think. Coming to what I do, we have coronary CT angiography and MR in our hospital, but not not PETs and any of the other advanced. So for very complex cases, I would refer them to another hospital. But I think most importantly, what rheumatologists can do is just to ask them, do you have cardiovascular disease in your family prematurely, or do you have it? Do you smoke? But you always have a smoking status, I reckon, and you always have heightened weight, and you have age. So the things which is lacking is lipids and blood pressure to do a very simple cardiovascular risk evaluation. And if patients have a risk factor or think or suspect they have a risk factor, you should refer them to cardiovascular risk evaluation in a cardio-rheuma preventive clinic, I think. So Euler recommends that it's the responsibility of the rheumatologist to have that the cardiovascular risk evaluation is performed, not that they should perform it, but to refer so they have it done. Right? Was that okay?
Thank you. Yes, I think that's. I think they're placing the replacement on the management or the screening on the rheumatologist alone. I personally think it should be collaborative care, but yeah, I think definitely interesting thoughts. Brittany, do you have any thoughts about?
Yeah, No, thank you. And I definitely agree with Anne, is that it really is everything, right? I think at the core of cardio-rheumatology is always prevention, right? We are always trying to prevent, but we see everything, because you saw from just this host of talks today, there's a whole host of cardiovascular manifestations. And just next week, with all the add-ons that I have, I mean, it ranges from prevention on patients with JAK inhibitors for cardiovascular risk to myocarditis. And so people can refer to my clinic for any reason. Recurrent pericarditis, both within, patients with lupus, is a growing niche now, at least in my clinic, with the increasing use of IL-1 inhibitors. And so similar to Anne, that it is a busy clinic because of all these manifestations, but I still think today it really does include everything. And also there's a growing need for the cardiovascular specialist to understand, right, to have a knowledge of these diverse manifestations and how these different biologics affect that risk. But we certainly still have a lot of work to do.
Thank you. Paula, any thoughts on that topic?
Well, I think all of us here today have the privilege of being in an academic urban environment.
Yeah.
And we have to be realistic about where most of the patients are actually residing, and what their lifestyles are like. And I do think we need to be doing two things. We need to, certainly in Canada, we should be leveraging the family docs. I know it's a different model, Brittany, in the US, but for us, we need to keep the family doc, I think, at the hub. And maybe we can leverage electronic patient records that cause us so much angst and administrative burden in one way, but actually leverage them in a way that, by educating the patient, having some smart phrases in the letter to the family doc, that can then be followed up with the patient advocating, because there's no way, I mean, we're talking about everything from scleroderma we've talked about today, and lupus, through to osteoarthritis, and you think about the percentage of the population that we're trying to cover. So I think that education and the advocacy and the utilization of the family doc is critical. What the magic elixir is to be able to do that, I don't know, but the rheumatologists and cardiologists there's just too much complex care that we're trying to do. Rheumatology is getting more and more complicated, and what we're doing in our field is, as Brittany just said, is getting more and more complicated as well. So that's what I think we need to be working on, and I know that's one of the aims of the cardio-rheum programs.
Thank you. There is a question in the chat about mechanisms from Dr. Witz, and I think this is an important question because, it's fascinating to see, like, initially we thought that, okay, we just suppress inflammation and everything will, like, all the cardiovascular diseases will improve, and then came the oral surveillance with the JAK inhibitors, and we learned that may not be the case, that maybe some biologics work differently. So I wonder, what are your thoughts about some of the mechanisms that might contribute to these findings on JAK inhibitors? And in particular, what is your approach when you face patients? Because from my perspective as a rheumatologist, the moment I mentioned heart attack as a safety issue, then the patient said, "Oh, I don't want that." So, but it is a challenge in patients who failed multiple biologics, and the JAK inhibitor could really improve their outcomes. So, what are your thoughts about the JAK inhibitor mechanisms?
Yeah, this is such a good question, and I really would love to hear Anne and Paula's thoughts on this too. This is something that I struggle with every week, because I'm getting increasingly referrals every week from the rheumatologists whose patients have been many times they've been on JAK inhibitors before the results of this trial came out. Sometimes it's a patient who's got a lot of cardiovascular risk, but they really need to start that drug. And it is really challenging because we're stuck with, what we have at hand right now, the data we have at hand, and we can only tease it apart as much as we can, but it really speaks. So we have to understand mechanistically about what is different about the JAKs, which can have off-target effects, and how is that different, for instance, in IL-6 in terms of that atherosclerotic environment. I don't know the answer to that, and I think we're going to have to. The only way to do this in patients with inflammatory disease, because we can't do CANTOS and CERT in these big trials, is that we have to do more mechanistic studies. That's why I think one solution is that we could utilize imaging as these surrogate endpoints with, in the lab, more data to understand this. But today, I will say that what I do is I do everything I can for risk stratification. So I try to understand all the standard cardiovascular risk factors we check today, get them on therapy if appropriate, and I often utilize imaging. I actually have one rheumatologist at the Brigham, a very senior rheumatologist, who is so worried about this warning that he's actually been quite great at actually he'll order, because I gave a talk recently, and he'll order calcium artery scoring, and then he'll kind of refer based on that score, which is sometimes always helpful to have that data point, because sometimes I use those in my risk assessment. But I think it's a really big challenge. I have found, for instance, one patient with a lot of cardiovascular plaque and a lot of risk factors on Rinvoq, and ultimately it's the rheumatologist who's treating these patients, and that patient had not been on Tosi yet, so we switched the patient over to Tosi. Many times the patient has no other option, so all we can do is optimize everything we can cardiovascularly, and we're at this kind of like, how do we weigh it? Because we know we don't want that patient to be inflamed. We know that risk is high, so it's like, how do we balance this?
And any thoughts about JAKs and cardiovascular diseases, how to manage these patients?
I think, thank you, Brittany. It's a very good answer. And I have some other views. I think that the Orales, that this study with the TNF-alpha inhibitor and JAK inhibitor, I think is inclusive, because they compare each other, but they don't have a control group. So it's really inconclusive. And when you see a patient with on a JAK inhibitor having a loss of coronary atherosclerosis, so what's the hen and what's the egg? The patient, atherosclerosis takes years to develop, and it's not the result of 1 or 2 year JAK inhibitor treatment. Right. So I'm really concerned about this. I think this is we have one RCT which is non-inferior and inconclusive, and also we know inflammation is one of the most important driving risk factors for advanced atherosclerosis or atherogenesis, and dampening the inflammation is probably the most important thing. So if TNF-alpha inhibitors or other biologic EMRs or JAK inhibitors increase the lipid levels, I don't think that has anything to do with it. Really not at all. Get them on statins. That's or lipid lowering therapy. Get it down, and they will have a higher CAC, because statins will produce harder plaques with more calcium, higher CAC, and reduce the risk of rupture of atherosclerotic plaques, which gives a myocardial infarction or an ischemic stroke. So there are, it's difficult. It's very difficult.
It is difficult. We need more research.
I definitely agree, and I will say I saw that chat from Dr. Gladman that I completely agree. The results are certainly still inconclusive, and it could just, that's a very good point about the increasing protective effect. And in fact, the meta-analysis, we all probably know this, have not shown this increased risk across the studies. Oral surveillance is obviously the largest one, but it's an important point here, that the TNF protective effect.
Thank you. I wanted to just, I guess, ask you one last question, because we're running out of time, and I think we could spend a few more hours discussing these topics. It's about NSAIDs. I think it is an important question, because our patients are unique in the fact that they do need NSAIDs to function and to be able to exercise and to have a better quality of life. So what do we do with the high-risk patients? How should we counsel them? Especially, in the context of increased cardiovascular morbidity, hypertension, and so on.
Did you want me to answer that?
Go ahead, please.
Okay. Well, hypertension is the primary drug of choice is an ARB, for example, in Norway or in Europe today. And if you use ARB and NSAIDs, you affect both the afferent arterioles of the kidney. So that's very, very you should do that with caution. So what's been shown that NSAIDs, of the NSAIDs, naproxen is the least damaging, not to the kidneys, but for the risk of future myocardial infarction. This is by both a U.S. study and a Danish nationwide study. I would say that NSAID should be used at the lowest effective dose, the shortest possible time. And then hypertension is very, very important and should be treated, as good as you can, optimally. Okay.
Thank you. I think we, due to the interest of time, we do have to end here. I really wanted to thank all of you. I know it's very late in Europe now, so thank you for joining us. Thank you, Brittany and Angelo and Lauren and Paula for co-moderating with me. I wanted to thank the audience, wherever you are, for attending this symposium. I also wanted to mention the Kit Colasso, who really organized all of this event, and thank you for his support. Thank you for the sponsors and for the IT support that we received. And I wish you all a great weekend. Thank you.